right eye, the PED went down to around 1/3 the size of what it was before. And if you talk to any of the colleagues who are actually using BOVs, we see these collateral effects pretty commonly these days. My last case, especially the left eye, is just to demonstrate how potent this injection can be. This is actually a treated DME, really a flattened macula, but single shot of BOV was good enough to flatten the fovea. Obviously, the patient required further follow-up injections to treat the extrafoveal region, but this is what our patients want. They want us to give them a miracle drug. Give them one shot and they should start seeing better. They come to you and keep asking for exactly what is the OCT showing, how much is my central foveal thickness and how much has come down. So this injection can actually really reinforce the kind of confidence you have and transmit it to the patients. To conclude, as I already said, that's my opinion that BOV actually ticks most of the boxes of recent anti-VEGFs. And I conclude. Thank you.
Thank you, Dr. Mandeep, for the excellent presentation. It was very informative. Probably we can keep the sessions at the questions at the end of the session, because I think we both have almost quite similar topics. So we'll do the question answer session after my presentation.
So, ladies and gentlemen, let me introduce my colleague, Dr. Vasu Kumar. He's the head of the department of NMC Hospital at DIP, an excellent retina surgeon, practices retina, uvea, and medical retina. Vasu, all yours.
Thank you. A very good afternoon to everyone. Thank you, Novartis, for organizing this session. So I'll be going ahead with recent updates in safety data in DME and AMD for BOVU. So as we know, improving diabetic DME management, basically any treatment we do should tick multiple boxes, including we want functional results, anatomical results, and also we want the with minimum number of injections or treatment. So Dr. Mandeep already spoke a lot about Kite and Kestrel study and how they concluded that BOVU proved to be non-inferior to aflibercept in terms of its anatomical and functional outcomes. Over that, there were further Kingfisher study which did a head-on-head trial with monthly brolucizumab and aflibercept injection. So just to make sure, this was a head-on trial with monthly injections for both the molecules, and it also concluded the same thing in terms of both anatomical and functional outcomes, as well as the safety profile. In specifically, this study was almost similar in both the arms. If you see this in the right, brolucizumab arm and aflibercept, if you see the number of patients in brolucizumab is almost double of aflibercept. So if you compare both, the incidence of IOI, retinal vasculitis, as well as vascular occlusion was almost similar in both the groups. So saying that the safety profile is almost similar in both. Another study with comparative efficacy of brolucizumab in neovascular AMD, it was a meta-analysis, one of the best, I would say, literature reviews. It included almost 19 studies, analysis, and 19 randomized controlled trials. And what it concluded was similar, that BOVU had superior reduction in retinal thickness with comparable visual acuity outcomes and with lowest injection frequency. Going on to the next study, these are the NICE recommendations for brolucizumab for use in DME. And this committee made similar recommendations that treatment of AMD, the usual treatment is usually aflibercept and ranibizumab, and the clinical trial evidence provides similar overall health benefits as the other drugs with similar safety profile, and the total cost are same or less than as compared to aflibercept and ranibizumab. So this committee was aware of the summary of product as well as the reported adverse events, but it concluded that the adverse events with brolucizumab were likely to be similar to the previous two generation of molecules. Just another post-marketing analysis of vasculitis and retinal vascular occlusion with BOVU results were almost similar, that over the period of last 2-3 years, the incidence of retinal vasculitis as well as occlusions have reduced over time from initial 7.5 events in 10,000 injections to almost now 5.5 events in 10,000 injections. So that accounts to almost 0.05% chances of inflammation. This is just a diagrammatic representation of the reduction in the further reduction in the incidences of the IOIs as well as vasculitis. So going on to my personal experience, this was first patient, 65-year-old male, type 2 diabetic since 10 years, presented with decreased vision in both eyes, had received Lucentis in the left eye 2 years back. So basically he was on irregular treatment because of probably some financial issues. He came to me, vision in the right eye was 6/60 and left eye was 6/18. It was a case of neovascular AMD. So right eye was the chronic eye, and the left eye was the recently presented eye, which was 6/18 in vision. This patient was started on aflibercept. He responded well on it. The subretinal fluid resolved. The CNVM tissue regressed. Subsequently, the patient requested for trial and treatment in the right eye. So right eye, as it was a chronic eye, and that time BOVU is a recently introduced molecule, so we tried giving one shot of BOVU in this chronic eye. So we gave one shot on 25th November 2020. This was after a single injection, the macula completely dried up. In the meantime, the patient, so while all this time we gave just one shot of injection, the vision did not improve much, but anatomically the patient improved a lot. Left eye recurred while on aflibercept. So while the patient, the left eye further, again the vision reduced as we were on treat and extend regime in the left eye. So subsequently the patient also wanted that, okay doctor, and in the meantime the right eye, it had been almost 4 months on a single dose of BOVU and it had not recurred. So we thought of giving the same in the left eye. The patient received one injection on 2021 January. So right eye was still fluid free, and the left eye also did well. Vision improved to 6/6. And if you see, the very important thing is that if you see the RP, initial pre-injection and post-injection, the RP is absolutely flattened out post BOVU injection. So this is reported by many other surgeons that after BOVU injection, the anatomical outcomes are really amazing, especially in cases of AMD. So and the right eye dry even after 4 months of first dose, and left eye doing well on the same molecule. So this above patient had been maintaining well on 3-monthly regime on BOVU without a loading dose. So straight away started on BOVU after aflibercept and had been maintaining well on that. Second case, 76-year-old male, no systemic illness. Left eye had a disciform scar. At that time, right eye was fine. After some time, the right eye also developed a neovascular membrane. He was started on aflibercept. So this patient was off and on the molecule for a long time. So approximately over a period of 2.5 years, he had almost received 18 injections of aflibercept. And the post 6 weeks, the fluid used to come back. Subsequently, now this was the one-eyed patient. I had to be very, very sure about what I'm giving to this patient. So by that time, I had some experience with brolucizumab. Shifted to the patient on BOVU, first dose, second dose, third dose. The macula was absolutely dry. So after that, straight away after the loading dose, I usually give a loading dose of 3 injections. After the third dose, straight away the patient was shifted onto a 3-monthly dosing regime. After that, after second 2 doses, we again further extended the dosing period to almost 4 months. And last I had seen the patient 8 months back. After that, he hasn't presented to me. So basically, this molecule did very well for this patient. He was one-eyed, but did very well, no inflammation altogether in his eye. Another case, 48-year-old male, type 2 diabetic, best corrected vision in left eye, 6/12. Well controlled, presented with this kind of an anatomy in the macula. Vision was 6/12, 1 week post-injection, vision 6.6. If you see the amount of drying effect, the macular thickness reduced from almost 600 micron to coming on to 300, 350 micron within a week of injection. Fourth case, 55-year-old male, type 2 diabetic, hypertensive, best corrected visual acuity in the left eye, 636, well-controlled, pseudophakic. Now this was a different case. It had received 3 injections of Ozurdex in the eye over past 1 year. This was the fluorescein angiography report. He had significant peripheral avascular retina, which received a PRP laser, as well as he received Ozurdex injection in this eye. So, so he then received the 4th Ozurdex injection. So if you see the report, 1 month post Ozurdex, his vision improved to 6/18. But surprisingly, by the 2nd month, he came with drop in vision with an increase or recurrence in the edema. So this was a patient who became quite resistant to Ozurdex. Given a single dose of brolucizumab, the macula completely dried up. 5th case, a 62-year-old male, type 2 diabetic, hypertensive. He had a coronary artery disease, best corrected vision in the left eye of 6/18. Right eye was neovascular glaucoma, absolute state, so he was also one-eyed patient. Received laser and intravitreal injections, both eyes elsewhere. Was well controlled, kidney functions were normal. Presented with macular edema with a macular thickness of almost 650 microns. Gave 1 aflibercept for macular thickness reduced from 576 to 550. Vision did not improve much. 2nd dose of aflibercept given. So the 1 month post-injection, the central macular thickness reduced to 521. So this was a one-eyed patient who was having a lot of difficulty in his vision, was unable to pursue his work. So after 2nd dose, he was also tired of previous multiple injections. This was also not working well. So 3rd injection, I gave him brolucizumab, and 1 week post-injection, if you see the macular thickness reduced to almost 431 microns. So they had a significant reduction in the anatomy, as well as the vision also improved. So this was a recently done patient. So he did well on brolucizumab as well. So these were some of the cases which I had. So basically, brolucizumab has worked well in my hands, and as Dr. Mandeep said, that probably in the last, this molecule has been there since last almost 3 years, initially approved for AMD and now for DME. It has worked well, and I think in UAE by now we have, there are almost total 5,000 injections which have been given, 2,000 in the last year, and they have been a very countable few number of reports of just minor IOIs, but no significant reports of any severe intraocular inflammation post-injection. Thank you so much.
Excellent cases, Dr. Basu. I'll just skip the gun. I think the only thing which holds back some of our colleagues in using BioView is IOIs.
True.
All of us believe that this is the best molecule when it comes to efficacy, durability, on all the aspects. So you have quite substantial amount of experience of using this drug. Did you ever face any such size-threatening complications or?
No, Dr. Mandi, I have never had any severe IOI. I had only 1 patient presenting with anterior chamber cells, mild redness post-injection in all these more than 100 cases, which was managed with just topical steroid respondent within 3-4 days, and that's it. I never had and basically I've been using this molecule since almost 3 years now, not a single case till now.
And do you modify your follow-up protocol for the patients
so
when you use BioView in comparison with other anti-VEGF?
So as with any other newer treatment, initially when I started, I used to see my patient next day, after a week, after a month, but probably I think after giving a few injections, I mean, probably after, so it's been quite some time now, I follow the same protocol as I follow with any other anti-VEGF agent. I call the patient straight away after a month of the injection. And
Thank you.
I would like to ask you, how has been your response with the injection? And as I saw, you did mention regarding the loading dose that you have modified the protocol for your treating patients. So would you kind of elaborate on that? That do you follow the same loading dose as 5 injections, or you kind of modify that with these newer molecules?
So I presume you're talking about DME.
Okay.
So DME, yeah, I inject every 6 weeks till the macula flattens out, or 5 injections, which one is earlier.
Okay.
And I've not had a patient who had to be injected 5 injections 6 weekly yet so far. But this data is quite contradictory to what you see in kite and crystal, because probably my patient profile is little different, younger, active individuals. I don't have a lot of Caucasians. So if you see crystal and kite and you compare them, the results were better in kite. Probably it's a racial thing where the response is better in Asian population and Middle Eastern population. So I was myself analyzing it. I could see you know, a discrepancy between the two datas, but that is the only thing I can come up with. My patients have been younger also. My average age was around 56.
Oh, so yeah, actually true. In UAE, actually we are having, and probably in the next decade, the number of diabetics as well as the diabetic retinopathy patients are going to increase. And I think I have a similar experience as you also mentioned, that all the studies, actually the concept of loading dose came from the first generation molecules like bevacizumab, where with a single injection, we never used to have a full response, and we had to give 3 or then subsequently study 5 injections to make the retina flat. But in my personal experience, I have had a very good chunk of patients. So I personally am not, with these newer, I would say these are the third generation molecules, which are packed with more number of molecules per amount of dose. And I'm not that much in a favor of loading dose. I usually tell the patient, like as once the retina dries up, we will start on either PR. Usually diabetic retinopathy, I don't do treat and extend. I also, as you said, I do a PRN basis. So many times we have patients, a good chunk of patients with just one injection, they flatten out, and then straight away after the first injection, I start them on PRN basis of treatment, and they do quite well.
Excellent. So any questions? Yes, Dr. Mitra.
Yeah, I just wanted to ask you, if you look into the pharmacology of these two drugs, Eylea and Bevu, what is so amazingly different between these two that the pictures which you showed, the response is so different?
So actually, Beovu, if you see the molecular size, if we compare bevacizumab or ranibizumab to first going to aflibercept Eylea, so Eylea packs almost 13 times more molecule than Lucentis. If we talk about Beovu, which is just a portion of the FAB fragment, so that packs another almost 12 times more molecule as compared to aflibercept. So that's why I call these the third generation molecules. So in the single amount of dose of 0.05 ml which we inject, the amount of molecules which brolucizumab has almost 12 times as compared to aflibercept, apart from the molecule itself. So a similar response we saw when aflibercept came into the market compared to ranibizumab. So that is what I can explain, what I think gives much better results, and that's why we have been able to. I have been able to come out. I believe a lot of people are here are in private practice, and giving 5 loading dose many times does not, it's not possible many times. So with these molecules, what I've noted that I am able to, many times I don't give 3 doses, it's just 1 or 2 injections, and it dries up the macula fast, and then straight away in DME, we can shift on to PRN regime, while AMD I do, in AMD also I do 3 loading dose, I usually don't go for more than that.
And there is any of you had any experience with Bevu in young AMD, or not classical AMD? Because I saw a patient of young AMD who was been injected Bevu and presented with granulomatous uveitis. I don't know whether it's very common or very rare to have mutton fat KPs, granulomatous uveitis post Bevu.
So I have 2 patients, one myopic CNVM and another is idiopathic CNVM. Both young patients who have been, the myopic CNVM has been on Beovu since almost, I would say, another 6-8 months now. No reaction altogether. None of the patients have had any reaction per se. Uh, so no experience.
We have been using them in CSRs with CNVs. So this is generally a younger population as well. So responses have been fantastic. Once you see CNV, you can switch to BUU straight away.
Thank you, and excellent
Thank you.
presentation.
Thank you.
Any other questions from any colleagues?
Yeah.
Because you have not taken the loading doses.
Yeah, so basically, yeah, that's true. So what I've noticed that the amount of injections, what I have given in personally, like now it's been 3 years, has significantly reduced, and this effect continues even in the second year. So as we said, the concept of loading dose came during the bevacizumab time where the macula did not dry up initially after the injections. But with these injections, what we have noticed that the effect still continues by the second year. So after the initial, once the macula becomes flat, we straight away many times I inject the patient. I need to inject maybe after 3 or 4 months. And so maybe in a year, I give max 3 or 4 injections through a good chunk of patients, and that effect continues by the year 2 also.
I think it's a very interesting question actually. So 7 were the total number of injections required in first year average. I mean, I'm just quoting Kite and Crystal. And second year required 4 injections. So 11 in total in 2 years. But if you're saying that what would be the response in second year following no loading dose pattern, it's not been studied, to be very honest with you. So all the studies are designated the RCTs with loading doses only. And that is what Dr. Vasu was saying, that newer molecules actually don't need to have that kind of loading dose. And that's exactly what my presentation also said, that if none of the patients required to have all 5 loading doses, then why do we inject? Why don't we just move to PRN straight away? So we are still using the protocols of Lucentis and earlier injections and trying to treat with new molecules.
Any cases of retinal vasculitis in the second year after giving BOV?
No. So, one of the second patient which I presented was the one-eyed patient that had been on the injection since 2021. No, I have never had. So basically, I have experience since almost 3 years, and these 3 years never had any incidents of vasculitis in them. Probably the same would be with Dr. Mandeep.
I think
Thank you.
I will
Thank
conclude. We are already out of time. So thank you, Vasu, once again. Thanks, Maram, Karthik, and the Novartis team. Thank you all for staying back.
Thank you.
Thank you.
Good afternoon, everybody. Let me welcome you again in the 5th MEOM meeting, and I hope it will be a very good and fruitful session. I'm glad to be the moderator for this session. I'm honored, and I have my panelists, Dr. Susanna Texiera, Dr. Mangat Dogra, and Dr. Osama Mahmoud. So we have eminent speakers today, and I will be probably the first speaker, though I should be the last. But again, the program was put, by Dr. Muhammad Al-Amri, and he arranged everything. I couldn't change anything, though I'm one of the organizers. So again, I will be the first speaker, and I will start my first talk. Thank you. Can I have the first talk, please? So I know today we have many imaging things going on, one now, one at 5 o'clock, but my talk today is about updating ocular imaging, and I'm going to speak quickly about the ultra-wide field imaging in real-life practice, how we use it, how we get benefit of it. We used to know about ultra-wide field, what is the definition? So there was no definition for what's wide, what's ultra-wide, what we need to know about the periphery of the retina, until this classification and guidelines of the wide field imaging came, and there has been inconsistent terminology, as I said, but after the international panel of world leading experts gathered together and put definition of what's central field, wide field, ultra-wide field, what's the center, and what's the periphery, and this picture shows you exactly what we mean by the posterior pole from the disc to the arcades, and then mid-periphery, and then wider field, which means that we can see up to the ampulla, and after that, it's ultra-wide field. So we need the center, the periphery, the far periphery, and the extreme periphery after the ora serrata. Nothing up till now can get 360 degree, but I think in the future it will be. So let me revise quickly what's going on in the wide field. We used to have 15 degree in the 80s, and after that 35 degree in fluorescent color, and then the 50 degree is the standard up till now with most of the cameras, 50 or 55 degrees. And then why we needed the periphery? Because sometimes you look at the center, it's free, and the patient is complaining, and you look at the periphery and you find out this picture, one of my patients, that's 1987, he was complaining of, floaters, and I found this at the periphery. So again, ultra-wide field now is very important because you get one picture showing everything from the disc to the extreme periphery. Like giant retinal tears, getting the picture of giant retinal tear in one picture. This is one of my patients who had a giant tear in one eye, and he came complaining of flashes of floater in the left eye, and look at the two large breaks, but at the extreme retinal periphery. And it was very helpful for me to do laser for him and then picture him after that. And otherwise, I would have spent a long, long time examining the retinal periphery. Again, look at this. I didn't put a title for this because sometimes you find the patient is complaining and you never know why. In this ultra-wide field, you can see the bubbles. This is of the repeated injection. This is silicone bubbles from repeated intravitreal anti-VEGF injections. Most of the patient comes every now and then complaining, and you can catch this large bubble in there. Sometimes you have a patient who had a retrobulbar and he's complaining of floaters, and you find that he had a needle break at the retinal periphery. Again, if you lose the lens, you need to see where is the lens, where is the detachment, and again, ultra-wide field is very helpful. In uveitis and inflammatory disorders, we can see the acute retinal necrosis with extreme retinal atrophy at the periphery. And again, von Hippel-Lindau disease, and you can see the feeding vessels. This is very important, and sometimes in children, even now without general anesthesia, you can put them on the optos and you can get the periphery, and after the laser photocoagulation, you can document that. So this is what we mean by ultra-wide field, viewing up to the vortex or ampulla or beyond, and this is one of the ICG pictures, which is very magnificent to see every vessels, retina and choroidal vessels. So in real-life practice, why we need wide field? Because we have to look in diabetic patients, sometimes the center is quite good enough. You have neovascularization, you have focal laser, but the ultra-wide field is very important because you can see the extent of retinal ischemia. That's why the macular edema is recurrent every now and then. Wide field in OCT, we started by 6x6 in old days, then came 9x9, and came 12x12. And the more we have wider field, the more we can detect the vitreous. So this is vitreous cases, 3 layers. If you are going to operate in one of these patients, you should know what's going on. And this is a 16 millimeter OCT, the maximum any machine can get now. You can see the vitreous clearly, you can see the retina, you can see the choroid and beyond. So it's very important to have all the lesions in one picture, and this is one of the wide field lesions. You can see not only traction on the macula, but he has a nasal traction, and this is proliferative diabetic retinopathy. Look how the wide field can show you the posterior staphyloma and the peripapillary staphyloma. So this is very good to document this before you start treating any patient, and you can see the posterior staphyloma, but the peripapillary staphyloma is very evident in here. How about OCTA? There was evolution OCTA. We started by 3 by 3, we have 9 by 9, and then we have 12 by 12. One picture like this can give you a very good information, but you still need the extreme periphery. So does it have a role in clinical practice, the wide field or the ultra wide field? Definitely yes. So this is the 9 field standard, the old ones, and we nowadays can change the classification. Like this is a patient of diabetic retinopathy. If you look at this, yes, there is IRMA, there is ischemia, but again, it's non-proliferative. But if you get a wide field, there is proliferation. So again, periphery is very important, and if you can get it in one picture, that will be like revolution. This is mild non-proliferative, but look at the periphery, extensive retinal ischemia. So some of these patients come up in few months with dense vitreous hemorrhage, and you never know why, because you already had examined the central area. Again, after treating the patient and you can resistant proliferation, it's not responding because you missed a lot of areas of ischemia. This is a pen retinal, but you need to know what is going on at the periphery. Sometimes you miss large areas. That's why it's inadequate laser, so you get proliferation still active. Juxtafoveal telangiectasia, look at the periphery. It's very important to see what is going on at the periphery, not only in the macular area. Again, in uveitis and in imaging of uveitis, you can see the bully, you can see the sensory detachment. You need a wider field to document these patients before start treating this patient, because we are treating the whole thing. Wide field in uveitis, as I said, look at the fundus picture and look at the fluorescein. If you look at the central or posterior pole, you will never find out there is vasculitis, and mainly the vasculitis at the periphery. So sometimes we miss the periphery, and we'll never know if this patient has a real vasculitis or posterior uveitis or not until we do fluorescein angiography of the wide field. Long-standing retinal detachment with new vascularization, and look at the periphery, extensive new vascularization because of long-standing limited retinal detachment. Again, OCT angiography, as I said, you can have 12 by 12, but if you need the periphery, you can have two 12 by 12 and make a montage, and this is very quite good enough to start treating these patients. Zeiss had a Plex Elite with one picture was 12 by 12, very accurate, very nice to document that. Even in vein occlusion, you can see the OCT, you can see the fluorescein, but OCTA can replace fluorescein angiography sometimes if the patient has contraindication to fluorescein angiography, and we can even have the flow inside. This is before laser photocoagulation, and this is after laser photocoagulation and intravitreal injection. We can see the regression of the new vessels. So again, fluorescein angiography cannot be replaced up till now, even with the mosaic, because of the artifacts. Once you go to the periphery, you can see a lot of artifacts at the periphery. You might miss a lesion, and montage even increase the artifact effect, and you cannot depend on that up till now, but I think in the future, OCTA will replace it. Last thing is fundus autofluorescence. When you do laser photocoagulation, you need to know what is going on at the periphery with fundus autofluorescence, and these are the laser scars, so it's an adequate PRP, another patient. Look at the fundus autofluorescence. You don't need to repeat fluorescein angiography every now and then. You can be satisfied with the color and fundus autofluorescence. And again, look at this. We hope in the future we can have 360-degree OCT, 360-degree fluorescein OCT angiography replacing the fluorescein angiography. My take-home message is, though retinal examination, including slit lamp or indirect ophthalmoscopy with 360-degree indentation should be your standard of care, but again, wide field, color, fluorescein, OCT, and ICG are very important in documentation in the diagnosis and monitoring of this patient. Thank you so much for your listening. I think we can skip the discussion to the end, so after we finish everything, we can have the discussion, so everybody will see what's going on, and then we have the questions at the end. Thank you so much. Next presenter is my dear friend, Dr. Abdullah Kahtani, who came from UK. Haven't seen long time. Welcome to our MEOM meeting. And he is going to speak about updating diabetic maculopathy management. Please go ahead, Professor Dr. Abdullah.
Yeah, thank you very much, Professor Magdi, and thanks everyone for attending. It's my great pleasure and honor to be here with you. Actually, I have it's a very big topic, updating diabetic maculopathy. So I'll try to summarize it and let you know where we are and where we are heading to. So there is no need to say that at least 20 or 30% of our patients we see in the clinic are mainly related to diabetic disease. And I'll try to take you through the journey, where we are and where we are heading to, and what's coming in the future or in the pipeline. As you may know, there is a consensus now that the treatment for center involving diabetic macular edema is mainly through injections, either anti-VEGF or steroids. And we tend to do laser for non-central or focal macular edema. And we have multiple medications in the market. And what most of us do is actually tend to do a combination treatment for selective number of cases. In relation to the new or emerging treatments, we have few molecules coming in the market. And I'll take you quickly through each of them. We have aflibercept 8 milligram. As you may know, we have a long experience with Eylea over the past few years with good safety and good efficacy. The company has started now to introduce the 8 milligram. And this is based on the Photon trial, which is a 2-year study. And they were looking more like a more durable molecule. So the trial arm was mainly like 3 months injection, followed by 12 weeks or 16 weeks. And there's a very good promising results from this trial and showing that about 80% of the patient will be able to be extended to 16 or even 24 weeks dosing. And the main rationale for the high molar dose is actually there is a possibility that with this higher concentration, you can get a potential additional suppression of VEGF over this period. And that's why they increased the dose. And interestingly, this molecule was quickly approved in the US just a couple of months ago, and hopefully will be approved in the UK in the near future. It's not only for diabetic maculopathy, but also for for wet AMD and diabetic retinopathy. However, there are two things here. They have actually 4 times the dose, not only 2 milligrams, they shifted quickly to 8 milligrams. And the company claimed that this is the most efficient dose to achieve that durable outcome. One interesting observation here, this molecule will be like 0.07 ml, which is slightly larger than what we used to do. However, based on the trial, there is no increased risk of eye pressure spikes or thromboembolic events. And we are still waiting for the real-life data to tell us the exact efficacy of the HD Eylea. Another molecule which actually has been there in the market with us for nearly a year, and the good thing about Vabysmo is that it has a dual action. In addition to VEGF suppression, it suppresses angiopoietin 2. The Yosemite and Ryan trial, again, were looking for a more durable molecule, and they said that large number of patients, up to 70%, can be extended to 12 or 16 weeks. And it seems like the main focus of most of the new molecules is durability, to decrease the burden on the patient from multiple injection. It was approved in the US last year and approved in the UK June 2022, and they have been using it over the past 12 months. In real-world practice, we're achieving really good results. We still, as you may know, with these long-acting molecules, you tend to get this durability when you shift the patient in the second year. So hopefully we'll see whether our real-life data will match with the clinical trial or not. Another thing under investigation, which is quite interesting, is the port delivery system, which was like a tiny refillable device which is implanted into the pars plana and can be filled with Lucentis or ranibizumab, which again looking for more durable action where you can fill that with once or twice a year. There are a couple of trials ongoing on this BDS system, and interestingly, it was approved in the US 2 years ago. However, so it has an advantage of long acting and you can refill it, but as you may know, it's a surgery with all its own complications, and that's why it's reserved for a second line treatment. However, last year, However, last year, the company did a recall for all Susvimo ocular implants, and that's the problem here. There was some reports of that the septum where you inject through sometimes get dislodged during the repeated injection process, and this is actually lead everything put in hold in the commercial setting. But I had a recent communication with the company, and they improved the device and hopefully will come back in the near future. So let's take you quickly in a few slides about what's happening in the pipeline. And actually, diabetic maculopathy is a very rich medium for clinical trials. If you go to clinicaltrials.gov, you'll see more than 600 trials investigating either recruiting or currently ongoing. It's a very big topic of discussion now because the health burden of it. And the main reason for that, we have so many challenges and unmet needs, like repeated injections or safety of the medication. And even these medications in real life, there is about suboptimal response in about 10 to 20% of patients. And ideally, the ideal drug or the ideal treatment we are looking for is something durable, something long-acting, has efficacy, and also easy administration rather than injection, because injection is invasive, and also hopefully less cost. So there are many things in the pipeline, new anti-VEGF molecules, new drug deliveries, new diagnostics. So there are few molecules actually in phase 3 trials, like KSI 301 and the Oftia drug. And we also have some biosimilars. There are also a trial ongoing about suprachoroidal dexamethasone injection using a special injectable device, which will explore the suprachoroidal route. Also, companies are trying to improve the technology for drug delivery, like giving, hopefully in the future, we'll have topical anti-VEGF. Things explored like cell-penetrating peptides or nanomicelles, where you can give an eye drop of anti-VEGF, which will be the future, hopefully. There are also, I feel this is really promising, that the new diagnostic, if you can do an early detection with a small portable devices, even the patient can do the scans at home. And this is actually the future, and hopefully will allow for telehealth and e-consultations. Artificial intelligence, as you may know, is a hot topic, and there is a scope for that. By analyzing the scan, predict those who may develop the diabetic maculopathy, and we can start treatment early. So there are many things happening in the pipeline, and we are optimistic. Diabetic macular edema is still a challenge for us. We still need to combine treatment, and the main thing is the durability, and there is a hope in the future. Thank you.
Thank you so much, Dr. Abdullah, for this nice presentation, and we will keep, as we said, the discussion to the end because we shouldn't run out of time. May I introduce the next speaker? Dr. Fahd Kohel is not here, probably, so I will introduce the next speaker, Dr. Brahim Al-Gharabri, my dear friend, and he is going to be speaking about update in CSR management. Please go on, Dr. Brahim.
Good afternoon, everybody, and thanks for the invitation. CSR in 2023, I don't think it's big difference compared to what it was before. As we know, it's affecting the middle-aged population. Male are more affected than females, and also those who are using steroids at high risk. And this is how the CSR presented usually in the imaging subretinal fluid with hot spots in the macular area. And as we know, that pachychoroid is an elegant term that we use it nowadays, and CSR is one of the variants of the pachychoroid disease, where there is vasodilation of the Heller's layer and Heller's vessels in the choroidal area. Imaging-wise, there is a different phenotypical variation. If we look to the classic CSR with just subretinal fluid, you can find some fibrin, and even can detect it clinically and by your OCT, and also in the chronic cases where you can find this atrophy in the retinal pigment epithelium. We used to classify it as acute and chronic, but this is not anymore. The better classification will be non-resolving or persistent CSR, which lasts more than 4 months, or recurrent CSR, where complete resolution happened and then recurred again. Chronic CSR is associated with atrophy of the RBE. In active CSR, where someone mentioned it was in the history, I had CSR, but nothing left after the resolution. That is the current available treatment, observation, laser, oral medication, or anti-VEGF even. However, actually, these are the main lines of treatment at the moment. What I mean is from the oral medication, only the mineralocorticoid antagonists are the main line. Let's start with the PDT. PDT is not available everywhere. PDT is still the gold standard for treating chronic or resistant CSR. We usually use it half fluence, either by halving the dose or halving the time of exposure. And also the spot size always depend on the mid-phase ICG leakage. We need to consider it if there is acute non-resolving CSR or recurrent occurring cases. And we need to be cautious not to repeat it too much. You can repeat it only once, but not many. You need to be careful if there is good visual acuity, because simply 6% of the patient can have atrophy, or if there is fibrin, fear of overdosing. And of course, the limitation is it's cost effective and not available everywhere. The second line will be mineralocorticoid antagonist, and this has been studied by Francine Poor. She was in Switzerland before, and with her group, they did big studies for spironolactone and eplerenone, especially. These are the two main drugs. They are comparable to each other, and actually, although spironolactone is 40 times potent than eplerenone, however, it is not used regularly because it has multiple side effects, as it is not specific, like the eplerenone. And I usually started this way, 25 milligram in the first week, do the potassium level. If it is less than 5 millimeter per liter, you can increase the dose to 50 milligram, and you carry on for up to 3 months. Please don't say it is effective or not until you carry on for a reasonable period, which is 3 months before you say it's working or not working. Also, you can combine the eplerenone with anti-VEGF if there is subretinal neovascular membrane associated with CSR. In inflammatory cases, I think Francine Poor mentioned she used drops of dexamethasone as a combination, and it worked better for her. And in chronic cases, we need to remember we don't stop the dose straight away. I usually graduated back to 25 milligram for another few months, and then every other day until the whole thing settles. So where we stand today with the MRA, simply there is many publications actually talking about the mineralocorticoids antagonists. However, the clinical studies report different results. Some people find it too good, some people find it not effective, and there is lack of consensus which patient we need to use for, or the proper dosing even up to now. However, new studies in the genetic basis, they started to say there is different haplotypes for this patient. Some people will have the gene to respond better compared to the others. Laser, we are using either suprafacial laser, which is the normal laser that we use only for the extrafoveal lesion, or the subchirurgical micropulse laser treatment, which is elegant idea because simply at this wavelength, you can approach the fovea. And because it's less taken or absorbed by the zensophil, and in overall, nearly 80% of the patients, according to these trials, showed reduction of the CMT. So which treatment is better? Simply, there was a place trial where they compared the BDT to the micropulse laser, and actually there was clear superiority for the BDT over the micropulse laser treatment, both in terms of the complete resolution and function. Also, there was another trial, which is called the SPECTRA trial. They compared the PDT to the eplerenone, and again, half-dose PDT is superior to eplerenone for the chronic cases or the resistant cases on the short-term efficacy. This is an elegant approach, transpapillary thermal therapy used for choroidal lesion. However, there was a study or some studies started to implement it in the chronic CSR, and it seems it's as effective as the PDT. And unfortunately, up to now, there is no trial, so it's not licensed to be used in CSR up to now. Okay. Other alternative, anti-VEGF is not good only if there is subretinal neovascular membrane CSR, but it's not working. Quickly, I'll mention a few cases. This is one of the cases where I treated with 44 years old. We used Diamox. He had everything before, and then When he presented, this is the CSR over 4 months. I started eplerenone 25 milligram, and then I increased it to 50 milligram over 3 months. However, after 3 months, as you can see, it's still there. And then I did BTT half fluence, and it's responded beautifully. And even it lasted up for 8 months. This is the last time I saw the patient. This is another case where a 33 years old had this hot spot there. And he was worried about the laser in the beginning because his brother had bad experience. So I observed him for 6 weeks, and then I gave eplerenone again for nearly 8 weeks, but he was not responding. I did focal laser for the lesion, and after 8 weeks from the focal laser, the fluid is still there. However, I looked to 2 scans. This is the scan at the level where the region is. I noticed this disappearance of this small PED, and I consider it as a sign of improvement, and I didn't rush for anything else. And after nearly 8 weeks, it's resolved completely. So when you are aware that you did the right thing, just wait and don't rush for anything quicker. Third one, this is a neurosurgeon in our hospital where I treated him with eplerenone. He responded nicely after 8 weeks. He completed 3 months even after resolution of his thing. This is the last one, but I promised Dr. Magdi I'll show him this case from the previous meeting. I said to him, I'll show you something interesting. This is very resistant, 70 years old male, bilateral chronic systemic edema. He has been given multiple anti-VEGF injections for years. And then they did fluorescein ICG for him, and we diagnosed with bilateral CSR with bilateral subretinal vascular membrane. BDT recommended at this stage. Right eye responded better compared to the left eye. However, we decided we will not do anything further for the right eye because simply there is no ellipsoid zone. There was a big destruction for the outer retinal layer. And left eye after BDT and the 2 aflibercept injection is not going anywhere. Unfortunately, we tried another 4 ranibizumab injection followed by second BDT for the left eye. Every time, as you can see, still not responding. And 2 more aflibercept and nothing happening. This is over 2 years, by the way, and because nothing else was available. And then BioView came to the market. And we decided just to give 1 injection. As you can see, after all the BDT and the anti-VEGF that we had and everything we did for this patient, 1 injection of BioView did this. So management of CSR, that is the take-home message or the conclusion. Observation, of course, will work in a lot of patients where you can wait for a couple of months before you go for anything else. Consider if the patient is young, if it's bilateral or unilateral, and you need to do something quicker according to his incubation or not. Eplerenone start with, as I say, 25 milligram, raise it to 50 if the potassium level is normal. If improved, continue eplerenone for 3 months at least. And if no improvement, do the FFA and see if the lesion is extrafoveal, do focal laser. If it is under the fovea, you can consider BDT. BioView could be a new player according to the resistant case that I show, and thank you very much for this.
Thank you so much for Dr. Ibrahim for this update on the management of CSC. I'm sure we will have a lot of questions at the end, and I'm glad we still have, we are not running out of time, so we will have time at the end for discussion. May I introduce the next speaker? Gene therapy in medical retina by Dr. Mario Sarvayev. Please go ahead, dear friend, and he's still suffering from jet lag. He lost his jacket today, so again,
Yes,
he's trying to get rid of everything.
I need to take a nap.
Okay,
Please.
please go ahead.
Okay. Well, I'm just going to tell you about, we are just starting. I don't know if you have patients here or somebody has experience with Luxturna here. Okay, great. 10?
11 eyes for, 12 eyes for 6 patients.
You already treated 6?
6 patients, yeah, bilateral, so it's 12 eyes.
Both eyes. Yes, both eyes, but okay. So this is well, so you come here and no, because what for? I'm just we did 3, Okay, we did just 3, but anyway, just talking about Leber congenital amaurosis. It's a group of diseases that drives to visual impairment or even blindness at birth or in the first 2 decades. Some consider this disease like a severe form of RP. And the most common genes, there are several genes that could produce lever, but we only have a solution for the RPE65. Come on, come on, come on. Okay, the next one. Ahí está. Well, you know, you have to do a genetic test. We have this drug, Luxturna. Luxturna has a prevalence of about 2% in RP patients. So this drug works for liver and also for RP. But in RP, there are very little patients. In liver, we have quite an amount of them that could be. But finally, it's 1 in a million. So I don't know in your country how many you are? Population. Because it's 1 in a million. In Argentina, we are 45 million. So we're supposed to have 45 patients, but we just found about 15, you know. Okay. Well. Okay. Well. So, well, we found 15. We treated 3, but the first 2 were RP, and this last one was a liver, and we have 12 more in the pipeline. It's difficult because in Argentina it's hard to get. The patients don't have insurance. This is a quite expensive drug, and so they fight. You know, they have sues in between the HMOs and the patients, and you know. So, but at the end of the day, all the judges give them the right to have the. And I'm going to tell you just about my little experience and the technique. As you know, we have to make this subretinal injection. We can use this regular 41 or 38 gauge cannula, and with this syringe and the extension. Very important is this. Do you have? Yes, you have. Well, nobody told me anything about this the first time, and I was so shocked because, well, the company, they say, no, you have to prevent inflammation, so you have to give prednisone, as you can see in the right side, regular prednisone, but after the first day, well, I'm going to tell you later. Well, the surgical procedure depends a lot. In my case, I have my assistant. I prefer, you know, some use the injector from the vitrectomy. But yes, but it's more sensible to have a human. There's no room for robotics. Where's Hussein? Oh, Hussein's not here. Yes, you are. No robots here, I'm sorry. Yeah, as you, I have my robot, you know, called, well, we have to choose the place where to put, and finally, but I have this is not important, I'm going to show you a video of this, okay, this is a 1 minute and a half or 2 minute video. The first thing is to take a hyaloid out, and you know it's not that easy. Well, you know, in children's it's not that easy. Finally, this is the first eye in the kid, and I had to make so much pressure to get that little bleb, and finally we didn't realize. Actually, my assistant didn't realize that we had a little bubble of air. And I said, well, okay, it's better. No, it's not better. I'm telling you later. And this is the second eye, and the left eye. And this time, we did it different. We stained and we take, no peeling, but little windows in the ILM. And it was very, very easy to make the blood. This is, I think this is the best tip I can give to you. If you take the ILM, it's so easy to make the blood. So very, very easy. So I made a little bleb. You can see close to the fovea, but not in the fovea. Don't get to the fovea. In the other eye, we detached the fovea, and it took a lot for him to recover vision in that eye. But in this eye, this second eye, the surgery was perfect, and it was amazing. Well, I'm telling you, the next day, as you know, I found such an inflammation that I thought that it was an endophthalmitis. You know, actually, I said, yes, it could be an inflammation, but no. You know, the eye was a yogurt. You know, everything was white, and I was so confused that I called Audina Berrocal, a friend of us in Bascom Palmer. She has, I don't know, 50, 100 cases, I don't know. And she told me, no, they don't tell you anything, but the inflammation is a monstrosity. So the way to find, the way to fix it was to inject, ¿cómo se llama? No Dexa, you know, the long-lasting. Yeah, but it's like a program. Yes, dexamethasone, not dexamethasone, the deposit one, the one we use to stain the vitreous. Triamcinolone, triamcinolone, okay. So triamcinolone, subtenon triamcinolone, and it was like magic. And so in the next, in the second eye, we injected triamcinolone just from the beginning. But this is just the only thing but what it was impressive, I don't know your experience, but what was impressive, this kid, he came with nystagmus, with 2800, look like this, and 3-4 days after the surgery, he came like this, staring at me, and he was using, before the surgery, he was using a green stick, for low vision patients, and he told me, looking at my eyes, he told me, "Doctor, I have a present for you," and he folded the stick, and the mother said, he doesn't want to use it anymore. So now he's the guy, he's Benjamin, he's playing, the surgery was 2 months ago, and taking pictures, in Buenos Aires, and playing games. It's amazing. I didn't believe it. This is my first, that's why I wanted to show you. Just this, maybe you have the same.
Yes, liver.
Yes, it's a liver, but we didn't have this this response with the two previous guys, because they were in their 50s, RP, But in liver, it's impressive. So this is the only thing I wanted to show you. Thank you.
Thank you so much. Thank you. We are glad for your patient, by the way. We are glad for him. May I introduce Dr. Amin Marashi, the next speaker from Syria. He was going to speak about updating geographic atrophy management. Please go ahead, Dr. Amin.
How to navigate with this?
The green one. That's the only one working.
Okay. So today I'm going to talk about the new emerging treatments for geographic atrophy. I have no financial interest in the products mentioned in this presentation. The main focus since the 70s was the recognition of choroidal neovascularization and the attempts to treat it until 2012. But we all know that the AMD is not only the wet AMD that causes loss of central vision. We have also the dry AMD, and exclusively I'm talking about geographic atrophy, and we have a lot of patients that they only dry AMD patients and remain dry, and they lose the central vision. So we have a new medication that draw a new horizon for us. To understand how those medications work, they address the immune response. We have two arms, the humoral, which is more about the complement pathway, and we have the cellular, which is all about the macrophages. So we have the FDA-approved pegacetacoplan, which roughly showed us that about 33 or up to 33% reduction, halt of lesion growth, not a reduction, but there is a bit of increased exudation due to development of macular neovascularization. Also, I don't know if I'm pronouncing it correctly or not, the avicii-nacapitat pigol, which targets the C5 complement. The other was the pegacetacoplan targets the C3 complement. Also showed about halting in 35%, and also we had the same issue of the increase of macular neovascularization and exudation. So now there is clinical trials about a new drug, which is the AVD104, which has a dual mechanism which regulate both the cellular and humoral aspect of the innate immune response. In the cellular arm, it binds to cyclics on the macrophages. In the retina, triggering a self-response and repolarization to a resolution macrophage phenotype, preventing geographic atrophy. And it also works on the humoral arm, which reduces the amplification of C3, but it does not eliminate it completely. This is the main difference between it and pegacetacoplan. Hence, there was a less cases of active macular neovascularization. The take-home messages is most cases are recommended for a non-central geographic atrophy, because we should understand that they won't reverse the geographic atrophy, rather it will halt its progression. The pegacetacoplan was recommended to be administered every other month, because when they compared it to every month, there was less complications. However, patient should be consulted that the macular neovascularization and inflammatory reaction are possible complications. However, the FDA gave an open label for central geographic atrophy also, but this should consult with the patient because those patients may appreciate if they have a bilateral geographic central geographic atrophy, the reduction of or the halt of progression. The halt of progression of the central visual loss. Thank you very much.
Thank you, Dr. Amin. Can you keep up here? Because we will start the questions from the last to the first about that. So instead of going up and down. So thank you so much for this presentation. We'll start by Dr. Amin if anybody wants to ask him.
Just I'll make a comment about the dry AMD. Actually, there is two drugs available at the moment, C5 and ACP. Both of them have been approved by the FDA, and C5 has been used for a year now. Actually, one of the main concerns, as you said, and which even raised by the ASRS, what the American Society of Retina Specialists is, the increased number of the subretinal vascular membrane or transformed to the exudative, and of course the inflammatory reaction which happened with some patients. In ACB, the new drug which has been approved recently, it's not in the market yet. However, this, in the two trials, the inflammation is less, and the subretinal vascular membrane, the percentage of both of them are less. Most probably it is related to the complementary pathway. What I'm saying is the C5 acting in C3 pathway. However, the ACB is working in C5 pathway, which is more specific and less immune reaction happening. I just wanted to declare this. The main problem which will face us is, first of all, it is not curing a drug. It doesn't show an improvement in vision because simply it's not like the exudative AMD. When you draw it, you notice some improvement of vision. It slows the progression of the disease, but it doesn't stop it from happening, just a slower progression. And it is injection every month, which is nearly $2,000 every month for this patient. So the discussion with the patient and explaining this kind of treatment will be a challenge, big challenge. And whether it will be benefit in the long run or not, that's what I want to.
Thank you, Dr. Ibrahim. Dr. Ayman?
Yes, I want to ask Dr. Abdullah. Thank you for this.
Thank you, Dr. Amin.
Oh, I want to ask
you can take
about
the same microphone, Dr. Abdullah. You can take from him the microphone and then answer.
To ask you, Abdullah, about the issue
course.
of tachyphylaxis in anti-VEGF treatment. You know, sometimes you are treating with Eylea and all of a sudden Eylea is not working. How would you differentiate? This is non-response to the treatment, or is it a tachyphylaxis? And how would you tackle such patients in your practice?
Actually, that's very common. We come across that maybe in 10 to 20% of cases, especially with diabetic macular edema. And that's why in most cases, even in our protocol, our loading is at least 5 injections, and some patients 5 monthly injections, and then we start extending. Even with Vabysmo, when we started using it, we didn't follow the guideline. We did only like a 4-week extension rather than jumping to 12 weeks quickly. And that's why the B patients will be non-responding because actually anti-VEGF treats only VEGF-related macular edema, but there is also some sort of inflammation, other pathological mechanisms which we don't know. So that's why even in our clinical practice, we tend to do a combination every now and then. So if the patient is not responding, but we tend to give it at a time, let's say 6 injection, we didn't show any change, we can try to switch to another anti-VEGF molecule. If there's no further change, we may combine that with steroid, dexamblant. If there is a scope from some focal leak somewhere, we try to deal with that. And also we look at the systemic condition. Let's say uncontrolled diabetes, uncontrolled hypertension, medications are unlikely to work. So to be honest, we tend to combine in many situations, many of these, especially type 1 diabetics. Yeah, thank you.
I've seen Dr. Mario is escaping just 1 second ago, so I was going to give him a question, but again, he left the room, maybe asking for robotics outside. So let's move to the Dr. Ibrahim Al-Gharabli. Any question for Dr. Ibrahim?
Thank you very much. This question for Ibrahim. CSR, as we know, is a very challenging and very common problem in this part of the world, and we see them quite often. And there are no clear-cut guidelines about certain modes of treatments. And you go through the literature, there are some, but not very clear-cut. So my question is, 2 questions actually. One is if you do a sub-threshold laser, do you repeat it if there is a persistent fluid, number 1? Or if you move on to do maybe anti-VEGF. So what protocol you follow to do anti-VEGF? Do you go for a loading dose? And how do you can continue to do injections, and what point of time you stop those?
Actually, anti-VEGF and CSR has been studied a lot, to be honest. And if it's pure CSR, anti-VEGF has no role. Maybe you can have 1 or 2 cases by luck, but it is not a routine treatment for CSR, except if there is subretinal vascular membranes with CSR here, the anti-VEGF will have a role. And usually, as I said, if you use the micropulse laser, you can still always have all the other options, like epineuron is still there, you can use it, and the BDT is still there, you can use it. Of course, any laser, you cannot repeat it, except if you missed the target from the beginning. In this case, you can go to the hotspot and just do whatever you like after. But of course, if no response to the micropulse laser, you can go for the other options, epineuron, PDT, and PDT is still the gold standard. If you have to repeat it once, the PDT itself. Otherwise, don't do any more because RB atrophy can happen and lose the vision.
Can I also? So let me ask you, Musa. So we are living a very exciting moment with new drugs, new techniques, and new images. So how do you think to see the periphery and to know what's happening in the periphery that was hidden from our thoughts will make a change in the way we treat things, mainly diabetic retinopathy and even macular edema from diabetic, because in the States, nobody believes in the laser of the periphery to treat sometimes the problem in the posterior pole. So that's the question.
I mean, they start to innovate things, they give you the things, and then said, don't use it. I mean, they innovate things. I believe in the periphery. Most of the time, the hidden lesion are the cause of recurrent central macular edema. This is the cause. If you have extensive ischemia at the periphery, you should treat that. You should not leave that forever and think about it. Some of the studies said targeted laser photocoagulation, and it did improve that it's different from PRP. It's almost the same. But again, if you have ischemia at the periphery and you can recognize that, I shouldn't leave that, because later on you will have neovascularization or recurrent of the diabetic macular edema. The technology now is helping us in the diagnosis, and whatever you do and improve your diagnosis, the management will be improved. In real life practice, don't leave ischemia. We don't leave ischemia. Even in a vein occlusion, we used to know that it's not ischemic. After the white field, it's ischemic. None of the vein occlusions has no ischemia. All of them had sort of ischemia. So again, we studying the periphery, we would know what's going on in the central area. And as we said, anti-VEGF, it's work and then it doesn't work. It works and then it doesn't work. We have a lot of unmet needs, but if you treat the ischemia, that's it. You can finish that. So again, imaging is very important. You know what's going on. Customize your treatment. You have a real life practice, you have an experience, do whatever you do, but again, not everything in the literature should be believed. I wanted to comment on Dr. Gharabli CSR. CSR is one of the chronic lesions. Whatever you do, you cannot prevent the recurrence. Whatever you do. And I think there's a genetic element in that, because some people have one attack and forever they never come back. And some people keep coming on and on and on. And once you reach the CNV, even if you inject anti-VEGF, the visual prognosis is bad, because this is a chronic, destroyed outer retinal layers, long-standing sensory attachment. So we are trying to keep the vision as much as we can. But again, injection is the only thing in CNV. We don't use injection in chronic CSR without CNV. And again, whatever you do, PDT is not popular all over the world. Again, in Egypt, in the Middle East, in the country, a lot of countries doesn't have the PDT. And why? Because of the companies hidden that to use other things. So you know that. But again, PDT is the only solution, but again, it does not prevent the recurrence. It depends on the patient itself.
Okay, yes, BDT definitely the gold standard. And as I said, if patients treated by BDT, honestly, I didn't see recurrence. I have patients which I've been followed for 3, 4, 5 years even. It is great treatment, but it's not available everywhere. For epineuron, if you reduce the dose quickly, this is will recur again quickly, and you need to maintain the patient on the minimum or every other day dose just to keep him stable. One of the interesting things, the combination, actually. I had someone with CSR, anti-VEGF, and I'm managing to control him with epineuron and anti-VEGF as a combination. Both of them are going absolutely fine for him. Every time I try to reduce the epineuron down every other day, the fluid will come back again and you need to carry on. Every time I try to stop the anti-VEGF because it is dry, it's just keep coming on. It is, as I said, just per patient, if we put it this way. And for your useful question, if you don't look for the periphery, you'll not see anything. That's fine. However, up to now, we don't have any guidelines to treat according to the lesions that we will see in the periphery. It's exactly the same when you do OCT angiography, and you see subretinal vascular membrane, but there is no fluid, there is nothing, no activity. Will you treat or not treat? So the thing is you are looking for, you will find it, but is this mean you need to treat this patient or not? That is the question that we don't have clear answer or consensus for.
Dr. Ibrahim, I have here my comment, I have a question. Dr. Ibrahim?
I just wanted to mention a couple of things. You talked about epinephrine. It has not worked very well with us somehow. I mean, maybe sometimes, as you say, it is like a placebo. The patient feels better that he's taking this drug, his fluid goes away, and then it comes back. And another thing which I wanted to just add, we have some absolute indication for the pediatric patients, especially for ultra-wide field imaging, and the two conditions being, of course, one we deal ROP and fever. I think there you have to do, that's where it started. And we can't even, today in anti-VEGF era, we'll have to do this for a very, very long time for all that peripheral avascular retina, what we call as BAR, because it's going to change the whole scenario of treatment in future for us. So I just wanted to add that part.
Okay. Thank you. Last question very quickly. I think Dr. Ibrahim and I, we are different opinion about the best treatment for CSR, even chronical. For sure, PDT is a bit superior regarding the end results by chronical CSR. But definitely, this very mild difference, it doesn't define or justify the risk that we could have some complications by PDTR. We have zero risk by micropulse laser. And even, when, as example, Dr. Ibrahim said, okay, if it doesn't work or there is an remittance, you can use any laser. That is not fair. I think we have to really to underline that the micropulse, if we recognize the post-treatment complication by PDTR or others, there is a risk. And we know that. When we compare that with the good result of micropulse laser with zero risk, I have now really over 10 years experience with micropulse. It's amazing. It is like magic. Zero complications.
Dr. Ahab, it is not my opinion. It is a trial called the PLACE trial.
Yes, of course.
Just a second.
I spoke about trial first, and after that I spoke about my own experience.
Okay. It is trial done to compare PDT to the micropulse laser, and at the end, yes, both are working. However, the PDT is superior to the micropulse laser. That is the conclusion of the trial, which is called PLACE trial. You can go for it. And simply they said, even one of the main problems of micropulse laser, it takes longer sessions and longer time to resolve the CSR compared to the PDT.
Thank you, Dr. Rahab. Thank you, Dr. Ibrahim. I think all of them work, but again, the trials has to be respected sometimes. Thank you so much. This will conclude our session because we are running out of time. Thank you for attendance. Thank you so much.
Dr. Mahmoud Ismail, I can. Good afternoon, everyone. So basically, we start our session about what's the update in the dry eye disease. Me and Dr. Mahmoud Ismail will moderate this session. The first talk, Dr. Safwan is still not yet here, so we'll start with Dr. Ashraf Omnia. He will talk about osmolarity, the hitting enemy of OSD. It's all the banner is yours. And everyone know him, so no need to introduction, I'm afraid.
Hello, everyone. We are happy that everyone is enjoying. So let's talk about something that is new in our area. It's already well known in the States, but in our region, North Africa and Middle East, it is not known yet, and we didn't increase the awareness till now about this. So I'm going to talk about osmolarity is the hidden enemy of ocular surface disease. So these are my disclosures, company that I'm a consultant to and a speaker to them. So let's go. Osmolarity and the surgical outcome. It's a new information impact for the patient management. So my presentation will discuss how osmolarity measurement meets the two requirements for variable diagnostic test for refractive and cataract surgery, providing new information and information that change the patient management. I will address also the light scattering effects of the hyperosmolarity and the hyperosmolarity impact on the keratometric measurement and the refractive surprise. The Ascaris ocular surface disease, the Ascaris highlighted this for the ocular surface disease algorithm relative to non-visually significant OSD versus the visually significant OSD. So this is like stable tear film and unstable tear film. You can see the difference in the picture, and you can see it on the diagram how the blue and the orange. The orange you can find that is different in the degree of osmolarity, and the blue is the normal range of osmolarity. The same. So in this area, these are low osmolarity and these are high osmolarity. You can see how the toxic high osmolarity causing damage of the corneal cells and affecting the nerve fiber damage also on the corneal surface. Toxic osmolarity, as we said, affect the corneal cells. Predictive tool identifying diagnosis and potential refractive surprises. Provide a pre-surgical baseline for the potential post-refractive surgical dry eye. Provide confidence in the advanced technologies. And also it must be a routine testing providing a bridge to enhance the patient adoption for premium IOLs. So why osmolarity matters? Because in the green picture, you can see that this is the normal cells, the alive. But in the hyperosmolarity status, represented by the red cells, this is the dead cells. And this is why the patient can see 20/20, but he is not happy. 80% of the cataract patients, 80% of the cataract patients present with at least one sign of ocular surface disease. And the leading indicator for this is the Schirmer, tear break-up time, staining, and meibomian gland grading. They found that 31.6% of the laser refractive surgery patients have inter-eye delta, more than 8 difference in the hyperosmolarity. And the prevalence of tear film hyperosmolarity, it was a study done in USA, and they found that the number of patients of this study, it was nearly 10,000. The percentage of patients that have +1 dry eye symptoms, 81. They have moderate hyperosmolarity, 29%, and the symptomatic patient with normal osmolarity was 36. Which OSD is it? This is a nomogram said that when we look for when you test the osmolarity, if it's normal osmolarity, so you can find an alternative disease for ocular surface disease like this: anterior blepharitis, allergic conjunctivitis, dry eye disease, etc. If it's symptomatic, means that it has a hyperosmolarity or toxic osmolarity. So abnormal osmolarity confirm that the patient has a dry eye disease. Track the treatment response, use the osmolarity testing to rule in or rule out the dry eye disease. And in this diagram, you can see that 80% of the cataract surgery patients have signs of ocular surface disease, and 57% of the cataract surgery patients have abnormal osmolarity. This was hidden to us. We didn't know this before. And more than 1 diopter variability in the preoperative keratometric in cases you are going for astigmatic correction, 1 out of 5, they are hyperosmolarity. And this is the normal. Normal hyperosmolarity from 290 to 280, abnormal from 325 to for the mild, moderate, and severe. For sake of the time, I'm going to go a little bit fast. So if you go for to confirm normal osmolarity, it is increased the confidence when you're using astigmatic trifocal IOLs, either diffractive or extended focus. You should go for testing of tear film osmolarity before going for this if you want the patient to get satisfied after the surgery. And now we find that even the light scattering from the hyperosmolarity representing the nuclear cataract exactly. And it was approved by a very nice study saying that the scatter index based on double pass retinal image of the point source to classify the cataracts. So it's the same as the cataract doing. Cataract doing light scattering, so the patient is unsatisfied, the same when it has a toxic hyperosmolarity. So the new information said that the hyperosmolar tears, which cannot be detected in a slit lamp examination, cause ocular light scattering. And so advise and manage the patient pre-surgically, including the need to address the hyperosmolarity tears. And this is the normal hyperosmolarity, and this is the abnormal, like this. You can see the yellow graph, this is the base, and when you have an hyperosmolar patient, you are going to install the artificial tears 5 minutes and 15 minutes, you can reach the base for this. And the same, this is the effect. The effect of hyperosmolarity making that you can find the graph is a lot of the changes in the K max, max for the patient differently, but in the normal hyperosmolarity, the same line, there is no changes in the K values. And now by the American Society of Cataract and Refractive Surgery, this is the protocol since I think 3 or 4 years. They are classifying when you go for surgery like this, symptom signs, and you put the second is the osmolarity testing. And they're dividing into a non-visually significant OSD and visually significant OSD. And you can prepare your surgery like this. So the effect is uncontrolled. For, cases of uncontrolled eye diseases is a contraindicated before cataract surgery. I will go more for a new, just published a new study, just this April 2023 by the Ukraine, and they said that the increased tear osmolarity can affect the planned outcome of the cataract surgery. It was published in the Journal of Ophthalmology, unexpected refractive errors. And they found that in normal and hyperosmolar, you can see the tear break up time in the normal is different than the hyperosmolar group, even with the stain, and the mean case is increased in the hyperosmolar group. And when you look for the significant refractive errors, it's very clear that is different from the normal to the hyperosmolar group, and it's more than 1 diopter missing. And the patient satisfaction is increasing, this satisfaction is increasing in the hyperosmolar groups. So they said that the patient with higher tear osmolarity can be more often have lower uncorrected visual acuity. And in this study also shows that the tear osmolarity, the main diagnostic factor of dry eye disease. This is the first case in Egypt. I brought the machine to my country. This is the first machine in Egypt, and I don't. It's not popular still in our region. And now I'm measuring tear osmolarity for all my patients before cataract surgery and follow up post-operatively first week, 1 month to detect the unsatisfied patients if hyperosmolar or not, and also for all my refractive cataract surgery. So the NewScope Pro, which is the new machine for osmolarity, it's a very light technology, assuming accuracy of testing and assure clinical value in pre-surgical assessment. Why osmolarity matters? Because providing new information for the patient management. Thank you so much. Osmolarity becoming one of the most important pre-management if you are going to attack a premium cataract patient. Thank you so much.
Thank you very much. That's very good. We'll leave this question at the end.
Yes, yes.
So your time, by the way, Safwan.
Yeah, I'm respecting the time.
Yes, I'm here.
So
I'm here.
316, from where we get it?
316.
The osmolarity.
From the
normal.
The normal.
Yeah. So how we are saying that this is a clear cut?
Yes.
Yeah, that's right. 316 is the clear cut. Above it, it's abnormal. How we reach that 360 is the safe? Because of the toxicity.
Yes, toxicity. No, no.
So what you said?
We have a range because we are now measuring the hyperosmolarity. Not all patients have the same osmolarity. Exactly. So it's from 318 like this to around 336. More than this, it's hyperosmolar patients. So if we find the patient is hyperosmolarity before cataract surgery, we should look why the patient is hyperosmolar. If it's hyperosmolar, we are going to control, look for peripheritis, look for dry eye disease, control it, and then remeasure the hyperosmolarity again. If it's controlled, you can go.
Yeah, Dr. Ihab, okay, go ahead.
أشرف يعني extremely relevant point, but for me the osmolarity measures the salt in water. So this is the amount of water and this is the amount of salt. Whenever the water decreases by evaporation or non-production, the salt will increase.
Exactly.
And this in human being.
That's the point, actually.
Yeah.
That's the point.
Yeah, in human being, this is not constant. You know, the base, is there a basal tear osmolarity where you can say that your measurements are correct and are the relative? And then my other question is there is always the thing about the biomarkers for diabetic macular edema, for so and so. If you look only at the tear osmolarity as an indicator of dry eye, did you correlate this to simpler thing like breakup time, like like the other parameters? Because I can say that smoking increased dry eye if I look only at smoking and dry eye. But if I do on a multivariate analysis, promoting a machine that we really don't know what would be the end of it, and we don't have regular measurement, So if you say that your machine would measure the sodium, the chloride, the sugar, and everything, and we have clear cut of everything on ground, and we have a normative database, I would definitely accept you must and you have to and you whatever.
Let me explain something, because before the tear osmolarity measurement, it was before I do the tear break-up time, the Schirmer test. But sometimes you can find the tear break-up time is good, Schirmer test is okay, and you go for surgery and the patient is not happy. Before, the most important that you measure the test card for the machine. It has a proper temperature. It cannot be very hot. It should matching the same temperature of the body to get the best results. So if it's more humid or high on the machine also, you can know that this test is correct or not, because it brings you the temperature at the time of testing.
Yes.
So if it's more heat, so it's not correct. So you should retreat it. Everything in the new machine is different than the old tear lab at all.
Thank you, Ashraf. As in sake of time, we have to move on. Yeah. And Dr. Safwan Al-Bayati joined us.
Good afternoon, everybody.
وكان الدكتور أشرف أرمية باعه وسابه هناك في الكورس. الدكتور صفوان اضطر يعني.
You remind me about that, والله.
Yeah, I will have to remind you.
Yes. So I do agree with our colleague that it's not in any case that we need to go directly in, but there is a simple issue that most of us maybe they don't have. Poor people like us, they are not have the ability of Ashraf. Ashraf have more, but we can go through and test the issues that Ashraf do it when our breakup time is below 10. That's the issues. Yeah, I'm going in. This is the forward. Okay, so complicated issues for what's the treatment of the last 6, what's the newest in the treatment of OSD in the last 6, including everything. So I said that let us go to a little bit basic. Blepharitis as a causes, dry eye syndrome, eye allergy, decreased tear quality and or production with age, chemical or thermal burn, side effect of medical treatment, keratitis, jaw grain, MEOM, MGD. Now, another return back to our vicious circle that can lead to higher osmolarity, and this higher osmolarity have a degree where they measure it histopathologically, and they found that it's in between 316 and 325 to create a toxicity and then a cell death. And which cell death? It's a goblet cell, the favorite cells for us. So all these cycle goes to increase this osmolarity and the inflammation, and that what will lead to lose two important issues, the mucin and meibomian secretions, the lipid. So we will have loss of tear and increasing the osmolarity and then the cell death and the inflammation. From this point, if we are understanding this equation easily to tackle, so when a breakup time is less, 100% we have mucin deficiency or lipid deficiency. We don't have a clinical test to test them in between. We have histological tests. So normal goblet cell means that normal meibomian gland means that we have a goblet cell. And always, the more sensitive is a goblet cells, not meibomian. Always think about the mucin deficiency. Now, if we will go to the test, what an important, our colleagues measure that breakup time is the easiest test that we have. It's a very easy, a lot of information that we can get from the breakup time before giving the patient any drop, any tear film. Tear film is, artificial tear film is all available. So the main question that we need to put it in our mind, which tear film according to the breakup time? So breakup time, Schirmer test, corneal staining. We might have corneal staining positive and breakup time borderline. So all these, it should be tear film osmolarity. See, I put tear film osmolarity at where the most for diagnostic imaging methods such as interferometry and meibomography. Now we have it, but many centers, they might not have it. But it's essential when we suspect the meibomian gland diseases. We can send him. They have a best, right? So, however, the presence of corneal and or conjunctival staining provide a valuable information to inform, to help characterization patients as evaporating or aqueous deficiency, but cannot predict which patient have clinical significant ocular surface inflammation. Now, meibomiography, clinical indicator for inflammation and direct correlate to level of inflammatory mediators and MMP9. Is it? Yes, it's important. The meibomiography correlate to moderate to severe dry eye. Now, inflammatory mediator, what we have available, I'm trying my best to have all of them, but it's very difficult, non-practical. You cannot put it in your clinic. The only MMP9. And MMP9, unfortunately, it's not a specific for a dry eye. It's a general. Any inflammatory disease in the cornea, in the eye can increase the MMP9. But MMP9 is helpful to follow the patient. When MMP9 start to reduce, this means that the inflammation which is the dry eye that we are considering and diagnosed, is improved. Okay. Now, that's the indicator for MMP9, and it's available in the market and easy to get it. Now I'm using it for another purpose, keratoconus. Very surprising. So all patients that have keratoconic, they have high MMP9. That's why now we are using the anti-inflammatory like Xiidra or Sandimmune as a treatment for the keratoconic. Now, treatment. Now, this is my job here. The MGD workshop recommended severity-based approach for the treatment, and I like this approach. It is important to first properly grade the level of MGD. It's not going directly to the new tools if we have it, because those tools can create some damage to the lid margin and if it's normal. So grading is very important. Level of MGD severity based on sign and symptoms and grade of MG secretion stage. So when we are staging 0 up to 4, in 0, all gland patent clear fluid is present, and in grade 1, 1 or 2 gland partially obstructed in grade 2, 3 or more partially obstructed grade 3, 1 or 2 blocked gland with main partially obstructed, 4 there 3 or more blocked gland. So in stage 1, warm compressor involving application of heat directly to the lid margin with the ultimate goal of melting the pathologically altered meibomian lipid. Warm compressor, which include increasing the temperature of lid with compressing to allow the altered meibomian to melt it by heat and released by compressed. 2, lid hygiene. Stage 2, all stage 1 addition to adding of omega-3 fatty. There is a lot of controversy, but I need to put it here because in this study they put it. In number 2 of stage 3, artificial tear. The artificial tear, it needs to be given according to the staging or according to the level or the breakup time. Breakup time normal, we can give sodium hyaluronate, but the breakup time not normal, below normal, we need to give accordingly because we have a lot of type of tear film, and one of it, they have lipid and carbomere or methylcellulose, so we need to give according to the breakup time. Topical and or antibiotic. Here, the topical azithromycin is the new issues, replacing the tetracycline or all derivatives of the tetracycline. And I like the azithromycin as my colleague like it, but it's very irritant. So what I'm doing is that I'm putting it on earbud, and I ask the patient to move it on the lid margin twice a day. That's more practical and less irritant to the as a drops, because if he'll use it as a drops, he'll use it once or twice and then he'll stop. Very irritant, but it's very effective. Believe me that for 1 week use it twice and for the other week use it once, and that's what's presented in this study. Stage 3 and 4, all treatment of stage 1, 2, and topical anti-inflammatory medications should also be considered, like Xiidra, liftigrast, and cyclosporine Restasis. Others I presented, and artificial tear, please take care about the breakup time and then use the proper artificial tear. Now, we have only eye protector that I'm using for all patients. It's an application, simple application in the iPhone, and there is in the Android, and that gives the patient a signal when he needs to blink every 20 minutes, 10 times, and that definitely it's helpful. Sure, it's helpful. Thank you very much.
Thank you very much, Dr. Safwan. Thank you, that's great. Next speaker is Dr. Sandeep Mitra. He will talk about inflammation and the dry eye disease. So you're changing your topic or what?
Thank you. Sorry for this because I think there was a confusion, and I'm going to talk about this premium IOL when you should not. I think the topic was changed for me. So anyway, let's go ahead and I will
Can
just
we talk
discuss
about
this
inflammation
topic, premium IOL when you should not. Now, the most important point when you are going to do a patient of premium IOL is to look at the personality of the patient. Ask him if they mind wearing glasses post-surgery. That's the first question you should ask. Or they are agreeable to IOL exchange if it doesn't work for them. Daily routine and need for a need-based approach. What they do, whether they are mostly desk worker or they are on the road most of the time, and then you decide the type of IOL you choose. Avoid people who are perfectionists. Again, night drivers and pilots and people who are on sales job require good stereopsis. Sometimes this treatment is not advisable. Spectacle independence is what you should advocate, not spectacle freedom. So they may still have to use glasses from time to time. Now, dry eye is probably the most important because that's the anterior most refractive surface of the eye. And I think you should do all the tests, whatever is available to you, to look into the wet, the aqueous layer, the mucus layer, and all the layers of the tear film. And what I do these days is we have the MS-39, which has a dynamic way of looking at the tear film. It's really, really very, very important. If you don't have, just taking a picture with your Placido disc keratometer will also give you a very good understanding of the tear film. Then treat the dry eyes vigorously before you even calculate the IOL power, because you may be putting wrong IOL power in these cases and you have disastrous result. Understand your options. You can choose different types of IOL. You have this anterior refractive, then posterior diffractive IOLs, and then extended depth of focus. So all of them will have some or other side effect, and you choose the IOL based on the need of the patient. Pupil size and angle kappa, again, is very important. Irregular pupils, ectopic pupils, you should not do, and large angle kappa should always be corrected when you are trying to focus these IOLs based on the visual axis. Fuchs dystrophy, so you must look at your endothelial layer. These patients don't do well with multifocal lens because it's a progressive disease, and over a period of time the cornea is going to get edematous and they will fail. Irregular corneas, again, this is a problem. Multifocal corneas you should not use, and especially keratoconus. So I had a patient where a multifocal lens was implanted in a keratoconus patient, and subsequently the patient kept on complaining, and the surgeon went ahead and broke the posterior capsule in order to improve the vision, and the vision did not improve. And then recently I did a DALC for the same lady, and thank God she improved her vision. So you must be very, very careful. Even in a patient of early keratoconus, implanting multifocal lens may not work at all. Corneal dystrophies, any anterior corneal problem, again, you should not use multifocal lens. Previous corneal excimer laser, it's controversial, but most of the time it's difficult to use because of the simple reason you may not get the target IOL power in these cases. If you want to go ahead and do in these patients, probably EDOF lenses are a better choice. Again, pterygium is better to remove that before you put a multifocal lens. Pseudoexfoliations and phacodonesis, again, these are two conditions where multifocal lens is very difficult and better to avoid them. Or if in case you have a vitreous capsular rupture during the procedure, it's better to avoid them in these cases. Patients have restricted visual field, either because of a glaucomatous disease or a neurological disease, you should not put premium IOLs. And of course, where there is a maculopathy, either because of age-related macular degeneration or, for example, he has an epiretinal membrane, you should avoid putting a multifocal lens. Thank you. And sorry for that, I was actually in the beginning informed about dry eyes and then it was changed. So.
No, sorry, no problem. We learned something anyway.
Thank
you very much for that. So the next talk will be Dr. Wasim Tropi. He will talk about diagnosis and monitoring of the dry disease, and the list getting longer and more expensive, I think. Is that right?
Indeed, yes. Thank you, Dr. Osama. Good afternoon, everyone. We know by now, and especially by the beginning of this session, that we are dealing with a disease which is multifactorial, complex, and there is no gold standard test in order to diagnose this disease, so there is no a silver bullet, and we need to deal with a basket of list of diagnosis, which is really, it's getting longer and longer every day. And here the question will rise. There is so many of those metrics. Which one do I need to adopt and in which order? And I'll try to help in fitting this into our practice, and I believe that depends on the level of dry eye practice that you have to adopt. There is 3 tiers of dry eye practice. Tier 1 is the basic care without new investment. Tier 2 is diagnostic device with more staff engagement, and Tier 3 is the dry eye center. In Tier 1, which means any eye clinic equipped with a slit lamp, you can do a great job with a small twist by adopting a small piece of paper, which is the questionnaire. It's very important. It establishes the diagnosis and it follows up the treatment. It highlights the most bothering symptom of the patient, and you don't have to rely on the patient-reported symptoms or change in symptoms in terms of follow-up. As Dr. Safwan mentioned, the simple testing, which is the fluorescein, you can get a very important information about 2 out of the 3 tear homeostasis marker, the tear breakup time, and the ocular surface stain. But it's very important to do it with care, how to implement the proper amount of the dye at a certain area of the conjunctiva in order not to disturb the tear film composition. With your slit lamp, you can do a great job with a special attention to the lid-ocular surface relationship. At this point, you can do the tear meniscus height to subtype your dry eye disease, and you can keep the Schirmer test to confirm, for example, Jokeren disease or so, and you can look at the lid margin where you can see if there is any conjunctivochalasis. I recommend for the lid margin a special attention to use the LLPP technique recommended by the ESCRS pre-op algorithm. Look to the blink pattern, lid closure, lashes, lid margin telangiectasia, and the meibomian gland orifices. Lift the upper lid, examine the superior eye surface, pull the lid, check for lid laxity, and the most important thing is to evaluate meibomian gland dysfunction. In this regard, I'd recommend to use the meibomian gland evaluator, which is a small device that applies a pressure at the lid margin, which is equal to the force to the normal blink of the eye, which is 1 gram per square millimeter, and grade the MEOM, which is the liquid that's coming out of those glands from clear to turbid to opaque to solid. How we combine this with this video, as you can see here at the left side, the MGE challenges in each pass 5 glands by applying the proper pressure, amount of pressure. You count how many glands are functioning, you grade the MEOM, and you get up the score, which is gland count times MEOM grade, and you get meibomian gland score. Here to differentiate, if you will do it with your finger, you may apply more pressure than it should be in order to have the proper grading. With the great attention to the neurotrophic keratitis, the corneal sensitivity is very important to assess, and you can do it with a cotton-tipped applicator. Like this, you can document the corneal sensitivity. You can do a lot of good in this regard in the treatment, but it's not the subject now for this presentation. In Tier 2 practice, where you have to adopt more diagnostic devices and your staff gets more engaged, at this level, you should start to adopt the point-of-care test advised by the DUCE 2 report. The osmolarity, lots of debate has happened, but what I consider osmolarity, I consider it similar to the intraocular pressure in glaucoma, so it's like a trend. You check your osmolarity, and with the treatment, you can see if your treatment is successful or not. It's the 3rd tier homeostasis marker. The MMP9 to check for inflammation, definitely it's not for the establishing the diagnosis. It helps to manage your patients, which one requires long-term anti-inflammatory treatment. And it's very important, as you can see at the lower picture there, before and after treatment, how you are improving the patient. And at the same time, it develops the habit of looking for inflammation, which is important in my opinion. At this level, you can adopt as well the meibography. Meibography is an excellent tool to educate the patient like this. They will get convinced and they will get more engaged in the treatment. Some devices, they are equipped with the Placido test disc that will give you the non-invasive tear breakup time. Again, there are new devices that can evaluate the corneal sensitivity, either contact or non-contact, that you can adopt at this stage as well. With a digital camera mounted on your slit lamp, you can take an excellent pictures for your treatment, as you can see before and after the treatment of blepharitis, or cool videos like peeling a Demodex mite from the roots of the lashes, as you can see there. Definitely more advanced treatment should be introduced at this stage as well. And the tier 3 practice is basically the dry eye center, where you should have more sophisticated devices in order to check, for example, the lipid layer thickness, like interferometry, or the light scatter, like the HD analyzer. At this stage, you should offer the full range of surgical and in-office procedure and treatment for dry eye disease. Your staff should be engaged more in the treatment of this disease, and your threshold to adopt new techniques and to establish your own nomogram should be low as well. The take-home message: no matter what type of dry eye practice you are doing, metrics should be adopted up to the level of your practice. Remember, dry eye is multifactorial and complex. There is no single golden test to diagnose the disease. And in terms of test sequence, you should start with the less invasive and onward. I believe I am on time, right?
Thank you very much. We had 1 minute also. So any question for you for this 1 minute? You have to come back. Do you face a patient with osmolarity normal and had a dry eye?
Do I face?
Yes.
Actually, from my experience, lots of the patients that I diagnose with dry eye disease, I do have tear lab since 3 years now, and most of them, they do have a normal osmolarity test.
But when is normal? What do you tell the patient?
When
it's
it's
normal osmolarity and you did the test, good test, help me to reach diagnosis and it's normal.
You mean with the treatment?
No, the patient you did the osmolarity is normal.
Okay.
But definitely this is had dry eye. What you tell the
You
patient?
have
Because he spent the money, you know.
Actually, you know, for the cash patient, I don't charge them for the osmolarity.
That I do agree fully that osmolarity can be normal because what we have is only myosin deficiency that will not change.
I agree with you, 100%, yes.
But because of the MGD, we have because of the instability of the tear
film,
cornea,
yes, yeah.
we have a sign and symptoms of.
And actually, it's not one-time osmolarity that defines, in my opinion. You should repeat it.
For sure.
And definitely, there is certain circumstances where the patient should be free of eye drops 2 hours before, blink twice, take it in the proper place. So, there is lots of really factors plays a role. It's the same as the stain. If you put plenty of fluorescein, everything will go messy, and you will not be able to get the proper results.
You have a normal osmolarity, and they are symptomatic. You can see that the artificial tear is only sodium hyaluronate.
Okay, thank you.
Thank you, Dr. Wasim. And next speaker, we would like to call Dr. Muhammad Ahmed. He's here with us. And actually, a discussion for tears and dry eyes is forever, actually.
Assalamu alaikum. I just want to comment regarding Dr. Usama's question. Actually, the normal numbers for the tear osmolarity is 280. So up to 300, we consider it within normal range. But having a difference between the two eyes more than 10, let's say one is 284, the other one is 298, along plus with signs or symptoms, we can check it under slit lamp. This can confirm the dry eye diagnosis, regardless from should be high numbers. Of course, when there is high numbers, then we should think about something more severe pathology is there.
That's different. I'm using for 7 years now, okay, osmolarity. So I have this 280, 285, and still is dry eye. So sorry, this is and the patient charge for it, okay? Sometimes insurance covered, but we're facing this problem. But anyway, we
it's
have
one of the
So
indicators.
we can start your secret, okay?
Okay. Good afternoon. Today we will widen the scope a little bit about the dry eye disease and going to the ocular surface disease. Sorry. Yeah. Well, ocular surface is a very delicate and complicated world, I would say. It includes a lot of things, including cornea, lacrimal glands, mucosal membranes, eyelid margins, lipid layers, a lot of things. So dealing with it sometimes is very straightforward, easy, and sometimes it's difficult to understand and manage. And today we will try to have a look about how we implement. I would like to thank my colleagues, Dr. Wasim, to highlight a lot of the instruments we are using. And I hope that we can have an idea how we can use these instruments in the clinical practice today. So as we see, we have a variety and different level of cases here, and we need to look carefully in some of the complicated cases. That's why, as usual, we start by our clinical approach by history, taking all the needed points, and we can go to the symptoms, variety of symptoms, itching, irritation, and a lot of findings. We can find it under a slit lamp, which help us reaching here. Of course, we have 3 different algorithms to use when in the ocular surface disease. The first one, the straightforward one, we all know the DAOS-2 treatment plan, which having these 4 stages. Or we can go, in this, we are focusing on the vesicular circle of dry eye, and each point of pathology needs a special management. Or we can go more focused to the American Academy concept of point of care, where we use a lot of machines like the tearosmolarity test, inflammation markers, and automated meniscus tear film measurement, which is ocular surface analyzer. We can use this in picking up those special cases where we need to take care of and avoid the complication we have mentioned this afternoon with Dr. Nancy in improving the ocular surface before going for refractive or cataract surgery. But the most interesting thing and the most practical approach I would consider is the classification of the cornea external disease and refractive society, which is the dysfunctional tear film syndrome. This new concept defined or classified the dry eye in 4 main categories: aqueous deficiency, blepharitis, evaporative, and exposure keratopathy. And here the interesting point of view, it sets up the concept of co-conspirators, which is a condition that mimic dry eye syndrome, and it has some different pathology, like allergic keratoconjunctivitis, superior limbic keratoconjunctivitis, conjunctival chalasis, and Thygson superficial keratopathy, and medicamentosa. So this might be one of the answers for the question of Dr. Usama, why we can see the same symptoms, but with normal osmolarity. Now, if we have a common factor which combined all of these, I would say the secret word here is inflammation. We need to look for the inflammation. And why the inflammation? Because the inflammation is destabilized the ocular surface environment. The tear film instability leads to ocular surface damage, and this vesicular circle which we all need to spot and break at some point. So as we see here, inflammation change the instability, making ocular surface damage, changing the hyperosmolarity, and the circle going on. So it was recently demonstrated, or maybe years ago, that T cells mediated inflammation have a very crucial role in this vesicular circle. So for this reason, we can see how we can apply this in one simple clinical case. Male, 35-year-old, have redness, irritation, have some atopic structure, here the key word. He's using different medication without improvement. By evaluating it, we can find 2 main things: mild, moderate MGD, and there is also some partial lacrimal punctum stenosis at the lower eyelid, which is quite common and difficult to manage in the clinical practice. So we can go, the tearosmolarity in this case was high, 323 and 313. MBB9 test was weak positive. So this is the tear ocular surface analyzer for these patients. Although he has some functional tear film, but still the lipid layer is affected, and the most crucial the tear meniscus layer or the watery layer is affected. So the treatment, depending on, of course, we have the three main pathologies has been spotted here. We need to target our treatment to the MGD, vernal keratoconjunctivitis, and the dry eye syndrome. We start by patient education, good eyelid hygiene, avoid allergens, and local control of the immune system. Here we have a couple of agents, Gentadexa, Aziter, Lubricant, Zydra, and Tobradex. The patients start to improve, and afterwards we taper the steroids and continue with the immunomodulator, and which is stabilize the case. So that's when we look carefully why the immunomodulator has played the trick in this case, because when we control the T cells, we break up the recurrent loop, because the T cells have some recurrent loop by going to the adenolymphocytes and recruiting more T cells and more inflammation. So that's how this loop is working on. Now, this is how that Zydra TEM anti-CAM1 inhibitor. In this other case, clinical case 2, that 56-year-old lady has mild signs of dry eye, diagnosed with dry eye, treated properly, have some good eyelid hygiene. But the interesting thing is that after initial improvement, she came back after 2 years after doing some PRK surgery. So that PRK surgery has broken out the balance in the ocular surface here, and the patients start to complain again, and we gone through also we can see the osmolarity here has changed, and there is serious pathology has developed, and we need to also address all the kind of pathologies. We can see the blepharitis, we can see the stenosis of the lacrimal punctum. The management, we have used multiple of antibiotics, steroids, and immunomodulators to increase or to control the case. The real-world study, this is a real-world study about immunomodulators system, which included 600 patients, and it showed that, interestingly, apart from improving the signs of the dry eye disease, I would like to see this. It decreases the use of the steroids, the lid hygiene, and a lot of things. That final case, it is a contact user. In this case, the origin of the pathology and the inflammation was the contact lens, which has been destroyed the limbal stem barrier and causing this overlapping between the conjunctival epithelium and the corneal epithelium. And then we have to go through different management, part of it by removing the epithelium, and the other part by giving some medications. In order, we have to go through different modalities of management in order to control the case and finally get a good result. So the take-home message is that look for the inflammation in any complicated case you are facing, and use your armstrong and use your weapons carefully, because the clinical management is an art rather than a science. Thank you very much.
Thank you very much.
أنا والدكتور صفوان عندنا اعتراض على حاجة واحدة. التوبراميسين is enemy number 1 to ocular surface in general.
Yes.
Actually, in Egypt, we are lucky enough to have the azithromycin eye drops currently, and الحقيقة هي ثمنها حتى 30 سنت.
Yes.
يعني
أقل
من نص دولار والله.
I will go back by the slide. You see that I put azithromycin as the antibiotic.
Yes.
But the problem, we don't have ointment including dexamethasone alone anyway. Yeah. So that's why I have to go for Tobradex.
Tobramycin is the Maxitrol. That's another alternative, Dr. Muhammad.
Yes.
Tobramycin enemy number 1. enemy number 1 يعني.
Yes. I do agree.
لكن احنا مش معترضين ان يعني على steroid in general، بس هو this is يعني one of the enemies of ocular surface. بس احنا مش عايزين نخوض في كده، لكن انا اقدر دكتور يعني يمكن انا كنت لسه هسال الدكتور اشرف ارميه على موضوع الازيثروميسين. احنا بقى لنا 3-4 سنين معانا الساينارو في مصر، ومن ساعه ما جه الساينارو بقى one of the tools. يعني azithromycin topical eye drops.
I mentioned in all the clinical cases.
You use it?
Yes.
Yeah,
it was mentioned there. I can go.
You like it?
Please go back to the.
No. We agree. We just agree with you in this.
لما بتدور لما على الصيدليه عندنا ما في عندنا هون pure steroids as dexamethasone. That's why you have to go to combination, either Tobradex or Maxitrol.
Maxitrol is much more relevant to the patient.
But the neomycin causing also, Dr. Safwan, causing.
I do agree, but much less than
Tobramycin, Dr. Muhammad, يعني believe me.
we should ask our pharma company
yes.
here to provide.
Okay. Thank you, Dr. Muhammad Basha, and we go for the next speaker, Dr. Sharif Amara. Dr. Amara will speak about optimizing the ocular surface disease before and after. حقيقة عنوان very شيق جدا دكتور عمارة، اتفضل.
Good afternoon, everybody, and first I would like to thank the organizing committee for organizing this very important conference. Today I'm going to talk about optimizing the ocular surface for before and after surgery. Okay. Any ocular surface disease, most commonly dry eye disease, can introduce visual quality and quantity and adversely affect the refractive measurement before keratorefractive and phaco-refractive surgery. In addition, ocular surgery can exacerbate or induce ocular surface disease, leading to worsening vision and increased symptoms. The impact of dry eye disease and ocular surface disease on topography and biometry and keratometry and high-order aberration is one of the major causes of disappointing post-operative outcome, and corneal surface irregularities can lead to inaccurate IOL measurement and axis calculation. Failure to evaluate and treat dry eye disease before the surgery can lead to unsatisfactory vision, new or worsened ocular surface disease symptoms, and post-operative infection. In one study, upward to 60% of the routine cataract patients were asymptomatic for dry eye disease, and yet 50% had central corneal staining. Gupta and his colleagues report that at least one abnormal ocular surface tear test and in 80% of patients undergoing cataract surgery, while 40% of them had at least two abnormal tear tests. Also for dry eye disease, more than 50% are contact lens wearer, and this causing dryness and many patients who seek LASIK surgery. Many patients who seek LASIK surgery cannot tolerate contact lens because of the pre-existing dry eye, and the incidence of post-LASIK dry eye ranged from 8 to 48% based on symptoms or signs. And one of the main cause of the unsatisfactory visual outcome and regression after surgery of refractive surgery is the pre-existing dry eye. So how to treat the patient of dry eye before the surgery? So we have an old algorithm for dry eye. This is a normal, and the ASCRS Cornea Clinical Committee, they developed an ASCRS preoperative, which is specifically for the preoperative patients. Okay, and we have here the screening is composed of three components. First, the symptoms, the questionnaire, and two tests, the osmolarity and the inflammatory marker, which is MMP9. We have a different questionnaire for the normal, for the regular dry eye patients. We have the speed, the DEQ, the OSDI. This ASCRS committee developed a new speed 2 questionnaire specifically for the dry eye and preoperative evaluation and diagnosis of patients. We have the difference that they add some specific questions for using lubrication or no, for fluctuation of vision, specific for some infections like blepharitis, like STI, and they have the same score as the old Speed 1 questionnaire. So they are for the screening, we have the questionnaire, and then the two components, which is the tear osmolarity and the MMP9 test. And if the patient is negative for all these components, they are considering, according to the recommendation, they are considering this normal patient and he can proceed for the surgery. And if the patient has abnormal component for any one of them, they consider this abnormal and we need to go for further evaluation and diagnosis and subtypes. So the visual significant OSD via multiple potential mechanisms lead to reduced visual quality and potential error. So for the clinical committee, they are recommending to use a non-invasive test to further evaluate the condition. So, but we can use anything. We have a lot of devices using for the non-invasive tear film evaluation. And we can go also for the fluorescein staining, which can stain the cornea, and we can check also for the tear breakup time, use rose bengal and Leishman green staining. At this point, we can evaluate and we can subtype the dry eye patient. So we can subtype this or divide the patient into non-visually significant OSD or visually significant VSD. The non-visually significant OSD, the early preclinical dry eye syndrome, conjunctival chalesis or pinguicula, and for the visually significant OSD, we have the patient has corneal staining, neurotrophic or exposure keratitis, infection or irregular astigmatism. For the treatment of non-visually significant dry eye syndrome, we can proceed for the surgery, but we have to counseling the patient and we tell him that he needs preoperative and postoperative treatment. But for the visually significant dry eye syndrome, we have to postpone the surgery. No rule for the monotherapy. We don't have time to give the patient a tear substitute and then to evaluate the condition and to need to add another medication. So we start for the combination of procedure. And at each follow-up, the algorithm should be repeated. And when it's moved from visually significant to non-visually significant, at that time we can proceed for the surgery. And even for the treatment, no rule for the step 1. We go direct to the step 2, and we can use also non-inflammatory, like we can use some topical steroid, like fluorometholone or loteprednisolone, and you can use it for 4 times a day for 4 weeks. Cyclosporin and Xiidra also play a very important role in treating the patient preoperatively. And we can see your oral antibiotics like azithromycin and vibramycin also play a very important role for treating any blepharitis and improve the ocular surface before the surgery. Lid margin disease, we have to address 2 important issues. The lid margin disease, which is a blepharitis and affecting the vision. We have different devices that can improve this condition. And the treatment also for surface staining. The corneal staining is a very important issue for treated before the surgery because it's affecting the pre and post-operative results. We can use topical autologous serum, and you can use also the self-retaining amniotic membrane. Punctal plugs definitely plays a very important role also for treating dry eye preoperatively, and nutrition like omega-3 also play a role in this one. Thank you so much.
We'd like to call our dear colleague, Professor Ihab Saad from Cairo University. He picked up the toughest part of ocular surface disease, which is the severe ocular surface disease. الحقيقة المحاضرات النهاردة جبارة كلها جميلة جدا، وواضح ان هي الissue of the day، لان احنا يعني for a lot of reasons الناس العواجيز اللي زيي من اللي بيعملوا براكتس من الثمانينات، في الثمانينات كنا بنكتب مرة أو 2 قطرة دموع صناعية، كان مفيش غير نوع واحد artificial tears أو يمكن 2 بالكتير. النهاردة شوفوا كم مرة أنت بتكتب tear substitute وأجهزة diagnosis وأجهزة treatment يا دكتور وسيم، حاجات يعني من 35 سنة يا دكتور وسيم الكلام ده ما كانش موجود يعني. فده بسبب حاجة أنا العيانين دايما بيسألوني ليه إحنا الدنيا اتغيرت جدا. سببين أساسيين. من 35 سنة التلفزيون المصري كان فيه القناة الأولى والقناة الثانية، وكان بنقفل الساعة 12 بالليل، يحصل السلام القرآن وبعد كده السلام الجمهوري وبعد كده يحصل مفيش إرسال. No emission after 12 p.m. في سنة التسعينات 90s ابتدى يظهر الدش ده الساتلايت. So there is more and more channels of television. بعد كده سنة 2000 ظهر اللابتوب، واللابتوب ده يعني very temptative بالنسبة للناس، كمبيوتر شايله على حجره واخده في أي حتة بيشتغل بيعمل. وابتدت البرزنتيشنز كلها على اللابتوب، والناس مغرمه باللابتوب، والصور بقت ديجيتال والناس توري بعض الصور على اللابتوب. في 2020 ما فيش واحد ماشي في الشارع او واحد ماشي في الدنيا في الارض ده من غير سمارت فون، وبيصور وبيلعب على الفيسبوك وبيحرك. فده التطور اللي حصل في ال 35 سنه. هي صحيح في كلايمت تشينج، لكن الكلايمت تشينج ده انا كبراكتيشنر في مصر مش حاسه، لان احنا جونا زي ما هو. مش عايز اقول لك ان يمكن احسن من الاول كمان. يعني القاهره في الثمانينات جوها كان اسوأ من الايام دي. لكن انا كان ليا الحظ ان انا اعيش 7 8 سنين في اسبانيا متواصله. اسبانيا تصحرت في الدكتور ايهاب، انا كنت بسليكوا شويه. اتفضل يا دكتور ايهاب.
Thank you very much, Dr. Mahmoud. Well, I was very apprehensively listening to the dry eye. I'm actually the ambassador for the TFOS Society in Egypt with my friend Mohammed Shafiq. And I'm saying, you guys are just, like, maybe you're joking around. Are we? Like, I will show you the serious disease and how we deal. No drops at all. We don't have machines. We don't have IPLs. And sometimes we have to innovate. We have to be creative in this other realm of disease. So the limbal stem cells are in essence in keeping the surface integrity of the eye. They are present at the palisade of Vogt around the limbus. And as you know, the cornea is formed of epithelial surface ectoderm and stroma coming from the neural crest. And the stem cells are residing in both layers. The stem cells are known to have an asymmetric division. They have a long lifetime because of the asymmetric division, and then they do have a terminally lack of differentiation. So we cannot say this is a stem cell coming from fat or coming from bone or anything else. The niche or the milieu where the stem cells are is within the limbus. The stem cells are present within the basal cells. They go into transient amplifying cells and then postmitotic cells and terminally differentiated cells, both on the corneal surface and within the cornea itself. For me, I deal with limbal stem cell deficiency, which can be of two reasons. One of them is the destructive loss of the limbal stem cells, commonly seen in chemical injury of the ocular surface, among other pathologies. And as you know, the alkali burn goes deep and penetrates into the anterior chamber and has a very destructive effect on the ocular surface, while the acid burn just coagulate onto the surface. And we have to really decrease immediately the burden of the alkali or the acid burn. We cannot measure osmolarity in such instances. We have to be swift and rapid in diluting the damaging effect, and we should fight phagocytosis and decrease the collagenase activity. This is the whole idea about the treatment of chemical injuries, to avoid such drastic complications where the whitening that is present around the limbus here indicates severe stem cell deficiency and a burnt out eye in this monophthalmic patient, or more severe complication like the fibrosis, the symblephera, the creeping on the conjunctiva, the conjunctivalization of the cornea that is really bad. So this is number one. Number two reason of severe stem cell deficiency is the dysfunction of the limbal stromal microenvironment. We see this in elderly aniridic patients. Those patients with aniridia, when we see them young, the surface is wet and they're doing okay. But as they grow older, they develop a very resistant type of dry eye with corneal opacities, the neurotrophic keratopathies, and the keratopathies associated with men along other diseases. The hallmark of limbal stem cell deficiency is the conjunctivalization of the cornea, among other signs of mucin or lipid deficiency, as you can see. We have to have a clear treatment algorithm to deal with those severe diseases. For instance, the otolimbal transplant. The otolimbal transplant can be from, we can think about in the realm of severe ocular surface disease. We see this kind of diseases in Egypt where the 270 degree of the limbus is occupied and infiltrated by a squamous cell carcinoma. This is an infiltrating squamous cell carcinoma. You can see that on the UBM and the anterior segment OCT. Note that there is a plane of less density between the mass and the cornea. And I think this is of great importance. What we should do in those cases is to proceed with surgery. And the idea is to be conservative, not to do an enucleation or a modified excenteration. We take a safety margin on those disease, on the surface squamous neoplasia. And I just thought about the UBM and the OCT anterior segment of this dark line between the mass and the corneal epithelium. And it turned out to be a plane of cleavage, which is really nice, We use the non-touch technique. We just hold the mass with one hand at one point that is clear of tumor, and we don't move this hand a lot. Mostly blunt dissection, very unusual to go to sharp dissection. And as you see, the tumor is coming out bit by bit. We do cryo, and to the very best of our luck, the epithelium at this instance was intact. So now we're dealing with a 270 degrees or more stem cell deficiency, right? Tumor has gone. I took an autolimbal graft from the other eye. I put it on top after cleaning and removing the tumor en bloc in totality. And then I covered this with an amniotic membrane. And you can see the result at 1 year of time. This is a very healthy ocular surface, disease-free, and we just made it. So when you have an invasion of the ocular surface with a severe ocular surface neoplasia, like the carcinoma this in situ or the squamous cell carcinoma, in here there is really no plane of cleavage, and the tumor is invading the anterior surface of the eye. Think about mitomycin. After 3 cycles, everything is gone. And it's gone persistently over the years. We've been following this gentleman for 3 years. This is the concentration of mitomycin and the regimen we've been using in treating those conditions. We don't mind using lubricant and some steroid along that as well, because it's a bit of a toxic, it has toxic effect. We don't have interferon alpha 2b anymore, and the results are really good in ocular surface squamous neoplasia. So what if you don't have squamous cells? What if you don't have stem cells? In those instances, in chemical burn affecting both eyes, we take maybe from the other eye or from the next of kin, the first degree relative, a little bit of the stem cell niche present at the limbal stem cells. It's a simple procedure. We don't have to do deep keratectomy. We don't have to do a sclerectomy. They are sitting there waiting for us. The pathologist, the cell biologist I'm dealing with could differentiate and identify the stem cells from each other, and that's it. This is the allograft, and she cuts it onto the amniotic membrane. The niche here is extremely important, the corneal epithelial growth factor. You can see the cells are outgrowing, and she was excited to have a multi-layer goblet cells along epithelial cells differentiate conjunctival from the corneal cells on the amniotic membrane before going back and inserting it on the ocular surface of such patient. I will skip the video because of time. And after removing the adhesion, we can go back one more time and do our keratoplasty along with your cataract surgery in a very healthy environment of the ocular surface. I always say we cannot put a seed in a dry land, so we cannot do a keratoplasty also in a dry eye. So the cataract is done, IOL is implanted, and the surgery is finished. So this is how we restore vision. So we all know that subsequent grafting is doomed to fail in high-risk patient. We've been introducing the Boston K-Pro in Egypt in 2010. This is formed of a central front plate, a cornea, and the back plate. And we've published about the 8 years follow-up of about 63 patients in the Saudi Journal of Ophthalmology. This is a free access. This is how we assemble the Boston keratoprothesis, the type 1. The central plate we place the cornea on top of it and the back plate. The back plate now is titanium, and we've inserted the ring. And the complex is useful in extreme cases. This gentleman was presented at the age of 14. His left eye is the no light perception eye. His right eye, he sees something out of his right eye, and he's feeling the light. So the decision, he had also a coloboma in the back of the eye. The UBM was very useful because the lady who did the UBM mentioned about the white-to-white junction of 9 millimeter. In here, it's super difficult to identify the limbus. The limbus is non-identifiable by transillumination by all means. And here the idea is where to put my trephine. How shall I be centralized on the center of the cornea to be able to put the Boston Kipru? There was no way except what Dr. Hala Shweikh mentioned about the 9 millimeter. I measured 9 millimeters, centered about the cornea, and I say, well, this is my plane of cleavage. A 7 millimeter trephination was done, and I was looking outside the microscope to see if I'm centered or not. Because if I wasn't centered, I'll just close it and come another day. The lens was, the cornea was removed, the lens was removed, and then the K-Pro was put in position, went for vitrectomy, coloboma, did some laser to ensure that everything is fine, and the patient restored ambulatory vision. And he's still, for the next 8 years, doing fine. And we use this for chemical burn, for severe ocular surface disease. And this was the happiness of one's life when a 4-year-old that had repeated keratoplasty on a second day after the Boston K-Pro, where the definition of visual agnosia for the first time, I could understand it. This child is seeing for the first time at age 4. Whatever he sees, he doesn't understand, but he can identify and recognize. So the teddy bear doctor is something interesting for him. And he goes for things. And you see, I was much younger at the time. I could sit on the floor with the kid. So happy to be able to help him. He was taken by the light. Actually, this was like a moment where everything was explored by this seeing eye. And you can see here, he was moving his fingers like me, first time in his life, in 4 years' time. And he was reaching for the sweets, and he was reaching for his mom's face to identify while looking at her. Are you really my mom? Is this you? Can I recognize you by being able to see you now or not? I mean, this was an amazing moment in our lifetime. And this is the real compensation for us. Nobody else would feel the happiness of changing one's life as we do. So in 1 hour, I'll be giving the oncology course. So guys, come and join me in Hall C. And I would like, the pathology book, I have a pathology book online that is narrated, video-based at the Eye Academy YouTube site. It's free for anyone who wants to go through. It's like 3,000 picture and 300 animation, all available for you. Very useful for teaching education. It goes in depth into the information. I'm also, being the vice president of MEOM, would like to invite you next month for Muscat meeting by the end of the month in the beautiful Omani city, where we'll have a lot of fun mixed with pleasure. I'd like to thank you, the organizing committee, for the generous invitation, and really happy to see friends from all over the world. Thank you.
I think we have to move, and thank you دكتور إيهاب. الحقيقة الفيديو بتاع الطفل الصغير very emotive, يعني very emotional يعني. شكرا. دكتور إيهاب. دكتور وسيم اتفضل.
you very much. Thank you.
Good afternoon, everyone. We will start the ROP session. Those who are interested in ROP are welcome to this session. So we will start with the epidemiology of visual impairment in neurodevelopmental disorders, and we will have the update in ROP classification and treatments, laser, anti-VEGF, and surgical treatment, and we will end up with adult and cicatricial ROP. So the first speaker is Usha Yohare. Could you please come to the stage, Yoha? Usha? Are you here? If not, then maybe we can continue with the second one, update in ROP classification by Prasan Raho. Thank you.
Thank you, Dr. Shengul and Dr. Suzanne. Actually, it's my honor to present update on ROP classification in front of you because Dr. Shengul has been part of one of the IC-ROP committee, and it's my pleasure to actually present, and I need her inputs as well on this. So the IC-ROP third edition was done in about 2 years back. And there was a need for revising the older IC-ROP, and the reason being the advent of anti-VEGF therapies and ocular imaging. So nowadays the trend has been to use anti-VEGF in a lot of patients with ROP. And the things of post-anti-VEGF, like for example regression, reactivation, and certain things needed to be redefined, as well as the role of ocular imaging. So these are the 7 points which basically are of importance in IC-ROP third edition. The committee actually described the role of intermediate zone or posterior zone 2 and also defined the presence of a notch. They classified or redefined anterior aggressive posterior ROP as aggressive ROP. They also looked at ROP regression, ROP reactivation, especially after anti-VEGF therapy, and then categorized stage 5 in a more clinical manner, and lastly defined the presence of peripheral persistent avascular retina and vascular anomalies. And last but not the least, the importance of plus disease. So let's look at these one by one. So what is the intermediate zone or the posterior zone 2 and the notch? So posterior zone 2 begins at the margin between zone 1 and zone 2 and extends into the zone 2 for 2 disc diameters. So how is this going to change? Because now our diagrams will have to include this small area beyond zone 1. And this is of importance because the severity of the disease is worse in these eyes. Next, the committee also described the entity as notch, which is incursion by an ROP lesion of 1 to 2 clock hours along the horizontal meridia into the more posterior zone than the remainder of the retinopathy. And why is this important? Because when you have a notch, you need to classify the disease in a different manner. You have to record it as the most posterior zone with a qualifier saying it's secondary to a notch. So bottom you see this example where there's a notch which is extending into zone 1, and that's why you call it zone 1 secondary to a notch. This again signifies a most posterior disease here. We know AP-ROP was classified in 2005. However, AP-ROP initially was described in extreme premature babies having predominant involvement of the posterior zone, posterior zones. However, aggressive ROP is also seen in other regions with limited resources, and especially with larger babies, and they need not involve the posterior portion of the retina. Hence, there was a reclassification, and now the term used is known as aggressive ROP or AROP. But the key diagnostic features of these are the tempo of disease, the rapidity of which the disease progresses to zone 3, which is basically a flat diffuse neovascularization, and also the appearance of a severe plus disease. So this is one thing we need to understand. We no longer call this as APROP, we call it AROP. This is an example of one of my patients with APROP. So what is ROP reactivation? Now we know that there are certain signs of reactivation which might range from a self-limiting demarcation line to reactivated stage 3 with plus disease. And these are more common after the anti-VEGF use, unlike in spontaneous or post-laser patients. And these are, on the right, you see all the examples of reactivation. The reactivation, importantly, we need to understand, may or may not follow the normal sequence of stages. That means may not present from stage 1 to stage 2, stage 3. The other thing we also need to know is that the neovascularization can occur at the site of the previous ridge or at the site where there's progressing vascularization, or sometimes you might also notice it in the rest of the retina. So you have to be extremely careful, not only to look at the peripheral part where the vascularization is progressing, but also at the site of the original ridge. Normally you'll see recurrent vascular dilatation or tortuosity, which is similar to acute phase pre-plus or plus disease. Extraretinal neovascularization, as I mentioned, can vary in the source, location, but also they are much more delicate. So you have to be really careful and look out for these extraretinal proliferation, because they may not be the classic ones which you see in acute phase ROP. And lastly, hemorrhages can be seen around these fronts in extraretinal vessels. These extraretinal vessels may eventually lead to fibrovascular proliferation and the complications of fibrosis, traction, and TRDs. There has been a categorization of stage 5 ROP. In the past, it was based on the configuration of the retinal detachment as to whether it was open, 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 closed, closed, open, or closed, closed. And sometimes if you would not see, you would do an ultrasound. But the current trend is to now look at retinal detachments on clinical exams. So we have stage 5A, where the optic disc is visible by the ophthalmoscopic exam, like in the picture A over here. 5B is where you have the lateral-ventral fibrovascular tissue, which precludes visualization of the posterior retina, but a funnel detachment is present, like in B here. And lastly, it is known as stage 5C, whereas 5C would include 5B with complications of the anterior segment. And these include shallow anterior chamber, anterior displacement of the iris lens complex, iridocorneal lenticular adhesions, corneal opacities, and also sometimes subretinal echoes on B scan. It's important for us to understand this because this would help us to classify stage 5 and also have probably more clinical importance in future studies. What about peripheral avascular retina and vascular anomalies? We know avascular retina may develop in eyes which have undergone either spontaneous regression of the ROP or post anti-VEGF injections, and these avascular retinas are prone to retinal thinning, holes, lattice degeneration, and may be associated with retinal detachment later in life. So we always say that ROP is a lifelong disease for patients who have this kind of a condition. Retinal vascular changes can include persistent tortuosity, straightening of the vascular arcade with macular dragging. Sometimes you get a falciform fold, also get circumferential interconnecting vascular arcades and telangiectatic vessels here. Lastly, plus disease. Now, we know previously we had in classification as no plus and plus, then later on the term was introduced as pre-plus. It's important for us to recognize pre-plus and plus disease, though, as it reflects a continuous spectrum of vascular anomalies. Plus disease spectrum needs to be determined from the vessels within the zone 1 rather than only vessels within the field of a narrow angle photograph, and rather than the number of quadrants of abnormality. And in the past, the original ICROP description was vascular enlargement of the iris, pure pupillary dilatation, peripheral vascular engorgement, and vitreous haze. These are important, but they may not be used. They may not be necessary for the diagnosis of plus disease. So to summarize, these are the 7 points I want you to remember, and this is helpful for us to examine our patients. Intermediate zone or posterior zone 2 with a notch, and aggressive ROP, ROP regression patterns, ROP reactivation, stage 5 categorization, persistent avascular retina and vascular anomalies, and lastly, plus disease spectrum. With that, thank you very much for your kind attention.
presentation. This ICROP 3, this third revision of ICROP, is based on experience. I mean, it's not just theoretical, but it was incorporating things that already we were using in our clinic.
Absolutely.
And it's very nice because it gives us a common language, but a very practical common language. That's why ICROP 3 is very important. So I don't know. I think one of the things that most impacted me was stage 5. That guide us a little bit about the use of the surgery, or the indications, the timing of the surgery, and the indications of the surgery. So guide us a little bit in that field. So I like very much the incorporation of these subtitles of stage 5.
So thank you for summarizing the ICROP 3 for us. Actually, as Susanna told, it's not an evidence-based thing, but you know, evidence-based medicine is not everywhere. So sometimes we need the experience.
Experience-based.
And
yeah.
This is just for classification, of course, not for the treatment and for the you know, other things. So we need to do, of course, studies for the treatment, but when we are talking about stage 5, and I was the one who suggested to do the subclassification of the stage 5, most of the friends from the west part of the world said that there's no need for that because, you know, we don't see stage 5 much. So then in this part of the world, I mean, in the middle-income countries, we see still quite a lot of stage 5 cases, and the surgical outcome is very different between stage 5A, B, and C.
Yeah.
So that's why I think it differs a lot. Thank you
Thank
for
you.
the
Thank
next
you.
talk.
Thank you.
So we can now continue with the next talk, which is the laser versus anti-VEGF treatment in ROP by Hassan Hashid.
Assalamu alaikum, good evening. Thank you, Dr. Rashangul, Dr. Suzanne. Yes, I will present, no financial disclosure. This slide is summarizing the ROB history. Keep adding the recent, you can see all the randomized controlled studies, the ICROP classifications, and before it was really debate, this versus laser anti-VEGF, but with this approval from the EMA for the ranibizumab and recently for the FDA, and even just a few months back we was waiting the 5 years report from the Rainbow study. So I think that in the last 2 decades that the first decade was for the laser ablation, and now we are on the anti-VEGF. So as you say that the Europeans already approved the Lucentis injection for the ROB in all stage, excluding the stage 2, zone 2 plus, because it was this debate in the ETROB study about this level, but in the Flibbercept and the FDA already included, so it can be used. So the rule of the laser, from my point of view, maybe it will be wrong, correct. It's principle, but complementary for the anti-VEGF, according to the evidence which we have it now in our hand. So if you go for the ablation, what the outcomes, so that's unfavorable outcome. If the patient has posterior location disease, plus disease, aggressive ROB, the result will be poor. And as you know, that type 1, type 2 ROB, type 1 we should treat, type 2 just observe. And the goal of the treatment, this is principle for us, because when we treat any baby, just we wanted for him, there is no retinal detachment, no dragging, good anatomical outcome, better visual acuity in spite of these peoples. They have, these babies, they have multi-system disorders, brain, hemorrhage, and less side effect. This is which we wasn't facing 7 years back. I remember that when you prepare a presentation for the bevacizumab, you need just to convince the people, bring the papers for them. So as Dr. Rao mentioned about BEAT study, in the BEAT study, here the terminology for stage zone 2 posterior, it came from this study. It wasn't before, according to my knowledge. Dr. Shangwal here is just our reviewer. So they created in the same definition of them, the ICROP 3. But they compare it for the posterior location of the disease, the stage 3, zone 1, and zone 2 posterior. In spite of the, if you look at this paper, that they look for clinical significance, they want to be better than the laser for the anti-VEGF. They reach it in zone 1, stage 3, but they don't reach it in the zone 2 posterior, in spite of wasn't inferior in the zone 2 posterior. So if you go for that, the reactivation or recurrence was 50% in the laser group in the zone 1, comparing by the bevacizumab, Avastin, and zone 2 posterior it was 20% the recurrence versus 1% in the bevacizumab, in spite of wasn't clinically significant, statistically significant. So I want to share one of our cases, that this case which we treated by the laser, you can see zone 1, we treated by laser, the patient regressed totally, then reactivation come after 6 weeks. We did for him FFA, we revisit the patient by the laser, he improved. Again, about if you have one patient with aggressive ROB, it was zone 1, zone 2 posterior, don't think that you will control it by laser. 50% this patient will end by retinal detachment. So still we need the VEGF in the zone 1 ROB in any stage. About the bevacizumab issue, it was the safety, the dose, because the dose they was using half dose of adult, and this study they have evidence that there is evidence of death for the patient who received the anti-VEGF, and there is clear evidence, the evidence that this Avastin will suppress the VEGF in the blood for more than 3 months. This is mean that this baby, they have the kidney, the brain, the lung, all of this need vascularization, so it could be affected. And if you go for to know how difference between adult and premature, they have already immature retinal artery barrier. So even the elimination from the eye is 50 faster than us, and even the elimination from the serum is less than us 3-fold. This is mean that if you inject him 0.1, 20% from the Lucentis, it will keep 7-fold more than the adult in the blood. And here to come the articles about the neurodevelopmental outcome, there is risk for any impairment or no. You'll find that there is conflict in the data. This meta-analysis, there is risk. The other meta-analysis, there is no risk. In spite of, we have a report from the BEAT study, the same 2 years later, they mentioned there is no adverse medical or neurodevelopmental outcome different between the two groups. But which we are sure about it, the high myopia, the very high myopia. This is mean that this baby, they will have more than -8 diopters. It will be 50% in the patient who received the laser in the zone 1 and 35% in the patient who received the laser in zone 2 posterior. So this is mean that you'll treat the baby by the laser. After 2 months, he needs the glasses. So you should send him to a correction and to follow up. And recently, there is a group in the pediatric group looking after to use low doses of the Avastin because they think that it could be effective. But when they decrease the dose, they face the issue when you use the anti-VEGF. More additional treatment, this means you need to reuse the medication, and in very low doses, the reactivation will be earlier. And this is something expected. If we go for the KROB study about comparing 2 doses, they approved the KROB study. It came for us because why? It was for us some debate. When you use the low doses, maybe you will activate the normal vasculature of the retina. So it will be, at least if you use the lower doses, it could be give the chance for the baby to have fully vascularized. But this didn't approve from this study, and even in the Rainbow study. The Rainbow study compared between 2 doses, and for me, Rainbow study something is very good because for us, in the real life, 2 doses with the laser, and we have now the result come from this study. We can implement another medication even. Reactivation was retreated by the anti-VEGF. Before any recurrence or reactivation, we was treated directly by laser. Here we can treat it in the first 6 months we can use this anti-VEGF for 3 times. And later we will see how it will be difference using revisit by the VEGF better than treated by the laser, to how it will be the difference. So we can see that if in the first 6 months, the superiority, not superiority, it was better than the laser, and in the higher doses, better than lower doses, the results. And the most important thing, the death rate it was the same in all the arms and continue for the 5 months. This is mean that there is no systemic effect for this medication, at least with this recently evidence-based papers which came. I want just to go for the 2 years for the Rainbow study. Still, the high myopia is an issue, and possible that this is according to the number of the letters, the babies who has received the anti-VEGF has better vision, but this didn't reach the clinical significance. But comparing by the laser, it was better. And going for this 2 years, good result continue to with time. Reactivation around 30% in the 2 doses. There is no difference in the reactivation 2 doses. Peripheral avascular retina, this is when you use any anti-VEGF, you should put in your mind, these need long follow-up for the babies. This vascular area is very important for us. But if you go for all the reports, after 6 months, most of the reactivation is less after 6 months for the treatment. But you need to keep in your mind, you need to see full vascularized or treat this vascular area in the future. I will this is the one which about the 5 years, you can still, the myopia is still the issue for the laser. And aflibercept approved by 20% from the adult. As we mentioned, use the ROB stage 2 zone 2 plus, and the reactivation 30%. There is some death rate, 30% that didn't relate for the ROB, and we wait the 5 years. And I want just to mention this case for us. This case, ROB zone 1 treated by anti-VEGF, regress, reactivation. And the previous, you say that for us, we treat by the laser. So we treat him by laser, he ended by -10 diopter. Another case, ROB in zone 1, so we treat him by anti-VEGF, reactivation zone 2 posterior, re-inject the baby. 3 months later, the baby is 0 refractive error, and the patient is good, and they have key follow-up for the babies. So to summarize, the guidelines, there is any change in the guidelines? Yes, you can, there's change in the guidelines. The UK guidelines, 2008, 2022, they updated. They use in zone 1 and zone 2 posterior, the anti-VEGF, unless you have evidence of infection. Zone 2, except the zone posterior, you can use the laser to stop follow-up, avoid any vascular, for follow-up issues. If you can follow up the patients, this is related according to the approval of the Lucentis and the aflibercept, you can use it, but here the guidelines to treat it in zone 2 anterior or mid. In the end, to conclude, anti-VEGF is the choice treatment for ROB in zone 1, zone 2 posterior, laser retinal ablation for zone 2 anterior and peripheral vascular area bar, in case there is no chance follow-up, infection, reactivation with fibrosis. Thank you.
Thank you for the nice talk. Anything to add, Susanna?
I know that a lot of debate.
Well, it was a long way since the first injection, and they called us that we are making experience with child and all that. Nobody wanted to use anti-VEGF. To now that evidence is there, I mean, it can control the disease. It's not the only panacea. It's not absolutely the wonder, but yes, it's a very efficacious treatment because it has the rationale. It treats the anti-VEGF that drives this disease. Now we have 3 drugs. We have 3 drugs.
Yeah.
And it begins, now it begins.
Before when we want to choose, because we have the access for the 3. But now if you ask me,
I'm going to say.
For me, we have the access for 3 medication. If the patient has financial support, we'll give him the Lucentis because it's approved in the UAE. Still, the aflibercept is not approved. If the patient hasn't financial issue, visit visa, so we inject him if he's zone 1, we inject him by Avastin, and we use around 1/4 of the dose of the adult. We don't use the 600 micron. Because for us, we found that if you reduce this 0.1, it will be effective.
That's no point. You have to use a second injection, and that's my question. So you have a drug that Lucentis. So most of the times you have to inject twice in zone 1.
Yeah.
And you have Avastin that you have just to inject one?
No. This is in the Avastin, mostly in the Avastin, when we choose, it will be for the patient the revisit of the eye, we want to finish him because there is problem for follow-up. We have system in our hospitals because we have different hospitals.
I was not
so the
speaking
patient,
about that. The studies indicate that
Yeah, yeah.
with Avastin you don't have so much recurrent
we,
diseases
we,
than
we don't
with
we don't we
Lucentis.
don't we don't re-inject by the Avastin. If the recurrence, we go for the laser because we don't have evidence. Something happened.
No,
this
no,
is
I was telling you exactly the contrary. You have less recurrence with bevacizumab than with Lucentis. And now you have Eylea that also has a very not so high, in the real world it's not so high like in the study, in the rainbow, and like in the, like Lucentis, butterfly.
Yeah, Doctor,
so
for-
it's a little bit, the
maybe
studies
yeah.
have bias.
I think we need to continue
Yes.
to the next talk. We will, if we have time for discussion, we
Yeah,
will have a discussion at the end. Actually, it's the
Doctor,
fact
you suppress
by literature.
you
So-
suppress the blood for 3 months.
So-
surely it will have stopped.
But you have no evidence of
But for us,
neuroproblems.
according to, if you ask me, doctor, from our experience of number, because we collect our data.
Thank you, Hassan. Thank you.
Thank you,
so
thank you.
we need to move on. So it's my pleasure to introduce Susana Teixeira from Portugal, and she will talk about role of imaging and fluorescein angiography in ROP.
So, good afternoon. I'm going to share with you a little bit of my experience with anti-VEGF, with angiography in ROP. Sorry, I'll do this work. Oh, it's in the middle. Okay. So we all know that the decisions of treatment and the diagnosis of ROP is under indirect ophthalmoscopy. But the new wide field cameras allow us to see and reproduce very well the images and allow us also to make fluorescein angiography. And fluorescein angiography gives a lot of information from the circulation of the eye. So what I see with indirect ophthalmoscopy is like this, but when I make a fluorescein angiography, I can see a new world. So you can see all the vascularization, and clearly we can see the area between the vascular and the avascular retina where the ROP exists. So you can see quietly the severity of the disease, the extension of the disease. Here you even can see, can go back? Yes, you even can see some kind of involvement of the anterior segment and the severity of this disease. And at the end of the day, you can quietly sit in your desk and amplify the images and study all what's happening inside that eye. So I think it's a very wonderful tool to study the physiopathology of the disease. Also in follow-up, I use the fluorescein angiography to see if there is some kind of motive to, for instance, have an hemovitreous, and to follow up the fibrosis secondary to the resolution of the disease, to see if there is some activity or not. And sometimes I have surprises like the presence of occult neovessels, even in eyes that already had laser. The interest about angiography in these eyes was widened like with fire after the anti-VEGF area. So after using anti-VEGF, we began to study the circulation of the eye, and suddenly we found very interesting findings, like this pachychoroidal fielding in the micro and nano babies treated with anti-VEGF, this irregular vascularization of the eye with vascular shunting, anomalous dichotomy of the branches, scalloped limited of the retina, blunt terminal, and these very funny tangled vessels, not with exudation, but just this conformation. And after you have the vascularization of the eye, you can see the vessels are stretched to the periphery like those fingertips. But the most interesting is that when we make laser, or when we make angiography to babies that had a spontaneous regressed ROP, we also can see the same. So we wonder if these findings are just because of the use of anti-VEGF or because the disease itself, ROP itself, can driven an abnormal vascularization of the eye. Also in the macula, you can see that have the usual hallmarks of prematurity, like the vessels encroach on the fovea, and these tiny hyperfluorescence window defects that we still don't know what that means. Perhaps the OCT simultaneous to the angio will explain us that. And the peripheral vascular, peripheral persistent avascular retina. So now this is the field of debate, you know, because it's an area that we still don't know what that means. We know that it's a place where in the future, in adults, we can have an area where we can have some kind of risk factor for retinal detachment, hemovitreous, the presence of some lattice. So it's an area that we still really don't know. So now, with angiography and OCT, we are looking for biomarkers of risk factors of this PAR. We still don't have biomarkers, but we have rationale. We know that the extension, the much extension the part, the most significant risk of development of retinal detachment in adults, in other more not so young babies. And also, if you have leakage, I mean some kind of activity between in the margin from the vascular to the avascular area, it's also a significant factor risk for the development of retinal detachment in older ages. So we are looking for those two things. I'm very quite calm if I see, even with a wide vascular area, if I see that the retina of the vascular junction is not with any kind of impregnation. But if we have this kind of milk leakage, we can think that something is happening in that avascular area, that we must be somehow aware that there is a problem. But if you think that doing laser is resolving everything, this is 1 year after laser therapy of a PAR, we can find neovascularization in the frontier of those two, and impregnation in the frontier, in the place where there was ROP before. So we must study, and we must try to have studies to know really how to deal with this PAR, to make laser or to just follow up this PAR, and when to do some kind of treatment. Now, angiography is also important in the diagnosis of the recurrent disease. It does not diagnose the recurrence, but help us knowing the pattern of this recurrence, if it is just in the advancing edge, or if it is in the advancing edge and in the anterior ROP. So there are two different kinds of recurrent ROP. Also in the atypical ROP, and we have more and more very tiny micro and nano babies that present with a typical ROP, and angiography help us in that diagnosis. So sometimes, let me see if I have still time. Sometimes we never know if we are in presence of an ROP or an induced oxygen-induced ROP, or in aggressive posterior ROP, or in a fever, because this baby began like what it seemed an induced oxygen-induced ROP, but suddenly behaved like a fever. And this baby was sent to me like a stage 3, so a type 1 ROP for treatment, and I look at it, it does not seem really, it was a preterm, but it did not seem really like an usual ROP. So these different loops in the vitreo and the behavior of the periphery, so we think it was a preterm fever, or a persistence of a posterior persistence of the vasculature. In the other eye, it seems like a persistent vasculature of the eye. So, also, like it's very reproducible, and you can easily take these pictures, and artificial intelligence is very interested in our images, in our pathology, and they actively are trying to make deep learnings and algorithms to study the stages of the disease and the indications or not indications for treatment. So we are a field also for artificial intelligence. So what do I think? I really would like to make angiography to all the babies, but I cannot. But I think it's a safe procedure. Help us to understand the physiopathology of the ROP, because still we don't know much, a lot of things about ROP. Improves the visualizations, increase the sensitivity, and help us studying the PAR and the differential diagnosis of ROP. But as usual, I have more questions than answers. So I have a lot of questions about when to use, to whom babies should we use, when to use. So I have more questions than answers. Thank you.
Thank you, Susanna. Fluorescent angiography and new imaging systems are, giving us in a different view. Yeah. So we will discuss at the end. Please come here. Now, the next talk is by a very experienced ROP specialist, by Dr. Mangat Dogra. Now he will be talking about stage 4 ROP surgery.
Thank you, the chairs here, and I must thank organizers for giving me this opportunity to be part of this prestigious meeting. I'm just going to talk to you about surgery in stage 4 ROP. So these are my financial disclosures. As far as the surgery for stage 4 ROP is concerned, I think scleral buckling was done in past and was a popular procedure, is rarely performed now. And what is very important is the lens-sparing vitrectomy, and I think it has really caught up and gives us the best results. In some cases, of course, lensectomy and vitrectomy may be required. Basically, lens-sparing vitrectomy, according to me, is one of the most important surgical procedure. At least I got very fascinated for many, many years doing for 4A, 4B. And early LSV is performed at this time, especially in the era of anti-VEGF, where you find that even if there is some proliferation happening, or if you go in early, you're going to give very good result. I think there are several studies in the literature which has given us 60 to 85% results as far as the 4A and 4B is concerned. I'm just going to share you some of these cases. I think this is one case a few years back, came very late. At this stage, this is the presentation, it was lasered. You can see how aggressive it is. You can't inject here, of course, nobody would, probably the whole retina would contract. But very soon, you can see it has progressed. But if you go in and just do the minimal, although it was very vascular, and you just cut that, it goes back and you may be able to salvage such a situation. This is another one. The right eye regressed very well. Of course, the razor was also done posterior to the ridge. But other eye, you can see, has progressed. Almost everything is contracted there, right in the center. So I don't know, how does this video play? Sure, yeah. So this is a vitrectomy for the same case. Basically, here we have done conventional the way we would do, but mostly we do what we do, stop and slide. I think that is what we have been doing for a long time, that you just go up to the level where that mark is there, and then don't go beyond that. You just polish out. That way you don't touch the retina. And you can see that this is the type of retina. I had shown you the picture earlier. Everything is contracted right in the center. And if you don't do anything here, already perhaps by the time the clearance was there, it got a little late. And so you can see how much tethered it is in the center. So you follow all the, you see, whatever the criterias are, these are very well described, and those who do surgery, they know it, that how we have to remove the vitreous, ridge to ridge, ridge to the center of the stalk. And I think that basically you want to remove as much as you can. Here it is different from the adult surgery. You can't be doing peeling, you can't be doing other things. So basically I think you are trying to cut whatever you can do safely, and that is what is done, and that is what is being done here by me. And once we knew that the center is open, but there was a more chance to kind of open it up further, although it was quite vascular there. But then that is the way we proceed, and we did, we had to cauterize here because it started a little bit bleeding, and then cut this, and that will be the, almost the end of surgery. And while we perform this surgery, I think one thing is important, never to create a break. That will be end of everything, because I think that's how you have to be very, 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 very cautious, not going overboard, and just doing what is possible to be done. Like in this case, and that's it. That's where we stopped. And here the... So this is the same case. You can see it opens up, and you can give fairly good result in such cases. I would like to show that same case earlier also. You can see what you do and how it opens up. I think very rewarding surgery. I have two great surgeons here, right, sitting with me, so they do all the time. I think what we realized, we were doing lensectomy in most of the cases where there was a temporal proliferation, which is not uncommon. The whole temporal retina, TRD, is attached almost near the lens. So that is where the problem was. I think, and literature showed that a lot of them require lensectomy, as high as 57% in the literature. So, and also they would, once the lens is sacrificed, there's a glaucoma, so many things. These kind of cases here, so they require. So what we did for the first time, idea came to me that why not to do only all nasal lens-sparing vitrectomy here, that you sit on the nasal side and do, this is published in Retina 2022, and basically I think we could salvage the lens in most of these cases, and all the surgical objective could be achieved. And of course, I did talk about this stop and slide way of doing it. I'm not going to show you video here. I'm showing the same video in that session, which is what you do differently, because that is where I would show that video. Here we stuck at the nasal side in the center, the infusion cannula, and you go on either side. You will be able to achieve all surgical objectives much more ease, and you have to only shift yourself and your microscope. That is the way it works, and it works very well. And this is one such case which was done from the nasal side, and you can see how well you could achieve the surgical objective. Everything could be done very well in such a situation. So I can go on and on, but I would like to say here is, I think anybody who is doing surgery, lens sparing, especially if you have a good anesthesiologist, good backing up from your neonatologist or pediatrician, just start doing lens sparing vitrectomy. I think you'll be saving a lot of babies in stage 4A, 4B. Don't let them go to 5. I think we have a problem. Of course, we have great surgeons here. I have almost stopped doing stage 5 because I think it's a challenge. We did for many years, but the problem is we have issues, getting something out of them, very few. And early lens-sparing vitrectomy in progressive 4A, 4B is required at this stage. And I would say all nasal, do try this approach. I think you will save the lens, you'll save amblyopia, as well as you'll achieve all surgical objectives in temporal traction retinal detachment. Thank you very much, friends.
Thank you, Dr. Dogra. You are a master. We learn a lot from you. And those stage 4 are very important to us, because as soon as we can make the surgery, the sooner the better. So yes. Thank you very much for your presentation.
Thank you.
Any questions?
Yeah, Dr. Dogra, thank you very much. I think we published the book edited by Shingle, the positioning and how to avoid complications, especially if you have a temporal trough. I sometimes use the chandelier and bimanual dissection, and sometimes I get more complications, the iatrogenic break that sometimes you inevitably have. Do you use bimanual, and how do you feel about it?
That's what I'm saying, no need. I have hardly used bimanual, I must say, in these cases, because these are totally different. So you go very limited. I think one of the things which perhaps Mike Tracy taught everybody, do the minimal. You can always come back. I think then you do no harm. So that principle, at least I have followed all my life. And if you do that, and in nasal, you see, there's a big advantage. I never knew. There's some, I think Yoshi from Wills was recently in Delhi. So he says, okay, I have not done, but I put all the time, in most of my cases, this nasal cannula, because it supports, the nose supports the cannula. Even if it is not moving, it is not touching the lens. So even if you want to go up, put a nasal cannula. I think it will be a great thing, but do limit it. So we have no, this thing that I have used chandelier and I have gone for bimanual, I have come back if I have not achieved the surgical objectives.
And you don't insist on doing a PVD, right?
You can
insist
do
on
a
this.
second
Yes.
surgery, a
Yeah.
stage
I totally agree with you on the chandelier thing. You know, I almost never do chandelier-assisted bimanual surgery in ROP cases because it can touch the lens or the retina, and if it touches the retina, it can cause iatrogenic break, and it's just a failure. It's not like in adult cases, so it doesn't let you to go further. So less is more.
Yes,
So that's where it applies. That's why I always, and you have a very narrow area for the maneuvers. When you just bend the eye to some place, then it may hit the retina more easily than in adults. That's why I always escape from that.
Thank you, thank you.
I'm going to do, except not opposite, but
Thank you.
sometimes I use chandelier. So I take the light pipe, put chandelier, and do indentation for laser at the end. I do that. So now it's Dr. Schengel Ostek, and she's speaking about late ROP, I mean adolescents and the sequel of ROP, isn't it?
Thank you very much. So thank you for staying till the end of the session. So these are my financial disclosures. You know, the Scott-Russell ROB has been first described by the ICROP group in 1987, and they have described some peripheral and posterior changes. The peripheral changes were the persistent avascular retina and some vitreoretinal interface problems, peripheral membranes, and also lattice-like degenerations in the posterior pole, the straightening of the blood vessels in the temporal arcade, and distortion of the macula as ectopic macula, and dragging of the retina over disc. So these were known before. I just want to show you some examples. So this was a prematurely born baby who had type 1 ROP in zone 1, and she had bilateral anti-VEGF aflibercept injection, and it started to vascularize, the disease went away, but this was 11-month-old appearance of the fundus, and she had high myopia in both eyes, as expected in most of the cases, even if it's not a lasered eye. So we still have high myopia in ROP cases, even if it's a spontaneous regression. And then when we do a fluorescein angiography, as Susanna mentioned before, we have persistent avascular retina very, very frequently, and then we did laser to this eye. This is a kind of Scott-Russell ROP still. So we have high myopia, and we can have glaucoma, cataract, amblyopia, vitreous hemorrhage from the recurrence in the late stage from the neovascularization, and late reactivation of the fibrovascular proliferation. But we also have rhegmatogenous, tractional or exudative retinal detachment in such eyes. That's very important. So this was a 20-year-old young man. He was a premature baby, followed in USA, born in USA, and he had previous lasers to the lattice areas and came just for a control visit. Vision was quite good in both eyes. This was the appearance of the fundus. Although vision was quite good, you see the straightening of the arcade vessels and ectopic macula in the temporal part. So the fovea was quite good. And in the fluorescein angiography, you can see the peripheral avascular retina, some lattice degenerations lasered, and you see many neovascularization in the periphery. And he has been followed up with this avascular retina. So actually, I did laser in both eyes, in the peripheral retina, not like we do in active disease, of course, not like confluent, but it was just like you do PRP in diabetic retina. So then there's no problem since 6 years. This is another case, 14 years old, premature birth, no treatment before. Vision was quite good, but in 0.8 in one eye, full vision in the left eye. But when you look at the peripheral retina, you see quite a lot of vitreous membranes, vitreoretinal interface problems, causing traction in the peripheral avascular retina, and you have so many lattice degenerations. So when you leave the eye like this, then it will come back with a rhegmatogenous retina for sure, almost. So what I did is a prophylactic encircling band, since the peripheral vitreoretinal tractions were very strong, and then afterwards, after encircling band, did prophylactic laser in both eyes to cover those lattice-like degenerations as a prophylaxis. Or they can come with rhegmatogenous retinal detachment, and they usually come with high myopia associated retinal detachments, and if you don't ask the prematurity history, they are usually misdiagnosed as Stickler's disease, so you should always ask this. When you have a rhegmatogenous retinal detachment in ROP survivor, they are usually more complex detachments, more likely to require multiple procedures, and the visual and anatomical outcomes are lower, and 2/3 of patients who underwent vitrectomy had poor postoperative visual acuity. This was an 11-year-old boy who had sudden diminution of vision in the left eye, and he didn't have any treatment before. He was followed in another center for scatricil ROP for since 4 years old, and he applied for strabismus. The vision was 0.05 in the right eye and 0.3 in the left eye previously, but now he came with the loss of vision in the left eye, which was the better eye. So he came with retinal detachment. This was the worst eye, which was the right eye. You see the retinal macular fold. And this was the better eye, which used to see 0.0. Now just counting fingers with total rhegmatogenous retinal detachment. So if I could see the retinal break pre-op, I wouldn't do vitrectomy for sure. But since I couldn't find out the retinal break, I had to do vitrectomy. After putting an encircling band, we started vitrectomy, and as you see here, these are not the PVR membranes. These are the previously present scatricil ROP membranes, actually. So we don't want to be very aggressive on peeling these membranes. We just peeled the membranes over the macular area, try to avoid from iatrogenic retinal break, and just left the ones who were which were very sticky and strong, then just left them, and then did some ILM peeling also, just to be sure that there is no membrane left in the macular area. And this was the causative retinal break, so now we could see it. It was under the thickened posterior hyaloid, and then we could peel the posterior hyaloid till the membrane, not more than that, and then left the eye in silicone oil. And afterwards, it was good. So we did laser in the peripheral retina, in the right eye, and this was the post-op appearance in the early period, and it was going quite well, but in the later period, you see although it looks nice, in the OCT we have a newly formed macular hole because of the contraction of the residual membranes, which I have to leave because of the strong contractions. Then this eye had operations with amniotic membrane in the macular hole area, but contracted again, third surgery and fourth surgery, and finally I had this. So retina was attached, but just counting fingers from 1 meter, but these eyes do really badly as far as the vision is concerned. And this is another case, for example. I could find this was an inferior retinal rhegmatogenous retinal detachment, chronic, associated with ROP, but I did just, since I could see the rhegmatogenous component, I just did encircling buccal cryo, and it did very well. So we have collected our data in Gazi University, and we have seen that the scleral buckling group, only scleral buckling group, did the best as far as the vision is concerned. And combined group, cerclage and vitrectomy was the second, and partial vitrectomy group was the worst. So the mean follow-up was quite enough. When we come to the scatricial ROP group, which has the tractional ROP, we have to decide should we operate or not, because they are coming very late. So you can lose the present vision. So you should weigh the risks and benefits. So this was a 6-year-old boy with 0.0 vision. The fellow eye was stage 5, and you see the macula was ectopic in the temporal and superiorly, and you see the tractional membranes in the superior part. I did operate this case because it was an anteroposterior traction, so it can be removed. But if it was a tangential traction, just tangential membrane, I wouldn't touch this case because he can see 0.1, so I don't want to lose that. I don't want to risk that vision. But when you just see such removable membranes, it's better to remove, and it's better to operate this case, so you should judge. So you can end up with this, the vision improved to 0.3, and for the future, you now guarantee this vision. And this is another case. This was 6.5 years old, premature born, no treatment before. You see inferonasal tractions in both eyes. So again, this was an anteroposterior traction. Again, if it was a tangential, I wouldn't touch. But you see the macula was off, but I'm sure the macula was on in the early years. But with the growth of the eye, that fibrovascular traction, which is anteroposterior, just pulled the macula and caused recent macular detachment. That's why we are expecting to have visual improvement after the surgery. So we don't want to peel everything, but just relieve the tractions over the macular area. You can leave the membranes there if it's too strong. I think I have to stop. Okay, so this is the post-op appearance of the right eye, and we did a vision improved to 0.7, and this is the left eye, 0.3. So we have to select, of course, the cases. This was a stage 5 case and operated at 4 years old, and now, although the vision was only hand motions, ended up with 20/400. So we have to consider surgery in selected scatricial ROP cases. We can have good anatomical and functional results in the selected cases. I would like to thank to my co-workers, and just want to introduce my book if you are interested. Thank you.
Thank you, Shangul. All the sequel, and I think the end of the history is a patient with ROP is a patient for life. So everything can go as well, but it's a patient for life, because most of the times it's okay. It runs well, but you must always look at the periphery. You can have suddenly a tear, something that you have to treat, or even if you don't have anything, you must always look, because the most old person with a retinal detachment linked connected with ROP at 69 years old in one of our studies. So it's a disease for life. Of course, some of them have these terrible presentations and need terrible and very exclusive surgery. Thank you, Shangul.
Thank you.
Any question?
We have actually so many questions. We have so many debates especially for those peripheral avascular retina to treat or not to treat, and when to treat if you treat, and about the recurrences, how to treat the recurrences with laser or anti-VEGF. We have so many questions. I just wanted to put the discussion to the end because I just wanted to present the scatricial changes. In those avascular retina, we end up with lattice degeneration and rhegmatogenous retinal detachments.
It's not always like that. Most of the times, the avascular areas are quiet, very quiet, very tranquil. But sometimes, when they are not quiet, they are a monster, that monster. So the problem is to know which are the quiet, I think it's 80%, 90%, and which one will bite us, will be the monster that will appear. I've got a theory, if you allow me. I think it's most genetic. When I see that the retina stops and has this kind of a vascular impregnation for 3, 4, 5, 6 months, it can be a fever, and fever can hit you at 3 years old, 4 years old, 20 years old, 60 years old. So sometimes I think there is a genetic component. That's why I look and I trust, not trust, I try to understand what angiography tells me. So that's not the usual, all those terrible things in the periphery. No, that's not the usual. But sometimes we have that, and I think there is a genetic component of fever. So when I see that the periphery is like this with some kind of activity, I follow sometimes 1 or 2 years. And then if there is some activity, I do laser. Not because I'm afraid I'm avascular, but because I'm afraid it's a fever. And she will come anytime.
Yeah, what I do in such cases is that I'm always afraid of, having later problems. That's why when the baby is big enough and when I cannot follow the periphery by just routine examination, I usually do a laser, I do a fluorescein angiography, which is usually after 60 weeks post-menstrual age. Then I do laser if I see an avascular retina, not in the zone 3 area, but in the zone 2 area. So that's my routine because I see such cases quite a lot often. So
we could
yeah.
be debating all the time.
Shengul, the case that you showed that had peripheral lattice and so forth, and you did a laser and a buccal. I usually don't think about buccals because the retina is flat. And even doing laser, I had a 10-year rhegmatogenous detachment with a very nasty posterior hyaloid contraction.
Posterior to the
yeah,
laser.
That's really bad to remove. And those were both eyes of a very functional patient, that went to school and responded well to the anti-VEGF in the old days. There is always this posterior hyaloid that we can provoke by laser or even by a buccal or by cryo, and we really don't know what would be the future. But when they contract, I think there is no way to just peel off the retina, and many times you have to do a retinectomy with those. So what's
you're completely right in your anxiety about these cases. That's why I don't do just laser in such cases. That's why I do put an encircling band, because the vitreoretinal relation is really bad in those cases. I see with my eyes the peripheral tractions caused by peripheral membranes. If you do just laser, it may cause contraction and may stimulate rhegmatogenous retinal detachment. That's why I first do just encircling band to relieve the traction first. I never do cryo in those eyes. Just encircling band to relieve the traction first, and then do laser, because the encircling band doesn't cover the posterior part. It's usually very wide-based tractions and wide-based degeneration. So what I do is just put three, four lines of laser to the posterior and to the anterior, so that I can support both. And it's first to do encircling band and second laser. That's
okay.
why.
So thank you. I do the same without a laser, but not Thursdays. So I thank everybody to be here listening to ROP, and now we have got a video session.
Okay, thank you for staying with us till the end.
I will come as well.
So we will have now a webinar or symposium by Bayer. Just you can continue with us. It will be in the same.
Thanks a lot. Thank you
Okay.
very much.
Who's going to present first?
Okay. So now we are going back to medical retina, and we will be talking about aflibercept and the extended durability in clinical practice. I'm privileged to have Dr. Mohammed Al-Omari and Dr. Prasan Rao in this session with me. So some of the studies, the new studies that evaluated the outcomes of a 2-year proactive treat and extended regimen with aflibercept for patients with DME is the VBEAM. VBEAM, we have about 48 patients. It's a prospective, multi-center, single-armed study assessing efficacy of a treat and extend regimen with aflibercept in patients with DME over 104 weeks, 2 years. So, aflibercept was given every 4 weeks for 5 months, followed by individualized treat and extend. The primary endpoint was the mean change of best-corrected visual acuity from baseline to week 104. The secondary endpoint was change of best-corrected visual acuity from baseline to week 52. The minimum treatment interval was 4 weeks, and the maximum treatment interval was 12 weeks, with 2 weeks extension at time. So the treat and extend with aflibercept initiated in year 1 can provide clinically meaningful visual outcomes over 2 years. We have the number of patients at presentation, 48, where the number of patients that continued till week 104 was 46, and we have seen an improvement in visual acuity of about 9.1 letters in the first year and 9.4 ETDRS letters by the second year. Approximately 35% of patients gained more than or equal to 15 letters at year 2. 57% of patients were on more than or equal to Q12 treatment intervals at the end of year 2. The mean number of injections was in year 1 8.5, and by year 2 was 3.9 injections. So the aflibercept initiated in year 1 can provide clinically meaningful visual outcomes over 2 years in patients with DME. The distribution of treatment intervals at the last study visit was more to 12 weeks, was about 43%, equal to 12 weeks was about 15%, and less was 41%. We have another study, which is the Hirano et al. Study. It assessed the proactive individualized treat and extend therapy with aflibercept in patients with DME over 2 years. We have here in the Hirano about 40 patients. It's a prospective, multi-center, open-label, single-arm study assessing the efficacy of a treat and extend regimen with aflibercept in patients with DME over 2 years. Aflibercept given as indication every 4 weeks for 5 months, followed by individualized treat and extend. The primary endpoint, still the mean change in best corrected visual acuity and central subfield thickness from baseline to year 2. And the secondary endpoint was the mean injection number, treatment interval, distribution, and adverse events by year 2. So the majority of patients with DME achieved actually 16 weeks treatment intervals with an individualized treat and extend regimen with aflibercept initiated in year 1. The number of cases that we maintained is actually 30 cases, and mean change in best corrected visual acuity was 6.1 ETDRS letters. The mean number of injections from baseline to year 2 was 11.4 injections. The patients completing the 2-year follow-up was 30 patients, 75%. Out of those, we have 66.7 of patients were on Q16 treatment interval at the end of year 2, which is almost quarter of those, 2/4 of those patients. The JADE study evaluated the efficacy of proactive treat and extend regimen with aflibercept for patients with DME. And again, it was single arm, and we have seen the injection every 4 weeks for 5 months, followed by individualized treat and extend regimen. The primary endpoint was the mean change, again, of the best corrected visual acuity with the ETDRS letters from baseline. And secondary endpoint was the mean change in the central retinal thickness from baseline, proportion with dry retina at week 20 and week 52. The minimum treatment intervals was 4 weeks, while the maximum treatment interval was 12 weeks. Here we can see that 89%, 40 out of 45 of the patients had a last injection interval of 12 weeks. So we are reaching to almost 90% of our patients with 12 weeks intervals. And the improvement in vision was 8.3 letters. Mean number of injections over 52 weeks was 7.7, and the proportion of patients who reached disease stability at week 20 and could begin interval extension was 87%. Proportion of patients with a dry retina at week 52 was 51%. So this is a collective data from the Violet, VIBEAM, Hirano, and JADE trials. The Violet we did not present, where aflibercept treat and extend implemented after 1 year of an on-label treatment. Vision gains were maintained in the long term with a low treatment burden. Mean number of injections at week 100 was 10 only. While in VIBEAM, as we have seen, the proportion of patients at week 12 or more intervals at the end of the year 1 and year 2 was 74% for year 1 and 57% for year 2. For the Hirano, the proportion of patients at Q16 intervals at the end of year 2 was about 66.7%. While in JADE, the proportion of patients at Q12 intervals at the end of year 1 was 89%. All of that with maintaining the improvement in visual acuity that we reached through year 1. So quickly, I will move on to one of my patients that I've seen that would be good to present. This is a 58 female diabetic patient, hypertensive, and diabetic for 18 years. The hemoglobin A1C moderately controlled in this area of the region. It's 8.7, and the visual acuity was 20/70 in the right eye, 2200 in the left eye. Anterior segment, there was nuclear sclerosis. It was a severe NPDR, not proliferative, and with DME, as we can see here in the right and in the left. In the right, it did not actually show central subfield thickness very high. It is 245, but all over you can see the encroaching edema on the central part and with intraretinal cyst in the fovea. And all around it can reach to even 400 microns. So with this even eye, I started treatment. While we can see even in the left eye, you can see intraretinal cyst, subretinal fluid, and a lot of exudates that are in the central area. So this is the journey of the left eye first, and then we will move on to the right eye. So at baseline, the visual acuity was 2150, 477 micron at presentation. First Eylea given. After 4 weeks, the vision improved to 2100. Central subfield thickness improved to 374, still with some intraretinal and subretinal fluid, much less, but it is improved. So the second injection was given. 5 weeks, because we usually cannot keep the patient on the interval that we wish, actually. She came back with 20/70, the vision improved, and the central subfield thickness improved to 351. And at that time, given the third injection, after the third injection, she came almost, the central part dried out we have hard exudates that started to encroach a little bit more on the fovea, but the central area and the fovea is drying up very well. So the fourth injection was given. 6 weeks after the fourth dose, not 4 weeks again, sorry, I missed the best corrected visual acuity. She started to improve to 20/40, as I remember, and central subfield thickness is even better. The hard exudates are still there. The fifth injection was given. 8 weeks now, we are starting to increase the interval because the fovea is dried up, and to give the patient the freedom of the injection. The sixth injection was given after 8 weeks, and then after 12 weeks, the sixth dose of injection was given, maintaining the dryness of the fovea and actually even drying up the hard exudates that was encroaching on the fovea. And then I increased the interval even more. I was intending to 12 weeks, but she came back after 15 weeks, so she was given the 8th Eylea injection with maintaining the dryness of the fovea, and even the hard exudates are much better. This can show us the efficacy of the drug and the durability that will maintain the dryness of the retina. The left eye improved to 20/25 for the last visit, if I can remember correctly. So what about the right eye? The right eye, we concluded that there was no much of edema in the central area. The best corrected visual acuity was 20/70 at presentation, and the central subfield thickness, the spot was 245 with an overall edema and hard exudates. After the first injection, the vision improved to 20/40. So sometimes we are reluctant to give the treatment for a patient that necessitate to have a treatment, because these patients will improve. The vision already dropped. So improved to 20/40, although the central subfield thickness did not improve much. Again, after 8 weeks, now we jumped. The patient said that she improved. That's why she did not proceed for the third injection. And she came back with a slight increase in the central subfield thickness, with a cyst that accumulated there and some hard exudates that started to encroach on the fovea, but still the vision improved. It's 20/30 still. And after the third injection, she improved even more, kept the vision to 20/30, central subfield thickness to 243. So the fourth injection was given 8 weeks apart. Then, after that, she came for the follow-up because she was following up for both eyes. And at that time, she refused any treatment, and actually I did not advise her to proceed for the treatment. The vision improved to 20/25. A very minimal cyst in the center did not affect the vision much. The central subfield thickness is very good. So follow up again after 10 weeks, the vision maintained, and the central subfield thickness 240. So we can calculate all of that. So 8, 10, so 18, and then 12 weeks, then it is a total of 30 weeks. She did not receive any injection, and the very minimal cyst that started to appear. At that time, I have given an injection, so it is more of a PRN regimen, a controlled one, and the vision was maintained all over with very minimal number of injections, so she received only 5 injections over a course of about 2 years. Thanks a lot.
Thank you very much, Dr. Ahmed, for this excellent presentation. As usual, nobody can beat with you when you are giving a talk. Ahmed, I have one question before we start with Dr. Prasan. Now, if we want to talk about an ideal drugs we are looking now all the time when we are trying to improve our management, we are looking for an ideal drug for the disease that we are going to treat. So what is the criteria now we are putting in our mind to tackle, and you feel that Eylea is playing a role in that?
Thanks a lot, Dr. Thanks a lot, Dr. Mohammed. excellent presentation, excellent question as usual. So I think the ideal drug is that carries three aspects. Efficacy, because if we do not have an efficacious drug, why we will inject it? It does not make any sense. The second is safety, because if we have an unsafe drug or with higher risk of complications, I would not carry the risk to give it to our patients. And the last, and what we are tackling now, is the durability, because we have a lot of our patients that they improve, but they would not maintain the improvement of vision because they need lesser burden of injections. So I think the ideal drug is the most efficacious or efficacious drug, safe drug, and a durable drug. So that's what we are aiming. We have an excellent drug in hand. We have Eylea, which is very potent, and we hope that we have as well, we have a lot of drugs, other drugs, which is very good as well. And we will have the 8 meg, which is even more promising of a more durable treatment that we can decrease the burden on our patients with that.
Yes, Ahmed, but if I want to talk about the Eylea now, we reached to a limit that we reach now 16 weeks, right? In treatment of diabetic macular edema, and this is the most achievable until now durable medications. So we are having a good medication that we are using for a long period of time, and now with more and more experience, we are going to have, we are getting the benefit of these medications. There is another question, Ahmed. We thought how we can treat and extend. I need you to brief us in a few only seconds about the treat and extend. Every 2 weeks or every 1 week, or you will go directly to 4 weeks. How do you do that, please?
I usually tend to increase at 2 weeks increment or intervals, and according to the condition of the patient, because if the patient dried up very quickly and is responding very well, maybe that's the time that I would push it even more to 4 weeks interval. So it will not be strict, and despite that the label is 5 loading dose, if I have a patient who responded after second and the third is given, I would start treat and extend at that time. So it is not fixed. Yes, the studies are there to guide our treatment, but after all, it is us that we can decide what would be suitable for our patients. So it is not wrote in stone.
Okay, now if I want to learn from you, Dr. Ahmed, I want to move in a protocol or semi-protocol, let's say. So after, Doctor, we can have the opinion of Dr. Abdullah Ban. He is also with us. Thank you, Dr. Abdullah, if you allow, Dr.
Thank you very much, Dr. Mohammed and Dr. Ahmed, for this excellent presentation. There is no ideal way of doing it. Especially we are dealing with a different cohort of patients. Let's say, for example, in our institute, we do about 16,000 injections a year. Maybe 40% of them are for diabetic. And that's why we have a protocol for diabetic, treat and extend protocol, and another treat and extend protocol for RVO, and another treat and extend protocol for wet AMD. In diabetic, we tend to slightly increase the loading. So we do 4 or 5 for most of them, and we try to do that for all patients. We tend to extend slower with diabetic, 2 weeks, but let's say for RVO, we may extend 4 weeks. And this is with Eylea specifically. But sometimes we use other drugs. Even in the trials, they said you can go after 3 loading or 4 loading, go to directly to 12 weeks. Even in our practice, we don't do this big step unless the drug has been there for a year or so. So we keep it step by step. So we do 4 weeks extension. So there is no ideal way of doing it, and you will still expect about 10 or 20% non-responder, where you may think of a combination therapy or other treatment option. Yeah.
Thanks a lot, Dr. Abdullah. Excellent. Usually when you have a protocol, that's great with big numbers, but when you have an approach one-to-one to the patient, you know quite well how is they behaving. Definitely diabetic requires more treatment, and you need to be more active in treatment, especially during the first year, and then you can increase the interval. But in selected cases, if things are well and under control, maybe you can try to get it treat and extend early on. But I agree totally with you.
Okay, I have another questions, Dr. Ahmed, and if any other one who want to comment. We know that we are also now, there is a way of treating the diabetic retinopathy itself by anti-VEGF. And we found, I think we are having this phenomena or this way of management. Start with protocol T when we found that Eylea, it can have an effect on treatment of diabetic retinopathy. Is there any, in your experience, correlations, and how you feel, how long you can continue to do that?
Yes, protocol S have shown that, and the other studies for Eylea, that it is effective. It will reduce the diabetic retinopathy severity scale by at least 2, and it have a very good control and even improvement in visual acuity. But again, with our patients, I think the best treatment for PDR is to do laser, because those patients tend to disappear. So if you have a patient that is responding well to anti-VEGF, and then they disappear, they will come back with an activity that it is not controlled or a bleeding. So still, in my opinion, for PDR, the gold standard treatment is a good PRP done with the help of anti-VEGF. Whenever there is edema or any aggressive PDR, I think we need to inject first and then continue with the PRP.
Thank you very much, Dr. Ahmed. So we will delay Dr.
I think
Prasan.
finally,
Dr. Prasan round. Yeah.
Finally we started. So I was just waiting when my turn is going to come. Sorry about that. So I was supposed to speak for 15 minutes. I have about 8 minutes, so I'll quickly go over my presentation. So I'm going to talk on translating data to clinical practice. As you know, diabetic patients have multiple comorbidities, which are complicated. They have multiple visits to the hospital. So this is a 65-year-old gentleman who lives with his family. He's type 2 diabetic, hypertensive, heart disease, and kidney failure. He developed a diabetic macular edema, and now this is an issue for him because he requires multiple injections on monthly basis. You have loading dose and then extensions, and this involves a lot of other problems because he not only has visits to his ophthalmologist, he also has visits to his endocrinologist, cardiologist, etc. So this is a real-life scenario for us. So what about this picture? Why am I showing you this picture? So this picture is of a gentleman known as Eliud Kipchoge. He's the world record holder for full marathon, 42 kilometers running in less than 2 hours. And the reason I'm showing you this is because for achieving this, he has to consistently run sub 3 minutes per kilometer for a period of 42 kilometers. That means that he has to be consistent and he has to also be durable. So the important thing here is the name of the game is durability here. And I just want to reiterate the fact about durability. Dr. Ahmed already mentioned efficacy, safety, but durability is the thing we need to watch out for. So I'm going to talk about 2 patients of mine. This is a case presentation of a 66-year-old lady who was diagnosed with DME and referred for management. She had bilateral cataracts, and the left eye she had very poor vision because of diabetic macular edema and glaucoma. She's been a diabetic for a very long time, and these are her various medications. So she presented to me in 2017. So you can imagine it's a marathon. It's a long run for these patients, and we'll just see over a period of 4.5 to 5 years how she's doing. So this is her macular edema. She's got central involving macular edema. CMT is 429. And as usual, what we do is we give injection aflibercept. So I gave her 3 injections of aflibercept, and can see the response with 3 injections. Her central macular thickness reduced from 429 to 350. And finally, after multiple injections, she was on extension for 6 weeks into 2018 when her central macular thickness was 239. One can see there's few cysts here present. Predominantly, she's got a parafoveal edema here. Then there was an 8-week extension for her, and you can see multiple over the 8-week period time, 10-week and 12-week extension period. She's really doing well. So this is her central macular thickness almost regularized to normal. Her central vision, her vision improved from 0.3 to 0.5 partial, and she continued to do well at 12-week extension. So I was pretty happy. I was even planning to extend her to 16 weeks, at which point of time she was lost to follow-up for 6 months. So because she was lost to follow-up for a period of 6 months, she comes back with a drop in vision, 0.2. She's got a recurrence in the central macular edema. You can see these multiple large cysts, some hyperreflective foci here, and the macular edema is increased as well. Now what do? We continue with the same medication. She's had multiple injections of aflibercept again. Multiple injections of aflibercept. The visual acuity didn't improve as previously, but visual improved to 0.4. The macular edema is 319. She had 2 more injections after this, and then an extension period. During the extension phase, the central macular thickness went to 304. The vision was 0.4. And at this point of time, I decided to extend her. So she was extended for 8 weeks, 10 weeks, and finally at 12 weeks. So you can see how she's doing here. She still has this subfoveal fluid here. Vision is 0.5, and central macular thickness is 290. So she seems to be developing some atrophy because of this. We continued to extend her to 16 weeks in May 2021, and then in September 2021 as well. And she had her last injection in the year 2022, June. So she started treatment in 2017, and for almost 4.5 years she's been under my care. And finally her vision is 0.5 with a good central macular thickness. So she's off medications for almost a period of 1.5 years. So to sum up, this is a one-eyed patient with diabetic macular edema with good visual potential. Responded well to aflibercept treat and extend. She was lost to follow-up for a period of 6 months with recurrence, and then had a good response to reinitiation with aflibercept and extended to Q16-week extension. And finally, after 3 years of treatment, as I said, it's a marathon. You need to be consistent in your treatment. She was off medication, and with the DME completely resolved and vision well maintained. Let me come to case number 2. This is a 56-year-old gentleman presented with reduced vision in both the eyes since 5 months. He has a HbA1c of 8.2. Best corrected visual acuity is 0.5 and 0.7. Anti-segment is normal. He's got a normal IOP. So again, this story starts way back in 2017. This is how he looked like. So he had this fluid under the retina, subretinal fluid with macular thickening. These are his images of the left eye. I'll concentrate more on the right eye. He has these multiple hemorrhages as well here. The central macular thickness is 520. I did an angiogram for him, and we'll concentrate more on the right eye here. And the angiogram clearly demarcates the presence of a normal foveal avascular zone, though he's got neovascularization of disc, indicating that we have a 2 combined problem of PDR with diabetic macular edema. So I gave her 3 injections of aflibercept, and if you look at the results here, she's got excellent response to the aflibercept, near normalization of the foveal contour. Some cysts here with some hard exudation present as well. This central macular thickness has become 288. So this is in 2018 when she came to me. We continued treatment for her, and in 2017, she had 2 more injections of this medication, and her vision improved to 0.8. Central macular thickness was 293. These are images again done in Jan 2018. Aflibercept given every 2 months, because at that point of time, the label was injections, 5 injections, and then 2 monthly injections. We continued the injection year, 2 more injections. So this is almost after a year. This is almost at a year when she came for follow-up. So at this point of time, I decided to do a treat and extend for her. So 1 month after, she also had a PRP done. So as is the norm, when you do injections, if the patient has PDR, eventually they'll end up with a PRP laser as well. So post-PRP 1 month, she did have some fluid collection. We decided to inject her, continued 3 more injections following the PRP here. And this is 2019 with a 12-week extension here. Visual acuity is almost 6/6. Central macular edema is normal. And if you look at 2020, this is in Feb 2020, 16-week extension. She's maintaining good vision with a good foveal contour here. And this extension period went on for 16 weeks, and he was on extension for 16 weeks. Though he has some fluid temporal quadrant of the macula with some hard exudates, he still maintains a vision of 1. And this is at the last time when I gave him an injection, 16 weeks, he lost to follow-up after that. To sum up, this is a patient with DME with PDR, treated initially with anti-VEGF monotherapy. Sequential PRP was done later, and this patient responded to treat and extend regimen with good best-corrected visual acuity and normal central macular thickness. So as I said, durability is the key, and durability leads to success. So if you look at anti-VEGF marathon, you know who the clear winner is. Thank you very much for your kind attention.
Thank you very much, Prasan, for these interesting cases and good management. So how do you plan to continue treatment if there is a subretinal fluid and even there is an improvement in the visual acuity or stop visual acuity? There is no more, but there is some fluid in diabetic macular edema.
So unlike in AMD, I think subretinal fluid just indicates the severity of the disease. It's not that eyes with subretinal fluid will not respond to anti-VEGF. That's a myth we have. They do respond very well to anti-VEGF injections. And the aim is generally to control the macular edema. If the patient has good vision and the patient has a dry macula, especially in the central part of the retina, I don't mind extending it. Despite the fact that some of these patients will have some peripheral edema as well. The worry is when the peripheral edema is more enough and increase and involves the central portion of the eye. That's the point to worry about. As I said, it's most of the time an individualized treatment option. So if you still feel there are a lot of areas of peripheral edema, you can consider doing a mild micropulse laser or something like that.
Suppose, Prasan, if you have, no more improvement in the visual acuity and you want to go to the treat and extend, how do you do it in this way?
So the criteria is to dry the macula.
But there is no response, and there is the fluid. There is some fluid, and at the same time there is no change in the visual acuity.
So, if you look at the OCT, there are clear-cut biomarkers which will tell you what is the visual outcome potential for these patients. We really rely on these biomarkers to judge whether the vision is going to improve for these patients. For example, in my first patient, the final visual acuity was only 612 or 0.5 partial, but she was doing very well because the macular edema almost completely resolved. So if I feel that the patient has a better visual potential on the OCT and there's still fluid and the medication is not working, you can shift to a different class of medication, and that can be a different topic to discuss.
Okay, thank you very much, Dr. Prasan. Thank you for all. Is there anyone who wants to ask or any comments before we can conclude this session? Thank you for all.
Thank you.
But before we move to the next sessions, I want to have an announcement that we'll have an opening ceremony in Hall B after we finish the next sessions. So please, you can join us that we will have the opening ceremony. Thank you very much, and we'd like to invite the next sessions.
Thank you.
Very nice now. It's the last section. Have to congratulate everyone that's the bravery to stay here. But I think we're gonna have a lot of fun. We're gonna learn a lot. But first, I would like to congratulate all the MEOM board, MEOM team, and special Mohammed Amhi, the guy that's make this dream happen. Thanks so much to invite me and the others, and congratulate. I hope these things still growing and bigger, and we're gonna see each other next year again. But we have this beautiful session of video. I have to check who is the first one. You? Okay. My friend Abdullah, please come, and it's your show.
Thank you very much, dear, and I would like to thank Mohammed for the organization and for delaying us at the same time. So we will start our talk. It's about Densiron, actually. So this is the first case. So this is a referral case from one of our colleagues in Jeddah. He do something, I'm not very fan of it, like half of the eye is Densiron and the other half is gas. So he tamponate the lower by Densiron because it's heavy and the upper by gas because it's light. Sorry, thank you. So we try to remove it. As you know, one of the way to remove it is by the cannula. So you cut the cannula the length you want. The IV cannula, the same pediatric one, you put it inside the eye, then you try to remove it, which go finally smoothly without problem. But at a certain moment, we will see what's happened. So I remove part of it. I go back to take the other. I try something with the back flush. It doesn't go because it's wider. So I go back with the cannula itself. And I will show you why I was trying to avoid the cannula and using the back flush before. Exactly, this is what's happened. Because it's a very floppy, and after the end of the Densiron, when it came, you go for a different density, then it will become very, very dangerous. And this is what's happened. So as you know, PFCL, laser, silicon, PFCL, silicon directly from the other side of injection, not from the same side of the hole, till we end. Then what I did is this one. I decide to avoid this floppy things by bringing something very hard. So I use an 18 gauge cannula, and I connect it to the handpiece, and I try to suck through it. So as you see here, the idea is to have a strong one, not moving and very steady. So I'm trying to remove. You should know that the problem of a long needle, you need a very strong vacuum to pull it out through all the needle. And this is why what I do is I'm trying to cut it piece by piece till I reach the minimum length needed just to touch the Densiron itself and be able to raise it up and take it out. I think this is another case. We do it multiple cases actually on that one. So this is 21. So I try to make it to exactly, it's like in a trial, which one is the thinnest, but at the same time enough to suck it through the machine. And honestly, it's only at this moment I realized that the machine power vacuum is reach a limit. We need a stronger vacuum machine. For those cases at least, or for endosection. I think the oncology people need more stronger machine. So you suck it slowly till you raise it up, then you complete it up. Don't continue, suck it closer to the retina because you will repeat the same mistake. But this time it's very hard, immobile. So whenever I see it like this one, I bring something to suck it up, and you will see now how we take it out. But the idea is you should know that with Densiron, when it's become small, you can suck it through the back flush, if the back flush connected to the machine itself. But as I told you, you have to raise it up. Don't continue suck it closer to the retina as much as you can. The problem if you leave it for a long time, the Densiron, because you are afraid, now we take it out, and we will continue suck it very anteriorly till it's finished like this one. So the problem if you leave it for a long time, it will become very dense, very sticky, stuck to the retina. So don't leave it. Don't avoid the problem. Face it always. Thank you very much.
Thank you so much. Just open for discussion. Dr. Arnaldo, do you have any idea how to handle this in a different way. It's very tough to take this out of the eye, for sure.
Yeah, indeed, those heavy silicone oils, Densiron or AG Oxen from Bausch they're tough to retrieve from the eye. I think there are two aspects. First of all, when you're going to use this kind of thing, you have to make sure that you leave no perfluorocarbon in the eye, not a single drop, because they stick together and stick to the retina. And when I try to remove those kind of silicone, what I try to do is I try to go to the bubble and try to aspirate and levitate the bubble, dislocate from the retina and put up, and then I can suck out the globe. That's the thing that I usually try to do. But I think in the first place you have to avoid to leave any drop of perfluorocarbon.
In my opinion, I believe we should avoid Densiron from the beginning. But those are referral cases.
Sure.
And because I believe filling the eye with the silicone properly, completely, as much as you can. We cannot always fill it. There was a meniscus there. But when you do it, I think will be more than enough. Because we don't need the retina, which is detached even after a laser, if it's very inferior, I mean. Of course, people like it. It's very helpful in some cases, especially inferior detachment, most of the case.
Make a small comment. If I understood right, this is a bubble of Densiron or heavy oil which is sit in the retina, and usually it's difficult to take out. Am I right? Yeah.
Because it's sticky to the retina. It's not because of the...
It is not like the normal oil. It will not float up to you. It has to stay in the retina, so you have to get...
No, but it's sticky, because there is another way to put PFCL to push it up. It doesn't work.
One of the other ways, I used to use this intravenous cannula, which is 17 gauge. Okay, and I used to trim it, the tip of it, just and enlarge my incision a little bit, take the trocar out, enlarge the incision a little bit, go in, and you can aspirate it to 17 gauge as easy as this.
This is what we show.
Yeah.
But the idea is, if you follow the rule of half Densiron, half gas, which is, I think it's a wrong thing. Either you fill it with a Densiron so you become able to take it, or with a gas so you can take it simply, or it goes simply.
Yeah, as I said, this is one of the easiest and straightforward ways just to take it if it drops down.
What the level of aspiration?
Vacuum. Very good question. Always the maximum, and believe me, it's not enough. But it's not enough.
Just to end the case, do you think that after that you're going to still using Densiron?
Actually, I use it in my life 2 times, and I always fill the eye with it, and I remove it maximum after 2 months. I don't leave it for a long time. If you leave it for a long time, it's become like silicone emulsification, but it's become very sticky. And as he said, BFCL, it's true. BFCL changed the chemically and react with it, and it's become a different material, not as the Densiron that you know that it's mobile easily.
It's going to start to be stick like a glue.
Exactly.
Yeah. But anyway, I think the good message is try to not use too much Densiron. And if you have to use, prepare to take it out, because it's not easy. And you did a great job.
Thank you. Thank you.
Just I would like to invite all the others panelists to discussion to be here, to be more easy to discuss. Please, Dr. Sethi, Dr. Madrav, that's the pronounce? Thank you. Yeah, sure.
Could we also have used a phagofragmentome to aspirate this Densiron? I have not used it ever, but Densiron, but a phagofragmentome can also do the job? 20 gauge. 23 gauge?
But he used 18 gauge, if I'm not wrong. Yeah, because we need a big gauge to suck this. That's terrible. And now we have our friend from Kansas University in US, Dr. Ahmed Salam.
Thank you so much, George. Panelists, can I put a very quick comment on the previous case? Very quick. A very nice technique described by Ash Sharma from Birmingham is to fill with air. So the air, if you have this bubble that's sinking down, if you fill with air, the air attached to this bubble, and then you can use the buoyancy of air just to aspirate the air, and the oil Densiron comes up. Name is Ash Sharma. Look it up. It just makes it very simple, and it's a really very nice technique because the oil mounts on the air, and you just suck the air, and the oil comes up. So, right, I'll start my case, and this is a patient who has had acute myeloid leukemia and was treated with bone marrow transplant 2 months ago. She's 70 years. She came to us 2 months after this with decreased vision in the left eye and pain. Her other eye is very good, pseudophakic, and the left eye, which has the problem, is hand motion, hypotony, inflammation in the eye with vitreous haze, and the retinal detachment, choroidal detachment, maybe a whitish area there, and we could not find any definite retinal tear. That's the view at this point here with this whitish area and the inflammation, and a very shallow retinal detachment, which we could not appreciate here, but she had a retinal detachment, and then her macula is off, as you can see here. So the question is what to do at this stage. So we're not really sure. The view was very hazy, so we gave her prednisone drops, and her anti-segments settled down very nicely, but her retinal detachment is getting worse. So the question is this a rhegmatogenous or exudative retinal detachment? I think that's the elephant in the room. And then so we decided, we felt that this is a rhegmatogenous detachment. The detachment was not shifting, so we tried to shift. The detachment was not shifting. There was no definite pigments in the vitreous after things are settling down, and we couldn't see a break, but the feeling that her detachment was getting worse was moving us more towards a rhegmatogenous detachment. So this is the case here. And few things, again, the first question, rhegmatogenous versus exudative, how you're gonna put the trocars with the choroidal detachment. So in this case, don't put the trocars like this. You go like this, as if you're gonna go in the posterior body. We took an aqueous tap, and continuing here with the trocars. We didn't want to take a vitreous tap because of the choroidal detachment and the retinal detachment. And then we're doing the vitrectomy here. And this is the whitish area we're talking about. We'll see it again. And the retina is detached and the choroid is detached. Again, at this, still we could not find the tear, but the feeling is that's rhegmatogenous. Here is the money shot where you can see the Schlieren next to this whitish area. So now in our mind, there's a retinitis, which is slow. Part of it is healing, and the patient got a break. And the break is in the upper part of the retina, so we decided to drainage retinotomy, drain. And the next question is what to do with the choroidal detachment, leave alone or drain? Yeah, because it was upper detachment, so leave alone. And we used 30% SF6 gas. And we just decided to leave alone and laser around that area. This is first day, so more than 70% gas fill, which is enough, and this is 1 week with the retina attached and settled. And then the question is the diagnosis. So again, a point for discussion. So here you're dealing with an immunosuppressed host and a gradual or slow retinitis. So it's either toxoplasma retinitis, immunosuppressed host, or CMV retinitis. And the aqueous sample came back for CMV. So the patient was put on systemic valganciclovir for her CMV retinitis. So I think several take-home points, again, for discussion. Exudative versus rhegmatogenous detachment, how do you differentiate? I think you have to take the whole case and then ask your heart, and your heart will tell you the answer, whether exudative or rhegmatogenous detachment. Retinal tears usually in eyes with retinitis are next to the scar areas or to the retinitis areas. Trocars placement in hypotenuse eyes with choroidal detachment. Again, don't go as we go to the vitreous cavity. You go as if you're entering the ciliary body. And not every choroidal detachment needs drainage. Thank you.
Thank you. Great case. Arnaldo, what do you think? How you define exudative or rhegmatogenous detachment? What?
Yeah, there's a certain, well, first you need to look the fellow eye. Most of the exudative detachments, there you'll find something in the other eye. If you are in doubt, also you can do an ultrasound and look for the shifting fluid, doing this shifting fluid maneuver, or just depressing the sclera and try to see how it moves in the ultrasound. And then you can decide of this. And of course, as you show that you look for some inflammatory signs in the vitreous or in the anterior chamber, and then you build your thing. Another point is sometimes you can get a patient that he has a systemic problem, like a low albumin in the level, like I had some patients or with a high blood pressure. They can have no exudative detachments, but usually they are bilateral. So if you rule out all those things and you still think it's a rhegmatogenous detachment, then you go as you did for surgery and look for the break and try to seal that break. For the choroidals, at that point, the video, I would do just like you did, leave it alone. But you can also do in the surgery, you can increase the pressure and put plugs, or if you have a valve trocar, you just leave the pressure high for like 5 minutes or so, and then you go back inside the eye. Most of the detachment can, go away, and you can keep your surgery.
What about B-scan? Can it help showing this is exudative from rhegmatogenous? I think B-scan can help.
I think B-scan, the help of the B-scan first, if you find a tear, then it tells you a rhegmatogenous, or if you're trying to do shifting with the B-scan. So we indented her, we did shifting with the indentation, and she did not shift, but the view was really very hazy. So the B-scan really did not add much. I mean, we couldn't see the break, and we already did the shifting with the scleral indentation.
Yeah, excellent case. I think the first question, whether it is a rhegmatogenous or a exudative detachment, I think it worsened with the topical steroids, and the view became much better, and you could visualize that it was a total RD, and it was not just the dependent in the inferior half. It was not because of the gravity. It was a total RD.
Yeah, it progressed.
Was suggesting probably
I
a
think it
rhegmatogenous.
progressed quickly.
And the steroid worsened. In fact, the exudative probably would have improved. This worsened, so it is a rhegmatogenous. The second question is about the entry point in a choroidal detachment. I would probably make an infusion cannula, make sure the tip of the cannula is within, and you make sure with the light pipe, and then probably you can inject something, with a 27 gauge hydrodissection or something to fill up the vitreous cavity. Make sure the choroidals are much less, and then enter into the superior, trocars. The third point about the choroidal detachment, in this case you have not drained, it was serous detachment, it settled well. Now if it were to be a hemorrhagic choroidal detachment, I follow my own way. I would select wherever it is a huge mound, just make a partial thickness with the 25 gauge trocars, leave the trocar, the whole blood comes off. As the professor said, probably you increase the intraocular pressure, the whole blood comes off. So most of my traumatic cases, I manage it like this, and they settle very well on table. You'd see them settling down, or the choroidal detachment. The fourth question was about to find the retinal break in a scar. Was it the fourth question?
I think the first.
I think.
Yeah. I think yes.
Yeah.
It's just it's the usually next to scar.
Next to the scar. Yeah.
You want to say something?
Yes, just to add to Dr. Points, that it was the points against an exudative detachment would also be that there was not enough of retinal pathology that was seen along with the retinal detachment. And also the disc looked all right. There was no disc edema, and maybe an angiography, a wide field angiography may have given us a slight clue on maybe we must have some vasculitis, but it wasn't there. So all these signs were against an exudative pathology.
Just one trick, I think, when we have choroidal detachment and it's difficult to put the cannula or the trocars or whatever, you can use AC maintainer, especially in this case you had just AC IOL, and the access of the fluid to the back will be absolutely fine.
Very good case. I think that if you don't make sure with the shifting maneuver, you did right. Maybe it's rhegmatogen, but we don't find the hole. And if you don't have a huge choroidal detachment, I can leave like a buckle. helps you to fix the retina, and they're gonna settle down easily.
Yeah, I think maybe for completion, an indication maybe to drain that choroid if the break was inferior.
Yeah, yeah.
Because then you need a bigger gas fill, so then I would drain the choroid and use a longer acting gas.
But maybe the break is so small, and
Yeah,
you
it's a
need that.
superior break, so
Yeah.
it was a superior break.
And also the choroid acts as a buckle for your retina, honestly. And it helps, you don't have to complicate the case as long as you can manage to do it as easy as that.
Do less, that's much better.
Yeah.
Less is more.
Less is more.
Thank you so much. And now we have an honor to have my friend Ayman from Jordania to present a nice case.
Thank you very much, George, and I want to thank Dr. Amri for the nice invitation. This is a 27-year-old female patient with history of mild myopia and eczema. She underwent PPV with C3F8 for a macular off temporal detachment due to temporal horseshoe tear. She presented to us 9 weeks later with PVR tractional detachment and cataract. No break was found. This was the case. You could notice the temporal laser for the old, the primary tear and the nasty PVR over the macular area. So this is the OCT, and can we play the video, please? So there was a hesitation from the treating doctor to go in, so he referred this patient to us. We went in, and you can see that there was a significant PVR over the posterior pool, and I noticed that there was some vitreous still in the posterior pool, so we went and we did some vitrectomy. Then we inject membrane blue, and as you know, membrane blue is very good in staining the fibrous membrane, and we start peeling and removal of the PVR from the posterior pool. Strangely, although it was not that old, few weeks, but the PVR was so nasty and so adherent to the macular area. So we had to be very careful in peeling that membrane. It was really a tough membrane, and it was extending even over the optic disc itself. And you can see how tough and adherent is the membrane. So you have to be careful not to create iatrogenic tears in this sensitive area. So we did peel, and at one stage we had to stop temporal to the macula, because I was afraid to create a tear if I insisted on removal of the whole PVR from the rest of the retina. Yeah, it was really a tough membrane, and I want to show you here that there was no PVD. There was the vitreous was still attached. As you see, there was no PVD done at the first or the primary procedure, and I think this was one of the main causes of PVR after surgery. Then this is brilliant blue, and I wanted to remove the ILM just to make sure that I'm removing all that PVR and the macula is really free of any tractional membrane. So we removed the ILM from the macular area, and then the eye was filled with silicone oil. this is the OCT after surgery, and this is the retina is fully attached after surgery. Now the question was, could we have, or the primary surgeon could have treated this case in a different way rather than doing a vitrectomy, given that the patient is young and the vitreous was completely attached? The second question is, does the eczema has a role to play in the cause of this severe PVR after the primary surgery?
Yeah, I think one of the main indication for buccal, which is left up till now, myopic, single tear, it was only horseshoe tear, and young patient.
Absolutely.
Okay. So why vitrectomy in a patient like this? And as you can see, we cannot even take the vitreous easily or induce the BVD easily in this patient. And as long as you will leave some vitreous, that is the punishment that you will have. So buccal in this case, this is one of the indication. I think it's only two indications left for buccal, this one and dialysis.
This is why I brought this case, because I wanted all our new generation of retinal surgeons to learn how to do buccals. This case would have been treated with a simple buccal, and we could have avoided all of this afterwards.
And the advice or the take-home message as well, if you cannot do the buccal, it's not a big problem. Refer it to whoever can do it. And the patient is more important than our egos.
Absolutely.
That's what we have to understand. Regarding your second question regarding the eczema, eczema means the disturbance of immune system, and definitely the reaction after any surgical trauma or whatever could be exaggerated, and maybe this is why she had the PVR, especially with the remnant of vitreous is still there, and maybe, but I don't have a big evidence for that.
I think I agree. I think in the first place I would put a buccal in this patient. Very young, myopic, single tear, peripheral. I think it's a nice case for a buccal. But one thing is, she developed PVR very early.
Exactly.
So this is a bad sign prognosis when they have such a severe PVR, very adherent to the retina, and you do the maneuver very nicely to try to remove and make sure that you remove all the membranes there. Even though this patient can recur, and they do often recur PVR after all, and so you have to warn your patient about this. Although the surgery was beautiful, but we know what can happen next.
Absolutely, absolutely. Those cases are prone to have a recurrence of PVR. This is why you have to watch them closely and treat them as soon as possible.
Excellent video, Professor.
Thank you.
I think this would have been one of the indications for scleral buccal. Probably we could have gone in for a segmental without even a complete 240 band. So this would have worked very well for a 24-year-old female myopic eye, single horseshoe tear. And the second question is the reason for PVR. I think it's a non-removal of cortical vitreous. The primary surgeon has failed to induce the PVD in a myopic eye, and it clearly shows off with the entire stretch of cortical vitreous, right from the nasal retina to the temporal retina, with a thick, probably he would have had a little bit of bleeding also, which would have settled down on the macula, causing more PVR changes in the macula. So it was an excellent decision to remove all the membranes.
Yeah.
And give
Thank you
her a
for
good vision.
bringing this, because it's very important to peel the vitreous. Doing PVD in such cases, we are doing vitrectomy, is of utmost importance, especially in young patients. I know that it's difficult to peel the posterior vitreous, but with some patience and persistence, you will be successful in doing that.
Just a question for all the panel. Would this case also be a candidate for pneumatic retinopexy? Pneumatic retinopexy? Would you also suggest that this could be an alternative for this case?
I think so. We can use that, but because it's young and myopic, maybe buccals is more appropriate. But we can try. If don't fix, we can go for buccal. And when you fail with the pneumatic, it's not something that's going to cause problems for the patient. You're going to move for the next step.
I would make my first choice a buckle, because in cases of failure of pneumatic retinopexy, most of the time you might need to do vitrectomy in such cases. So my first choice would be a buckle if this patient presented to me first time.
But anyway, it's beautiful because I just remember was Retina Society 2007. I was in a guy has a talk was the buckle in the dodo bird. That was extinction for a long time. This was 2007. And nowadays we have many people that agree that buckle is alive and it's a very good tool when you know how to use, in special in young patients with inferior tears with vitreous attached. To go for young patients for vitrectomy, have to be prepared because the posterior hyaloid is very stick, and then we have to stain, use triacenolone, use membrane blue, but we have to sometimes to take this hyaloid with forceps, because not only the suction of the machine gonna take it. It's like to membranes.
It's not easy at all, Giorgio. You have to be persistent in separating the posterior hyaloid in such cases.
And in this case, the first surgery left behind the posterior hyaloid. Maybe it was one of the cause of PVR. It's very bad, because when you start with PVR very early after the surgery, these things not going to go well. Sometimes you're going to operate 2, 3, 4 times. Nowadays, I'm not sure that I'm correct, but I'm using in such a case methotrexate for 2 months every week, 300 milligrams, and I have a series of 12 cases right now, and looks like they prevent to reproliferate. I'm not sure. We are waiting for these trials that we are using methotrexate and see if it really helps or not.
So do you use it in high-risk retinal detachment cases, or do you use it in
Only
every case?
in the second or third surgery that has PVR, bad PVR, that I operate first time, that's reproliferate. I never used primarily in surgery, just the second or third surgery.
Yeah, it makes sense. Yeah. Thank you very much, George.
Thank you. Thank you so much. We need to move forward for the next case. Let me check. Just lose my list. Sorry about that. Is Dr. Ahmed Beda is here? No? Next. And next is Mangat. Dr. Mangat, please.
So basically, in this session, it is what would you do differently. So I'm just going to kind of talk about one case only and one video. If you have a 4B retinal detachment with extensive temporal TRD, you sacrifice the lens most of the time. But sacrificing lens means glaucoma increase later on, as well as risk of long-term amblyopia. And we know lensectomy in such a situation has got its own other issues. So if you have like this, you would sacrifice, that is what would happen. So could you do something? I think this is something which has been described by us, and it is published in Retina 2022. All nasal lens sparing vitrectomy. So basically, what you're going to see here is that you stick this infusion cannula nasally, you sit on the nasal side and stick in the center here. And it is in fact beneficial because this nasal bridge supports it, it doesn't even touch the lens. And nasally, you have no proliferation. And then since you are sitting on nasal side, you go on either side the same way. That means your cutter also would be in the same hand, same place, and so would be your light pipe on the other side. And as you would see in this particular case, you can achieve all the surgical objectives, which perhaps otherwise you would not have achieved if without sacrificing the lens. So I think lensectomy is something if you can avoid in such cases, because I've been involved in ROP surgery and there is an intraoperative OCT. You can see how high it is. It is going all the way up, and that's how the whole thing is contracted there. So you can do all maneuver very well. You can, I think I mentioned earlier in the ROP session, some of you may be there, that it is different from the adult surgery. You need to just here, no question of going for the hyaloid or pulling anything. Here you need to remove vitreous as much as possible, then cut all those thick membranes or thick tissue, whichever is safe. And that is what is being done. And now you can see here that it's not that bad. And there are some areas which are fairly vascular. So here, sometimes you have to diathermize and then come back again. And so you cut and don't produce a retinal break. And here, as you would see subsequently, this is almost completion of the surgery. You don't want to go beyond this. And partial fluid air exchange is done. You can see it has settled down. Intraoperative OCT, you can see it has gone back. And now I need not do anything, just a partial exchange and close the case. And that is end of the surgery. So this is the result. You can see the whole retina has gone back, lens is in place, and so that is what I wanted to show, that what you could do differently to tackle a particular case. So I would like to ask the panel, are there any other approaches, or would you like to do the similar kind of a procedure, which in fact I would say we did for the first time in such a situation?
Somebody here has experience in ROP? No? I have to ask help from my friend from Portugal. Susana, please. We don't have experience in ROPs. Give the microphone to her.
The aim of the surgery is just cutting the tractions without touching the retina. That's the aim of the surgery, because retina is plastic, is elastic, and as soon as she is released, she goes to its place. So it's very brave to save the lens, because if you take the lens, you have amblyopic eye. So you have a wonderful result from the surgery, but an eye that doesn't see because it's a phakic, and the other eye is phakic, and you cannot put a lens in that case. So I think it's a wonderful surgery, really. Release. So we used to say, you do less, you do more. So the less you do, the more you do. So
exactly.
It's a very important message to the persons who deal with retinopathy of prematurity. And you can always go there a second time.
Yes.
When the guy is old and you can already peel that membrane near the optic disc, you can go there nicely at 6, 7 years of age, take it or not. So, but I would not do differently. And this ability to think that, if I go in the temporal, I have to touch the retina and take the lens. So this ability to think freely and say, oh, I should go nasally, why not? I shift the baby, I shift the microscope, and I do nasally.
You shift yourself, sit on the nasal side, just shift the microscope. Nothing different. I also thought the same way, and it's very easy.
This is the movement of someone who loves the surgery and who thinks the rational and innovates, you know, makes different things. That's why I think Dogre is wonderful making surgeries. So it's a perfect surgery for me. Thank you.
Thank you, thank you, thank you, Susanna.
Great case. The principle is the same. I think that do less is more. We have not to touch not to make breaks, because it's going to be much worse, as I learned right now, and have more comments here.
Thank you, George. That's a question. Is there any role for buckling in stage 4A or B ROP?
I think buckling has really gone down very rarely. In fact, I'm also one of those who started with buckling for stage 4 ROP. I think with lens sparing vitrectomy becoming more popular and going in different direction this way, there is hardly a need for buckling these days. Very few cases, maybe if you have too much of a traction localized and you want to just flatten that, that also is a problem. You see, you have to ultimately remove this buckle once you put it there, and it doesn't really serve that purpose. The retina is not going to open up. That is what would happen. Here you saw the whole retina open up. So I think if you can perform with different permutation and combination lens sparing vitrectomy in 4A, 4B, that gives the best result. That is the way I would say.
Just the last comment. Long time ago, I had a patient. He was something like 14 years old. He has a operation when he was a baby, and they put a buckle, and the buckle migrate inside the eye.
Yes.
Terrible situation. Have to cut this buckle, what's in the middle of the vision. But I think complication with buckle is things like that can happen because the eye gonna grow,
yes,
and it's gonna be ischemic, and to be a mess. You have to take it out, no?
Yes, yes. Mostly it has to be taken out after a few months. It can't be kept there. Most of the time we did that. We removed the buckle in many of the situations in infants. I'm talking of infants only. Yes.
Thank you, thank you. Let's move ahead. Now, Dr. Mohammed Afdallah, please.
Thank you, George. Good evening, everybody. Just a quick case. So once in a blue moon, we can get such a case with epiretinal membrane causing tractional diabetic macular edema with this cyst with a thin roof, okay, and affecting vision. You have to peel without de-roofing of this cyst and converting the cyst into lamellar or for thickness macular hole. We'll get the opinion of the panel, but here is, we all know that the point of maximum stress is at the roof of the cyst as the membrane causes traction, tangential traction on both sides. So here is my preferred technique. I show the video. First, I like to go with a bent needle, not with the forceps, in order to create a plane so as not to put extra traction on the roof of the cyst. Then I go in a circumferential manner, in a centripetal peeling. I do not peel centrifugal. Centripetal, very, very close to the surface, going circumferential from area to area, trying to peel every time towards the roof of the cyst, very carefully and all around. If I feel some traction is there, I just stop and I go again with the needle. As we can see here, I collect the whole membrane towards the center of the maximum stress or maximum traction. Then I do sometimes debulking with the occutome with minimal or no vacuum. Here I notice some traction, again with the needle, so as not to put traction on this. And again, centripetal peeling towards the center carefully from all around till, as we can see here, we reach 360-degree peeling, and here the membrane has detached by itself. And this is the post-operative, the pre-operative on the left side, the post-operative on the left side. There is collapse of the cyst. The roof is preserved. We avoided creation of lamellar hole, macular hole with improvement of vision. So my question to the panel, what would you do differently for such cases that you encounter with a very thin roof and the cyst in order to avoid creation of iatrogenic lamellar hole or full thickness macular hole? Thank you.
Thank you. Arnaldo, want to start?
Well, first of all, these are very difficult cases because you know you can create a hole and turn your disease retinal membrane with a cyst into a macular hole surgery. I wouldn't do anything different actually, because that's the technique that the foveal sparing peeling. So you just go avoid to make traction around that area. And in such a case, I think that's a good case that if you have intraoperative OCT, that might help you, guiding you how close you can get to that part. But if you don't have it, of course, you have to rely on your experience and your feeling. Where are you peeling, and looking around why you peel. So you look for tractions in other parts of the retina and go there. And that's just amputate the stout that is remaining when you release 360 as you did.
There has been some reports of what we call the macula sparing technique. In order you go taking the RAM all around for 360 and leaving the roof untouched. You don't try to peel, you don't try to pull, you don't try anything, you just leave it. It has been described in literature.
For me, I'll do the same actually. I'll not do anything different. Just amputation for the center and take it from all around.
I think wonderfully shown, and the same principle that we follow in a vitreofoveal traction, we are following in this case, that we are being careful while inducing a PVD, as well as staining very well with triamcinolone and a blue dye and in high magnification. And the space that we have, we know that the space is there, the cleavage plane there only, you use the bent needle.
So basically you just, not other epiretinal membrane, you just go and peel in a centrifugal manner. And Dr. Rao?
Fantastic video, Professor Abdallah. I think we would do the same, fovea sparing, ERM or a EM epimacular peeling. Then you probably trim it with a 25 gauge, vitrector. In case, if you happen to lift up the fovea and causes a foveal, you have caused a small macular hole. In that case, you would re-inject blue dye and see whether there is an ILM. You may do a macular hole surgery. You just peel the macular hole and put a tamponade. In 3 days' time, it is closed. So even if it happens, you can close the hole.
Yes, sure.
Maybe I can say something, George.
Yeah, for sure.
So we pay attention to not detach not tear the detached roof in the vitreomacular traction syndrome. Pay attention to keep the detached retina intact after peeling of posterior hyaloid. What am I doing in this patient? I create a small hole on the detached posterior hyaloid around the attachment area, then go under the posterior hyaloid with membrane peak and gently separate the attachment of the hyaloid from the retina and keep intact the detached roof of the vitreomacular syndrome. So I try the same technique with this kind of patient and go into the vitreous with MVR blade or with PPD needles and to make a small hole is close to the OCT guiding area with the OCT guiding to close to the detachment area, and then you can go behind the membrane with membrane peak. You can separate also. It works in
some patients.
Yeah.
Differently, not from the periphery to the center. My technique is from center to the periphery. You can detach also.
Okay, fantastic technique. Actually, OCT, interoperative OCT will be of great help. But in this particular case, there was total PVD. So just the membrane causing the tangential traction, and we have to remove this membrane.
One quick thing, usually if we face this in the VMT sometimes, and we face
This is a diabetic
exactly.
case.
What I'm saying is, do you usually go for ILM peel as well? What I'm saying, if any operator, that's for the panel as well. Usually when we do AR, do you do double peel nowadays?
I don't.
Because the recurrence of the operator membrane is scaffold for any recurrence. That's one thing. The other thing is, if you, I know most of the time when we have the operator membrane and remove it, it takes part of the ILM with it, but still some areas of ILM. Just in case, if it's an inevitable hole happened, like Dr. Madif said, it's not the end of the world, just complete the ILM and just treat it as any macro with some gas and it should be fine. Because sometimes even with all the tricks you are trying and whatever you are trying to do, even by trimming this to the stump at the end, you sometimes just with a little bit of aspiration it can come out, the whole thing. So
that's true. Two things, because we need to move forward. It's very difficult to complete this case without make a hole. And if you make a hole, just treat as a hole. Make the peeling of the internal limitant membrane. One variation of your technique, colleague from Brazil, Márcio Nahemi, doing, is make a hole and inject PFO underneath the membrane, just to spread the vectorial force and try to put it out without too much pressure in one place. And they have a series of cases of that. They publish this. But your idea is good too. We have to have many good ideas to try to fix this. But for the next case, Dr. Saad Wahab is here. Please. We need to be a little bit more quick just because we have to finish the session 8:15 for the open ceremony. And then we're gonna be, not everybody has time now to comment. Let's do two comments for each case. Go ahead, please.
Good evening, everybody. Thank you for giving us this chance to share with you some of our thoughts, because I do believe that sometimes when you finish a case and something does not go the way you want, you do ask yourself, what could I have done differently? How do I advance? Okay. So this is a 45-year-old lady that I have seen. She's very healthy. She's high myope. She's had bilateral refractive lens extraction almost 10 years ago before my presentation. According to her, one eye went very well, and the other eye had some complications. They had to come back for some retained cortex. And she also gives a history almost 2 years prior to presentation to us of a vitreous hemorrhage that was treated with a vitrectomy elsewhere. On examination, she was counting finger in that eye, 20, 25 in the other eye, and she, to make it quick, showed a dislocated IOL capsule into the vitreous. The whole thing was dislocated. Now, she does give a history of mild trauma to that eye. On examination, I can see the dislocated IOL, the very extensive 360 laser mark, and the other eye is normal. So at this stage, we decided we're going to go in, remove the dislocated IOL with the capsule and do a Yamani technique. It went very smooth, as you can see. Again, I was really surprised with the extensive laser that was done 360 degrees. And I did ask her, why was this done? And she said, according to the previous surgeon, he felt safer. And apparently, this is the practice with some vitreoretinal surgeons. When they're doing a vitrectomy, they do a prophylactic 360 laser. Anyway, everything went smooth, so we went in. I really don't feel, and I want to hear the panel feeling of this, I don't feel PFC makes a difference, but it maybe makes me feel comfortable. because I lost the lens a couple of times. And then ultimately we managed to remove the IOL, and we continued into the Yamani technique, which was again straightforward. For the sake of time, I'm just going to move, because the rest is just a standard technique for a Yamani technique, for Yamani surgery. Within the first week post-op, she's done extremely well. Everything looked fine, her IOL in place, her vision did improve to 20/40, she looked quiet, normal IOP. On the 5th week post-op, she represented to me with sudden loss of vision in that eye, and when I looked at her, she showed a macula of retinal detachment, and as you would expect, she has detached it from a tear that developed at the edge of these extensive previous laser mark. Of course, we took her back, we did a vitrectomy and silicone oil, but my question is, would I have done something different? Should I have left her with oil from the beginning, or should I have left gas, or should I have done more laser? And I'd like to leave you with this. Thank you.
Thank you so much. Very nice case. It's spontaneous dislocation of the intraocular lens in high myopia, and that you handled beautifully. Wanna start this? You wanna start?
Wonderful video, Professor. Well, I would have done the same. Probably we wouldn't have, revitrectomy, taken out the IOL and done a Yamane or any suture technique of secondary implant. Was there any contact of IOL while retrieving it from the vitreous cavity? Was there a spot of hemorrhage or something which could have said that there was probably a retinal touch?
I'm really not sure, because we do usually routinely inspect these patients, intraoperatively. I look at the periphery carefully, and I just left her with air, I remember, and there was nothing really that looks suspicious at this stage. But I mean, would you have left silicone oil? Would you have re-injected?
No, I wouldn't.
Yeah.
I wouldn't have done.
Yeah, or gas?
Not really, unless there is a suspicion of a retinal break. So was it a very dense break which probably would have caused a leak at the edge of the breaks? The previous laser marks? It was quite posterior, as you rightly said.
As you could see, and I would like to hear your thoughts on this. I never do prophylactic 360 laser. Sorry, even in a myopic patient. I mean, we inspect these patients carefully, and even if I do, it would be much smaller. Sorry, I had a long day. I arrived this morning and I'm recovering from a flu, so excuse my cough. Okay. So, do you guys do prophylactic laser?
No.
Yeah.
For sure not. What else you want to comment? You want to comment?
Only just, I think, I don't do prophylactic laser anymore, and most of the people, I think, in the recent year, they don't.
Apparently the Europeans do. Somebody told me.
Some people, there is a lot of publications say it can even, the prophylactic laser and annulus or whatever can trigger the whole process, and it can trigger create tears or whatever. So it's not routinely done nowadays. Only if there is a tear, there is laser. No tear, no laser.
You've done a great job, Saad. Definitely, the patient was unfortunate to have detachment. But what I would do differently, and I'm doing it now, I will not use the Yamani technique in such cases because the lens is not stable. We have a lot of problems and complications with the Yamani. I would do a 4-point fixation using Gore-Tex suture, 4-point fixation. It is the best in such cases, and definitely I never had any problems after doing
Interestingly, for the second IOL implant, there was a nice publication where they compared the AC IOL compared to all the clear fixed IOL or whatever. The AC IOL can do very nicely in a lot of cases, actually. There was no big difference. So we forget completely about the AC IOL nowadays and just talking about Yamani, scale fixation IOL and all this. Of course, it's the best position of the C chamber. But still, it's not the easiest. It's still not the easiest technique. It still have a higher rate of complication.
I have no problem with ACIOL. I just don't like to use them in young individuals. But I agree, ACIOL was a great case.
No, I'm talking general, not in this case,
okay.
definitely.
Anyway, it's a very nice job you did in a high myopic patients with dislocated lens. I think nowadays the concept of doing 360 laser for prevention is not something that people are doing more, because you do laser, but you're gonna have breaks outside the like you has shown to us, and then prevent this with oil or gas. It's not something usual to do, because it's a very low rate to have these breaks after you just doing vitrectomy to take it out the intraocular lens. And the technique, I agree, that's Yamane is something that everybody are doing nowadays, but it's not so stable like to fix this, and maybe you're gonna help a little, but I think there's a by chance happens and you have to fix. It's a complication that we are exposed to. But thank you so much.
Thanks.
Great case.
Thank you.
You need a question?
Excuse me, I have two questions about this case. We see subluxation of IOL in bag complex without retinal detachment. First the question, why you do posterior vitrectomy? This first question. Second question, I dealing with like this case, we do scleral fixation for complex IOL in bag without removal IOL in bag and then scleral fixation for another IOL. We can do scleral fixation for complex IOL in bag without replacement of IOL.
Yeah, you can answer.
If I understood your question. Now, she does report a history of trauma, so that's probably why she got it. Now, we know myopics are very unstable, and they do lose. And in this case, the whole thing fell off. I mean, not only the lens, so there's actually nothing to attach a new IOL. So you really, and the lens was a single piece, so it has to come out. Okay, you can't refix it again unless you consider iris suture. So you bring it up and you suture to the iris. Yes, you can do that. And I think my question here is not the technique, because as somebody was saying previously, there are more than one way of doing the same thing, and there's nothing right or wrong. But I think my question is that, because I went back, I looked at the surgery, should I have had put silicone oil for her? Because she had silicone oil, apparently, in the previous surgery. So that's my question. In these cases, you have no option. This lens complex capsule should come out. You can't just bring it up and leave it there. Okay. Does that answer your question? Anybody wants to add anything from the panel? Okay.
Okay. Sorry.
Thank you very much, Professor Saad. It's a really interesting case. Regarding to your question, putting oil in the first place or not, it doesn't make a difference. If there was a break, it will redetach, whether oil or gas or air. So my feeling, you did the right thing. It just happened. We know after vitrectomy, redetach can happen maybe 5%, 10% of cases, and this is
okay.
I always go back and ask myself, what did I miss? What should I have done? I think we're taking too long, right? We should move.
Yeah. We should move forward. Please, Dr. Kagan Hussain is here. We need to be more fast, because have very short time for many people to speak.
Quickly. So my video is exactly 2 minutes 38 seconds. So be ready. So this is the case. Believe it or not, it's from Ridley's museum. So this is also unbelievable. This was, we were in Alexandria. So this is 22 years old male presented with the silicon band intrusion, and he had got the perception of light vision and his phakic eye. So anyone has encountered such a case? Can I see the hand raise? No? So we did the plan that we will do the peritomy, explore the external part of silicon band and cut it there, and the surgery will end, that's all. And then we will do the vitrectomy for joint retinal tear. Very simple plan. So anybody has seen such cases? Never. Operated anyone? No. So I did the same, sling the muscle. I thought I will find the silicon band over the sclera, cut it and remove it. But you know, I couldn't find the silicon band over the sclera. So what to do? It's a tough situation. Yes, Mario? Yeah, believe me. Joint retinal tear is waiting there. You see the silicon bind behind the phakic eye, 22-year-old male, joint retinal tear, 180 degree. What to do? Think. Everyone is thinking. And who is sitting on the chair? Cut it, pull it. No, you can't pull. You see how the choroid is churned around the band. So I tried to cut it with the 23 gauge horizontal cutting scissor, but it's like a cord. So it took me almost 5 minutes to cut a silicon band in a vitreous with retinal detachment and joint retinal tear and phakic eye to cut it inside. You see? And cut it. Everything is relieved. Then it's a routine job. Just do the vitrectomy, peel the PVR membrane, stain with the vitreous, and deal with the joint retinal tear. So this was from the Museum of Ridley's Believe It or Not. I think you didn't see, and this is Believe It, it's done. So PVR was dealt like it. Believe me, 2 minutes 38 seconds, not a 1 second more. Exact. You count the time. 3 minutes I have, 2 minutes 38 seconds I only. This time out is for, there is a timed out always for me. So I did the laser, PFCL oil exchange was done, I did the laser, retina is flat, and here is the post-op. My patient has 620A4 visual acuity, and that's all.
Thank you, so beautiful case. Somebody different want to make anything different? Me too.
Oh, okay. The best question is from my very dear Shingul. Where the band gone? Disappeared. Who? Show. Everything's gone. The band was somewhere under the sclera. I don't know where it is. I couldn't find. I have to cut the sclera, do the autopsy and see where it is. No, I didn't like it. So I left it where it is. Maybe somewhere suprachoroidal space, somewhere in subs, but it was not present at all over the sclera. So I left it, doing good.
It
Anything
is
else?
suprachoroidal space for sure.
I'm not interested till the day. The patient is doing good from last 1 year. So,
okay.
Anything.
Nobody gonna change your
Anybody
your
has different plan?
No.
Mario? No, it's okay?
It's okay.
Everyone is happy? So 3 minutes, I'm done.
Thank you so much. Now, Abdul. Dr. Abdul, please.
Bismillah ar-Rahman ar-Rahim. It was a case of subretinal foreign body. How I can move this one forward? Okay. This is the green. Okay. Yeah, it was a case of subretinal foreign body in 1-year-old girl. After trauma, she referred to me from the neighbor country. And the foreign body was very adherent. Bimanual dissection was done. And I decided to take the foreign body through the cornea. The patient was aphakic. Actually, this is 3-hand maneuver. My assistant was everting the cornea for me. Of course, after injecting the viscoelastic, I got this foreign body. It was in the era of 20 gauge surgery. It was in 2005. Also, silicone oil was injected and the laser was done. So my question now, do anybody extract this foreign body through the sclera? Also, what about using the sclera buckle in this case? And the old of the patient was 1 year. And if anybody will cut the sclera buckle after that or remove it, and if you will use the silicone oil as a tamponade in this case.
Who want to answer this question? Yep.
I think it's too big to remove through the sclera. You make a huge sclerotomy, and then you have the complications of that. So the way to do it's easier. It's complicated when the patient is phakic. So then you have to do and go phaco and then remove through the cornea. I think it's the best way to avoid the foreign body to going back the eye, trying to pull out the eye. So that's the trickiest part. So regarding putting a silicone oil or something, I just judge by, if I remove all the posterior hyaloid and there is no PVR or something like this, I just leave it with at least a gas.
Yes, you will leave gas, yes.
Okay, I have to say thanks because we need to move forward.
Okay,
thank you.
Yes.
Dr. Abdallah. Go ahead. We have no time.
Oh, really? Okay.
The boss is here to make this happen.
I'll be very quick, actually. It's actually a relatively common case. We see that every now and then in clinical practice. Patient bilateral congenital cataract surgery, aphakia, vitreoretinopathy. She had right eyes gone, all detachment, left eye previous to detachment surgery. As you can see, oil in place, and single eye with hand movement vision. And looking carefully at this single eye, we can see multiple pathology here, BVR under oil, actually involving the macula itself, open break, atrophic retina, subretinal band, and very bad OCT profile. And the question is what to do next. I'll just go quickly. I decided to remove the oil first, and after that, maybe because the pupil is eccentric, I thought to dilate it a little bit. After removing the oil, putting membrane blue, and then removing putting BFCL after that, and then peeling the BVR. It can be a little bit tricky in these cases, especially if a patient had multiple surgery and the retina is atrophic. You need to be a little bit gentle and just try to a slight sweeping movement there. You get the plane of dissection. I just removed the IOL, didn't like to do any further maneuver on the macula. And then removal these subretinal bands and a little bit of exploration. The retina is really atrophic and thin in the inferiorly. And then I thought maybe the next step is to do a retinectomy. Yeah. So I prefer to do very wide retinectomy in these cases, and once you try to trim the retina, there is no much bleed because it's really atrophic and scarred retina. There may be an option, some people would do a segmental buccal or heavy liquid, but I thought directly to do retinectomy and then remove, doing a couple of rows of laser. I tend to do 2 or 3. Our preferred method here is what we like in these cases. What we like to do it a fully automated direct BFCL oil exchange. It works really well, and we do it fully automated from the machine. Most of the machines have this function, and it works really well. And the technique is quite simple. We try to prime the oil in the infusion, and after that, we inject the oil, remove the BSS interface quickly, and then you don't need to do anything else. Just then aspirate, go directly and aspirate the BFCL. It's a very stable, well-controlled way of doing it, especially in aphakic eyes. And the patient did really well. Immediately after surgery, 3 months, oil removed. The reasonable restoration in the macular profile, but as you may know, this patient has vitreoretinopathy. Originally, vision improved from hand motion to 636. And the question is that, would you do any different in these cases?
Dr. Ibrahim can help.
Maybe the only difference, I agree with retinectomy, okay, because usually I don't think the buckles will do much here, as long as the restrictions and membranes. But however, the only thing which is different in this case, I'll not go for direct silicone oil. Usually, they behave absolutely fine. Slippage is not like the dialysis where it's more common. If you do retinectomy, you have a good exposure, you can take all your fluid out. I didn't have any big problems with slippage here. It's not like dialysis, so no need to do direct silicone oil. Fluorocarbon exchange, that's the only thing.
No, that's a very good point. Actually, it's quicker and faster doing it that way. It normally takes about 5 minutes or less, but when you do it fully automated from the machine, so you control both the aspiration and the injection from the foot switch. Yeah, but that's really good. And we do that actually in many cases.
Fantastic case, doctor. It was an inferior retinal detachment with one break at 7 o'clock and a atrophic retina and subretinal bands. Probably I would have considered inferior buccal with a band. We wouldn't have gone for a retinectomy. It is nicely settled now. But I think it's a single-eyed patient. I would have given one more chance of retaining the retina. So if it had gone in for a PVR with a detachment, redetachment, we don't have a space to put in a laser later.
Thank you.
Thank you.
Now, Dr. Arnaldo, have 2 minutes. Now, we're going to short the time.
Well, I feel sorry about the last one, then we'll probably will have 1 minute. Well, thanks, Mohammed, for the invitation, for the kind invitation of everyone. First of all, I would like to invite everyone to the next year to come to Brazil to our meeting for our society. This is a case of a 9-year-old white female with decreased visual acuity for 30 days. She has no past medical history, no past ocular history, and no family history. Visual acuity was counting fingers on the affected eye, 20 and the other eye. Anterior segment was unremarkable, and IOP was just in the left eye, a little bit lower than the one. So can you, if I click here, move forward or? Yeah, okay. So this patient has a giant tear, but pay attention to the nasal side with those folds, where I call this visual as the stubborn folds. So we did, the standard vitrectomy for this patient for a giant tear. This is a non-traumatic giant tear. And to release that fold, in the sake of the time, just moving forward, I increase the size of the tear by doing retinectomy and trying to get rid of the folds. But still, there were 2 folds there. One of them I could release and make it okay, but the other one is still smaller than it was previously. So since it was nasal, I didn't want to do anything further for this patient, so I just did the air fluid exchange, and then I put silicone oil at the end. So now time for your comments.
Just
see, 1 minute and 45.
Okay, we just we just finish the case doing retinectomy to open the folds and put oil. No.
Yep, that's what I did.
Somebody did something different for me. I'll do the same. I agree with you. Nobody disagree with you. finish the case. Thank you.
Thank you. Thank you.
Now, Dr. Ahmed Keshab is here. Please.
Okay, so I cannot beat that. So this is a 61 years old male patient, hypertensive, visual acuity 2150 in the right eye, counting fingers in the left eye. He gave a history, vague history of ocular trauma, mild ocular trauma, nuclear cataract in both eyes, +2. And this is the OCT, despite that it is actually much darker than that, and you can see where, when we start the video. You can see the extensive fibrosis. He's not a diabetic patient. This is the video. Let's run it, hopefully. Yeah, okay. So combined phaco-vitrectomy. You can see this extensive membrane. I did a core vitrectomy before, and you can see this membrane. I was trimming it 360 degree around the disc. It was highly elevated, and because there was a vitreous hemorrhage, retropupillary, and then trimming this. Hopefully it will be, yeah. So you can see this peripheral band-like membrane, and then there was still very taut membrane on the surface of the macula that I was not able to catch it with the forceps, so I used the bent needle just to trim it, and then with the forceps to just peel it and remove it. I did not want to pull too much, not to cause any bleeding, because up to now I did not know why this membrane happened. This is traumatic or what? And there was extensive corrugation. I did not have, and I do not have, an intraoperative OCT, but with this extensive membrane that was there, I thought the peeling of the ILM, and this is one of my questions, is essential in such case, just to prevent the recurrence and to allow the fovea to settle in a better position post-op. I did not want to cross too much, and I wanted to peel all around first, just to make sure that I'm not exerting extensive traction on the fovea. I think trying to extend the ILM peel as much as I can to release this extensive traction that was there on the fovea, then maybe a removal of the ILM from the top of the macula and the fovea would be next. Yeah, now pulling it without extensive traction. There was still an island of this ILM that was still persistent after this peel. You can see here. And then there was a remaining piece of island of ILM that we need to remove, because I've seen cases when we miss any piece of the ILM. Usually we tend not to, and whenever it is left, there was edema after that. And you can see this area of infratemporal area of elevation of the retina, and the membrane was all around. The retina was not detached. I examined the whole periphery just to make sure that there is no tear or anything. And there was a superior supranasal area of traction as well. I did laser around this part. I did not do extensive trimming of this membrane, and that's my question. And this is the post-op image of the fovea, and this is after almost 4 months after the surgery. So my question is, should we do ILM peel in such case? Second question is, should I go and extensively trim the vitreous base and remove all the vitreous base, or prevent any further or any small iatrogenic hole in these cases, and not to do extension of that? Thank you very much.
Thank you so much. Beautiful case. In the sake of the time, we will not discuss. We have moved to the next one. Sorry about that. I'm sorry. Dr. Mahmoud Hazazi.
Thank you, George, for the
Thank you.
moderating this session. By the way, I just got approval that we have 10 minutes. Yeah. So no one should rush me.
If I have 10 minutes, it's a lot of time.
Yeah. So, so this is a case actually. A person wanted to do good. He saw a car catch on fire on the way, so he stopped to help. One of the tire exploded with high jet of air, fire, and particles. So he was kept in a different hospital for 2 months in the ICU because he has grade 3 burns in his face, hands, and all over the body. And he presented to me after 2 months after the trauma. So this is him. He is medically free, 52-year-old male. The presenting vision is light perception in both eyes. I operated first I guess it was the right eye, no, the left eye. First because it showed flat retina on B-scan, and most of the work was in the anterior chamber to preserve the capsule, but unfortunately, once I explored the fundus, I found that the patient has a chronic submacular hemorrhage with severely atrophic photoreceptors ended by counting finger in that eye. So now we are trying to save the other eye. So the other eye, now the video should start in a minute. We don't have such a minute. I have already pressed, but part of the video is a slide. I think it just started. Yeah, it's moving already. So I took the patient to OR. You can see the anterior chamber is, is messy, cataract. I wanted to just insert a trocar with AC maintainer, removing the cataract to have a view to the posterior bore. You can see the retina is contracted, 360 separated, with adhesions to the periphery. It's almost closed anteriorly and slightly open posteriorly. I did my best to remove all the membrane to, hoping that I can open the retina. The question which I need the panel opinion is, temporally there is a contracted retina. I don't know what is the nature of this one. Is it embedded inside the sclera with self-sealed? It is very bulky and it's really risky. If I pull it, it may bleed. If I leave it in place, what's gonna happen? So I elected to deal only with the retina, separate the retina 360, flatten it, remove all the membrane above or below the retina, and close with the such way just to minimize the risk of any possibility that this patient may bleed or have any complication. Actually, he did very well after a follow-up. This is his OCC, and you can see the next slide will show the Optus photo showing a flat retina. But you can see temporarily there is still a lesion, which is the contracted retina. So is there any opinion that to remove those part of the contracted retina? I don't know what is underneath. Is it a big laceration? Is it attached to the choroid? So that is my concern.
You mean to take it out the choroid?
No, there were like contracted retina in the periphery. I just separated from the retina, which eventually went flat, and I left that contracted tissue of the retina in its place, which is periphery.
You need to remove this. This contracted retina gonna pull out the ciliary body. You're gonna have, we have already problem with hypotony with this case because
no, but it's separated from the periphery. It is only like a small island contracted in the mid-periphery between the flat retina which
just island.
Island, yes. It is away from the periphery.
I leave that.
It is
Leave
very
alone,
bulky. I
leave
cannot
alone.
remove it. I need,
Leave
you know,
alone.
yeah. It's like foreign body.
It's
I don't know.
It's a retinal incarceration, isn't it? In the
Maybe.
site.
Most likely, yes.
So obviously you can't pull out. You have to just, what you did was perfectly correct.
You did perfect.
Sure.
Thank
This
you.
is not for sake of time.
Yeah.
Okay. Thank you very much.
Thank you. And I have to, the last one, not the least, Ami Marash from Syria, a great friend.
I won't take much time. I want to talk about posterior cortical hyaloid schisis that we usually face in diabetic patients. So, sorry for the bad quality of videos, as I do all my videos from the smartphone. What I do essentially is, after I remove the posterior cortical hyaloid, I restain again, and I put a diamond dusted scraper in order to create a flap in the posterior cortical hyaloid. Then with the ILM flap, I create a cleavage, and from this cleavage, I take the cutter by vacuum and separate the posterior cortical hyaloid in all 4 quadrants. This is another video showing the maneuvers. Then with the cutter, I remove the posterior cortical hyaloid completely in all quadrants. So my question is, would you encounter this in a different technique? Or would you leave the posterior cortical hyaloid, which I always try to remove it completely, all piece of it, so I don't want to end up with complications such as PVR. Thank you very much.
Thank you so much. I think we just finished the section, and we move for the opening section. The president, please. Thank you so much.
صفاء يلا بصي انت هم هيشغلوا القران الاول وبعد كده انت استلمي المايك هات بصي هتشتغل 2 minutes just 2 minutes بعد كده
لابسه البدله الخضراء Can we sit down, please? The longer you take in talking, the longer the opening ceremony will be. And I know everybody wants to leave. Everybody's tired, right? Right, Thanasius? Okay, thank you. Dr. Nazim, please come up here. Dr. Al-Amri, as a guest. دكتور احمد سلام ممكن نقعد، دكتور محمد عوض الله ممكن نقعد. هعمل زي الفصل بقى، اندى على كل واحد باسمه، مش هينفع. احنا بنتكلم العربي عشان الاجانب ما ياخدوش بالهم احنا بنقول ايه.
فتعالى الله الملك الحق ولا تعجل بالقرآن من قبل أن يقضى إليك وحيه وقل رب زدني علما.
Good evening, ladies and gentlemen, dear friends, dear colleagues, and estimated guests. On behalf of MEOM and Pressmena boards and committees, I want to welcome you all, and I want to thank each one of you for being here with such enthusiasm. I want to thank especially all members of boards and committees because we owe them all the success of this special meeting. I want to also thank especially Dr. Mohammed Al-Amri, Dr. Ashraf Armiya, and the presidents of the 5th MEOM session, our dear and well-known and very appreciated Professor Magdi Musa from Tanta, Egypt. And I want to invite him to the podium to give the opening ceremony talk. Please welcome him.
Thank you, Dr. Safa. I will be very short, but let me welcome you all again in the fifth MEOM meeting. I have certain notes. I will speak quickly, but let me tell you that I'm very happy and glad to see all my friends, all societies, new friends, old people, old friends, and this is what we aim at, gathering ophthalmologists from all over the world, seeing each other. The social part is good, the scientific part is good. This is our aim. So let me give you a short history of MEOM. It started 5 years ago by Dr. Mohammed Al-Amri, who established the MEOM, and it was a very good idea, establishing people from Middle East and North Africa, and then other countries already sharing with us. But the MEOM established in 2018, and our aim is, or mission for the MEOM was to gather all ophthalmologists together from all over the world, but we started with the Middle East, and our mission was, as I said, to establish and foster an advancing academic environment that encourage excellence in teaching and in research in the field of ophthalmology. But this is our mission. It started 5 years ago by 5 consecutive meetings, and the last year meeting was the biggest one before this year. It has almost 2,000 attendees, 120 speakers. It was in the Meridian here in United Arab Emirates, and it encouraged more and more people to come this year. And this is the 5th MEOM meeting, which is in combination with the PRIS MENA, which Dr. Ashraf Armiya will give us a hint about the collaboration between the MEOM and PRIS MENA. And this is our 5th, and as you've seen, we have over 165 speakers this year, more than 2,000 attendees. Not all of them attend in the same day, but many attendees this year are for the first time, and we are glad to have them, and we are glad that we are increasing more and more and attracting more and more participants. I won't be long more than that, but in summary, the MEOM Academy is a dynamic organization, and it's committed to advancing ophthalmology. Our aim is education, training, and research at global scale, and all our annual meetings and online meetings, which Dr. Al-Amri has a very good job in that. He has a meeting every 1 or 2 months from all over the world. If you cannot reach the education from here, from attending the meetings, you can reach it online, especially the countries which cannot come to our area, like in Yemen. They have always online access to our meetings and reaching them with the scientific programs and all the scientific material. So we are dedicated to reaching and underserved regions and make it a valuable resource in the field of ophthalmology. I won't take more time, but let me introduce Dr. Ashraf Armiya, who will speak to us about PRIS MENA. Thank you all for attending, and we hope to see you next year and the year after. Thank you.
Thank you, Dr. Mohammed, Dr. Magdi Musa, the president of the MEOM 2023. The idea of PRIS MENA came to us that we found that presbyopia worldwide are increasing, and we should do something for our region, for the Middle East and North Africa. And when we transferred the idea to the international level, we found that all the international level happy with the idea that we are to do this in our region. So they supported us as an advisory board from all over the world. So the aim of PRIS MENA is to have the updates in the rapidly advancing field of diagnosis and therapeutic techniques, especially in the era of refractive cataract surgery, with the growing desire of our active senior patients to become independent of spectacles. PRIS MENA, talking about presbyopia in all levels, from the cornea till the lens, recognize the need to keep up with the updates development in our region, which is very important, in collaboration with most of the eminent people all over the world doing in the field of presbyopia. We have our annual congress nowadays, and it will take place with the MEOM Academy meeting, the annual one. And also we are opening a membership for everyone has this activity doing presbyopia, and we are going to give a lot of information for everyone needs to start treating presbyopia. So I'm happy that everyone enjoyed our first day, and I hope that the next year, the next meeting, it will be different, and we are planning to be in a more high scientific level than it was this year. Thank you so much.
I will be happy to introduce Dr. Nazimul, the General Secretary of MEOM meetings, and I want him to announce winners of the awards of the session, the two sessions, the free paper session and the surgical video session done this morning. Please, Doctor.
Yeah, thank you. First, I want to thank the judges and the participants for taking intensive interest in the free paper and the video presentation, as well as the Young Ophthalmology Award. I wish to announce the free paper award was awarded to Dr. Laila El Matawi. Is she here? Oh, yeah. Sorry. Yeah, she's from Morocco. Please come. Please come. Hello.
Please come in. Mabruk. Congratulations.
The best video award was awarded to Dr. Isam Faraz from Iraq.
It was a wonderful video. Yes. I want to say something about this video because he presented a very, very elegant idea of before you do a pupilloplasty, he's trying to centralize the pupil with an endodiathermy before taking the suture of the pupilloplasty. He presented 3 cases, amazing cases, and so different technique.
The Young Ophthalmologist Award went to Dr. Rukaya Imad Radwan.
كرمت يومين ورا بعض ده ومفيش بعد كده صح؟ ألف مبروك. Let's go in the front. Let's go in the front.
So I'm just going to highlight about tomorrow, and I'm going to give hint about surprise for our next meeting. Tomorrow we are going to have, for the first time in our region, live surgery anterior and posterior segment is going to be broadcasted in 2 halls, Hall A and Hall B, for 1 hour and a half from 9 countries and from 9 centers from all over the world at the same time. So I think we are going to enjoy tomorrow a lot. And then we are going to play a video. This is the surprise for the next For the first time in our region, we are going to have a 1 day for ocular trauma like Prismena. For the anterior and posterior trauma, it will going to be from 8 a.m. in the morning till 8 p.m. at night. It will be all about trauma, anterior and posterior segment in 1 day in conjunction with the anterior and posterior segment, just 1 day. So we are going to have in the first day the Prismena full day, and the ocular trauma will be on the same day in the other room. So I think we are going to enjoy a lot next year. Thank you so much.
Thank you all, and let me thank Dr. Mohammed Al-Amri again for all his collaboration, for his effort, and for suggesting that I will be the president of this meeting, and we are looking forward to more and more successful meeting. Thank you so much for attending the opening ceremony. Thank you.
Gita, we'll take a picture. Group picture.